but our impact is deeply personal. An early diagnosis can change the entire course of patient's life. Today's CME gives us a chance to reflect on that responsibility, sharpens our skill, and reminds ourselves why careful, compassionate imaging truly matters. I hope today's session is not only academically enriching, but also a reaffirmation of our shared commitment to patient-centered care. I am Dr. Prabha Ranjana, consultant radiologist, which means I usually talk to screen. Today, I get to talk to people. We women are incredible at one thing, postponing ourselves. Today, I want to talk about the one later, which can cost a life. This is the most common breast story I see. She had no lump, no pain, no warning. Not dramatic, not obvious, but very real. If I asked you to book a breast screening, would you? Don't raise your hand. Don't answer me. Just find answer inside your head. Most breast cancers are invisible, painless, and found only on screening. This is why waiting for symptom is not being careful, it's being late. Screening is not about fear, it's about timing. What caught your eye first? Subtle architecture distortion on mammography, it's easy to miss, easy to dismiss. Sounds tells rest of a story. An ill-defined hypoechoic lesion with posterior shadowing. Mammography hints at distortion, and ultrasound confirms suspicion. One finding, two modalities, and one crucial diagnosis. If symptoms were truly early, why do we screen at all? Exactly. Pain is late, a palpable lump is late, skin changes are late. By the time cancer announces itself, it has already had time to grow, invade, and spread. Screening exists because early breast cancers is invisible to hand and silent to patients. It does not cause pain, it does not cause a lump we can feel, it does not distort the skin. It is detected only through imaging before it becomes symptomatic. Why mammography works? Because it sees what no hand can feel. It is the only test that can detect microcalcifications.
Impactful lecture on early breast cancer screening. It was clearly focused and truly meaningful. To continue the session, it is with great honor and privilege that I introduce our respected head of the department, Dr. Anita Bajaj ma'am. She's an exceptional clinician and an expert in ultrasound, known for her precise diagnostic skills and sharp clinical acumen. Her talented hands in performing invasive procedures reflect not only technical excellence, but also remarkable confidence and dedication to patient care. Beyond her personal achievements, she is deeply passionate about health and fitness. She is also a marathon winner, beautifully balancing professional excellence with personal discipline and determination. Ma'am, we are truly proud to have you as our leader and mentor. We warmly welcome you and request you to begin your session on nuances of normal mammogram and mammography reporting, the BIRADS.
Thank you, Shubhi, for this, and thank you, Prabha, for beginning. This is a vast topic I'm trying to cover. There's a lot of things in mammogram, but let me see. I hope I can do justice to it. So we are really thankful to this, the ACR BIRADS Atlas now, and now it has become a manual. It has eased our life too quite a lot, because now it has given us standardized protocols what to follow. So how do we report a mammogram? First, start with the indication, breast composition, as Prabha also showed, important findings, mass, asymmetry. I'll go through everything. Comparison with previous studies, final assessment category, we have to give the BIRADS category and recommendation, how would we manage that particular category, or if biopsy needed, not needed, and then any unexpected finding which you find has to be communicated with the clinician. So this covers the same thing. Standardized reporting when you're giving BIRADS, it should combine, if you have done an ultrasound, the overall assessment should reflect the most suspicious finding. That is the finding with the highest likelihood of malignancy. And clear recommendation have to be given on a follow-up, when to be followed up and what further management needs to be done. So there's this BIRADS Atlas has given us a nice mammography lexicon, which we all, it's standardized. Now every breast, a person who's doing breast mammography should follow the same words and the same style to have a uniformity across. So the composition is from entirely fatty to little scattered areas of fibroglandular density to heterogeneously dense and extremely dense. So you can see, as Prabha also mentioned, how a dense breast is a big challenge because you can't pick up a lesion, or it's difficult to pick up. A mass can be either shape, can be either oval, round, irregular. We have to look at the margins, whether they are circumscribed, obscured, microlobulated, indistinct, spiculated. Then how is the density of the mass, whether it is low density lesion, which is fat containing, equal, or it is a high density compared to the rest of the glandular tissues. So what is a mass? It is a space occupying 3D lesion. That means if it is, it should be called an asymmetry. The shape can be oval. Sometimes oval mass lesions can have a couple of lobulation, 2 or 3. It can be round, it can be irregular, and the margins would be either very circumscribed. Sometimes they are obscured by the glandular tissues. They're microlobulated, indistinct or spiculated. Then density, as I mentioned earlier. Normally, all fat-containing lesions are typically benign. So microlobulated or microlobulated or indistinct margins normally implies a suspicious finding. And spiculated, of course, is almost classical of malignancy, so there it is a very suspicious finding. When you see that the margins of the lesion are obscured or partially obscured, we may need another modality like ultrasound to find out whether it's a benign lesion or it's a neoplastic malignant lesion. So these are few examples. This is a well circumscribed mass lesion, round, oval in shape. Then the other one is a lesion which is showing lobulated, microlobulated margins with some spiculations, and there are associated calcifications. Here again, this lesion, slightly indistinct margins. Can you make out the few spiculations coming out from the edges? So this was a malignant lesion. This is a classical spiculated lesion, where although it's small, look at the density and the spiculations seen. This is a well-defined lesion, oval with calcifications, but slightly, one of the margins is slightly indistinct. On contrast, on the right side, these are 2 lesions which are well marginated, oval, and you can see the complete margins. So this shows the benignity of the lesion. High density is normally associated with malignancy more likely, and where it's extremely rare for a breast cancer to have a low density. So this is a classical fibroadenoma, we all know, like a popcorn kind of calcification. Although you can see the lobulations, but they are not microlobulation. They are macrolobulation, slight undulation. The other lesion, this you can see is a low density. This is a lipoma, low density. I hope you can make out the margins in the retroareolar region. This, the same lesion, you can see the microlobulated margins. That's the spiculations running, and of course the calcification. This is a classically spiculated lesion, although it is not as high density. This one is an oval with slightly obscured margins. One of the margins was not, although this was a benign lesion. Again, these are 3 lesions, of which 2 are very well defined, and in one of them the margins are obscured. These were all fibroadenomas. This is the density. You can see from high density to medium density, and this is a lipoma, which is a low density lesion. So these are the descriptors. So this one of the lesions here, we can see on a, thankfully this was a fibroglandular, almost fatty breast, and here you can see the spiculated lesion. This was BIRADS 5 proved to be invasive ductal carcinoma. Then we come to the next part, apart from the mass, is architectural distortion. So term architectural distortion is used when the normal architecture is distorted with no definite mass visible. This includes straight lines, spiculations radiating from a point, and focal retraction, distortion of the straightening at the edges of the parenchyma. Of course, the differentials may be scar tissue or a CA. Architectural distortion can also be seen as associated features. When it is associated with mass, it is more likely to be a malignancy. You can see here there's subtle, I hope the slides, it's visible, there's a subtle architectural distortion seen here in the CC view. Same in the MLO view. We cannot see a definite mass. We take a compression view. Can you see how the speculations are happening here? And there's a calcification here. This is on ultrasound. So this was a BIRADS 5 lesion. Then we come to asymmetry. Asymmetry can be global, focal, or something which has been developing when we have been observing or following up. So what is asymmetry in a single projection usually is because of superimposition of the normal tissue, and that can be confirmed with ultrasound. A focal asymmetry should be visible in two projections. The real finding that must be differentiated from a mass. Global involves almost at least 1/3 of the breast and can be a normal variant sometimes. And developing asymmetry is more conspicuous as compared to the, when we see it compared to the prior examination. So you can see as an example, there's a subtle asymmetry here seen in the upper outer quadrant of right breast. Okay, when we zoom in, take a mag view, that is the visible lesion, and it was a typical spiculated lesion on ultrasound and turned out to be DCS. This is on the right side, there was asymmetry. On the upper outer quadrant, you see a compression view, and there were some amorphous calcifications here. This was again infiltrating ductal CA. This is a global asymmetry. You can see there's thickening of the entire breast skin and the parenchyma. It is more echogenic. Here also again, there's slight nipple retraction. And so this turned out to be the adenocarcinoma, which was, there were subtle masses on the ultrasound also, multiple lesions, hypoechoic lesions, which were irregular spiculated on ultrasound. Now asymmetry versus a mass, how do we differentiate? Asymmetries have different border contours than true masses, may also lack the conspicuity of the masses. Asymmetries appear similar to other discrete areas of fibroglandular, except they are unilateral with no mirror image correlate in the opposite breast. And asymmetry demonstrate concave outer borders as compared to the mass which demonstrate a convex outer border. Then something which we do mammos specifically for, it's the calcifications. So morphologically, we could have typically benign calcifications, something which are suspicious, like the amorphous, coarse heterogeneous, fine pleomorphic, or fine linear or fine linear branching. The distribution is very important as we go forward. The typical benign calcifications are skin, vascular, coarse, linear. I'll take you through them. And there is one exception to the rule. An isolated group of punctate calcification that is new, increasing, linear, or segmental distribution, or it is adjacent to a known cancer. These are probably benign or suspicious. So you can see these are benign calcification. That's a classical benign calcification, dot-like, and this is small. Again, a coarse calcification. These are dystrophic calcifications in a no operated case. These are popcorn calcifications of involuting fibroadenomas. This is eggshell calcifications. So what are suspicious calcifications? Amorphous are like hazy, like powdery. They don't have very specific shape when you see them. A coarse heterogeneous is irregular, conspicuous calcification that are generally between 0.5 to 1 millimeter and tend to coalesce but are smaller than dystrophic calcification. Fine pleomorphic are usually more conspicuous than amorphous and are seen to have discrete shape, the X, Y, Z which form. They are linear bunching forms, usually less than 0.5 millimeter. And the fine linear or fine linear branching calcification may be discontinuous. Occasionally branching form can be seen. They are also less than 0.5. We'll go through the examples also. So see, this is a classical amorphous calcifications. If you can make out, these are like powdery dot, like somewhere you don't even see whether they are there or not there. These again amorphous, and we had biopsied both of them while we're doing stereo. It turned out to be a DCIs. This is a lesion lump which the lady has been following, and then there is some asymmetry with amorphous calcifications. This was an invasive ductal cancer. These are clusters of amorphous calcifications. Again, there are clusters. See, there is a segment of the breast involved, and within that also these are clusters. So we need to identify them. This was a patient who had unilateral, diffusely scattered calcifications. Of course, we assured that it is diffuse, so you don't need to, but she was very anxious. So we did a biopsy. It turned out to be benign. So the diagnostic approach is to analyze the morphology, distribution, and change over time. The form of or morphology of calcification is the most important factor in deciding whether calcification are typically benign or not. If they're suspicious, we need to determine the etiology by doing a biopsy. Distribution could be diffuse or scattered. Calcification may be scattered throughout, in which case they are more likely to be benign. Regional, that is a larger volume greater than 2 ml breast tissue and not in the expected ductal location. Clustered is when there are at least 5 calcifications occupying a small volume of breast tissue. And segmental is when calcium deposits in ducts and branches of a segment or lobe. So you'll see in both the views and make out that. Sometimes the differentiation between regional and segmental is problematic because it is not clear on mammogram or MRI, the boundaries, but then both are kind of suspicious. Clustered calcification seen in benign malignant diseases both. However, when clusters are scattered throughout the breast, this favors a benign entity. A single cluster of calcification favors a malignant entity. And linear distribution is typically seen in DCIS, where it fills the entire duct and its branches with calcifications. So stability of intermediate or suspicious microcalcification is truly unreliable for exclusion of malignancy. That means we have to continue the surveillance. So it seems that morphology of calcification is far more important than the stability, and stability can only be relied on if the calcification have a probably benign form. So all suspicious calcification need to be on surveillance. Benign calcification, I said they have classical tattoo sign. Basically, they are similar appearance in both the views. Round punctate calcification are 0.5 to 1 millimeter. They are can be seen in fibrocystic change, DCIS, adenosis, skin calcification, very rarely in DCIS though. Suspect DCIS only when the calcification is small, that is punctate, and show some heterogeneity, especially when in cluster, linear or segmental distribution. So round and punctate calcification, we would classify them as BIRADS 2 when they are scattered, and BIRADS 3 or 4 when in isolated cluster, or if new or ipsilateral to the cancer. Already there is a lesion there. This is classical vascular tramline appearance. Sometimes confusion happens when one of the walls is not calcified, but it is self-explanatory. Coarse, of course, popcorn-like are produced by involuting fibroadenoma. They are rarely they have a diagnostic problem because most of them are very classical. This is the classical fibroadenomas. Then there's one interesting entity that is rod-like or plasma cell mastitis, which are usually greater than 1 mm in diameter. They have lucent centers, they are linear, and they are radiating towards the nipple and are usually bilateral. These secretory calcifications are most often seen in women older than 60 years. Sometimes it may be difficult to differentiate from linear calcification, but the uniformity or the distribution tells you. So this is the classical rod-like plasma cell mastitis kind of calcifications. Then lucent centered, we all know, round with a center with a lucent center in the center. mostly result of fat necrosis, calcified debris in ducts, and occasional fibroadenomas. Eggshell is a very thin, less than 1 millimeter calcification that appear as a calcium deposit on the surface. Although fat necrosis can produce these thin calcification, calcification in the wall of the cyst are the most common rim calcification. So oil cysts or the walls of the cyst, you can see there are multiple, this lady had multiple eggshell-like calcification. Another example is here. Suture calcification, very self-explanatory post-surgery. They could be staples or sutures which get calcified. Dystrophic calcifications these are the ones sometimes where we get confused because we want to see a recurrence post surgery, okay? So then it has to be very carefully monitored. They are coarse, irregular, lava-shaped. Calcifications are larger than 0.5 and have a lucent center. They have been seen in aerated breast or following trauma. They develop over 3 to 5 years after treatment in about 30% of women. These calcifications are also described as fat necrosis. It is important to differentiate them from recurrent malignancy. So see, these calcifications look quite scary if you see, but they are just dystrophic calcifications. You can see it on the other view as well. Now, suspicious are the ones which are high probability of malignancy and need to be biopsied. So, amorphous I have already explained. These are, so most of, however, one thing needs to be remembered, 60% of benign amorphous calcifications are benign. 20% are high risk of atypical ductal hyperplasia, lobular dysplasia, or lobular carcinoma in situ, and 20% have a risk of low-grade DCIs. 10% IDC. So we have to remember these ratios when we see. So BIRADS, amorphous calcification, we would say BIRADS 2 when they are diffuse and bilateral, 3 when multiple bilateral but clustered, but 4 when unilateral, clustered, or new on follow-up on an inpatient with or on a patient with cancer in the contralateral breast. So we would label them as BIRADS 4 in that case. So here are some of the examples. I hope this is visible. These are amorphous calcifications. I'll show you a zoomed up image. Now you can make out much better. See here. And these clusters also. They are both patients had TCIS. This again same. Now we come to the other entity, that is coarse heterogeneous, another suspicious calcification more than 0.5 millimeter. They are intermediate concern and they are sometimes they're seen to coalesce together. Location can be fibroadenoma, sometimes when they are small, fibrosis, post-traumatic, and representing evolving dystrophic calcification, but most of the time, so multiplicity and bilaterality of such calcifications favor benign etiology. DCIs is considered when they are clustered, linear, and segmental distribution. So the highest probability of malignancy are calcifications with fine pleomorphic, fine linear, and fine linear branching. These are fine pleomorphic. They are conspicuous than the amorphous ones, and they are better seen. So they have a 25 to 40% risk. These are linear branching. Again, we'll label it as 4C. So typically benign are, I have just compiled them together from the atlas itself. These are typically benign. These are suspicious, which we have already covered. Okay, so how do we label them as 4A, B, C? Amorphous is typically 4B, coarse heterogeneous is 4B, fine pleomorphic is 4B, and fine linear or fine linear branching is 4C. But apart from that, if they are if they show a regional, they are linear segmental distribution, then you have to upgrade them, and associated with the mass, higher chances of malignancy. So this is what we have already covered. Then we go to the associated features which we see. It could be skin retraction, nipple retraction, skin thickening, trabecular thickening, axillary lymphadenopathy, so the architectural distortion. So all these findings will upgrade the calcifications or other findings which we see. Like this is there's a skin thickening, axillary nodes, all that. So these are associated features which help us make a diagnosis. So we go from 4 to 5 if we see these associated features. Then after seeing all these, we have characterized everything. Now we have to give them a grade. So how are the grades? I am sure everybody knows BIRADS 0. So we'll just quickly go through that. BIRADS 1 is negative, which is like a good fatty breast, no abnormality seen, and we can safely call her for a regular follow-up. BIRADS 2 is when the patient has come for routine screening, but calcification, intramammary lymph nodes, vascular calcification, implants, related to prior surgery, or fat-containing lesions like oil cysts, lipomas, galactoceles, mixed density hematoma, all these will come in BIRADS 2. Then probably benign is where we need to see them in a close follow-up, like 6 months. So it's not expected to change over a follow-up interval, but the radiologist would prefer to establish its stability. Lesions appropriately placed in this category are non-calcified, circumscribed mass on a baseline mammogram, unless it has been shown to be a cyst or intramammary lymph node or other benign finding on ultrasound. Supplementary study has been done. Or a focal asymmetry which becomes less dense on spot compression view, we can label it as 3. Initial follow-up is 6 months. Then after 12 months, assuming stability, form a follow-up after another year. If the finding shows no change, we'll downgrade it to BIRADS 2. But if there's any change, we have to upgrade it to 4 or 5. So 4, again, we have gone through this, is the suspicious one where if it classify as 4A, B, C, so the lesions which are included in 4A are partially circumscribed mass suggestive of atypical fibroadenoma, palpable solitary complex cystic or solid cyst, probable abscess. 4B is group of amorphous or fine pleomorphic calcification, nondescript solid mass with indistinct margin. And 4C is new group of fine linear calcification, new indistinct solitary, irregular solitary mass. Final is 5 is where we are almost 100% sure, that is greater than 95% likelihood of malignancy. So the rationale right now is to do an immediate percutaneous biopsy. These are classically speculated, irregular, high density mass, segmental or linear distribution of fine linear calcification, irregular speculated mass with associated pleomorphic calcification, we'll put it in BIRADS 5. And 6 is a known case of biopsy proven case of malignancy. So how do we, after getting all this there, how do we approach, how do we write everything? There should be a complete set of location descriptors, right or left, quadrant, clockwise, on ultrasound, quarter and clockwise rotation should be supplemented on the image, depth, anterior, middle, posterior, distance from the nipple, and this has to be very clearly mentioned in your report. And you have to measure the mass at right angles, both the dimension. In lymph node mammography, we take the widest measurement. And for the calcifications, we measure the greater linear dimension. For architectural distortion is the greatest linear dimension. Lymph node is of course short axis. For one thing, important thing for speculated lesions, the speculations should not be included in the measurement. So let's go through few cases. What do you think of this? This is seems like a pretty well-defined lesion on the left breast. We see a CC view. Now what do you think? Does it look good? Yes. So here we go. So there is indistinct margin. There are some amount of speculation kind of thing, and see the ultrasound. This turned out to be lobular carcinoma, which is sometimes very scary when we get triple negative, lobular, all those. So now this is an architectural distortion here. You can see there's a mass here, but this looks pretty well defined, but you can see the architectural distortion here as I zoom in a magnification view. Do you like this? And the amorphous calcification. So what would we label this as? For C, yes, perfect. Now there's a very well-defined mass lesion, but something else here. They are pleomorphic calcifications. Can you see them? Now they are segmental, that is upper outer quadrant. This is the magnification view. The well-defined thing is the intramammary lymph node. What is this? BIRADS? 4C. And we could see on ultrasound also all these calcifications. So instead of stereotactic, we did an ultrasound-guided biopsy, and we got the diagnosis of DCIs. Now, can you see on this, there's a subtle lesion there. So, BIRADS. This is a classical spiculated lesion, so BIRADS 5. Now you can see here, there are multiple well-defined lesions here, but what is there? Do these look good? See here on a zoomed view. So this is a fibroadenoma, but what is this? What BIRADS would we give this? Yes. Now this, can you make out a difference between right and left? It's very subtle. Now see this. Is it more apparent? Okay, now we have a zoom view. Does this look good? It's little indistinct margins, but pretty much well defined. We did an ultrasound. So this was a fibroadenolipoma. So BIRADS 2, yes. This BIRADS, yes. This BIRADS 2, benign. This was a patient who came post-surgery for follow-up. I got a little scared seeing it, of course. So what do you think? Post-surgery, what BIRADS would you give? We would give it as 2, yes. There's a seroma which is causing all these changes, and there is dystrophic calcification. And I look back and see, last year also I've seen the same changes. So it's a BIRADS 2, although it looks scary. Then there's a lesion. This lady has been following up for a fibroadenoma, and now see there's something which is developing there. So this is a developing asymmetry, plus there's it has spiculations. So what BIRADS? Now see the zoomed view. BIRADS 5, perfect. This calcifications, what would you label? Is it visible? What BIRADS? 4B. Now I have not put deliberately the other view, but there's a subtle mass here, but there's something associated finding. Axillary nodes, yes, so it ups the grade. So this is definitely abnormal, and actually this is it was biopsy, we did the biopsy, it was a CA. So this is 4C definitely, and with added lymph nodes, you can upgrade it. See the ultrasound picture. So it is 5, BIRADS 5. You can see the speculations in ultrasound here. Now some few interesting things. What do you think of these? Coil structures, parasitic infestation. Parasitic infestations. Then there are 2 more here. See there, you can see the coiled. This is another patient. This is the 3rd patient. So all these were travelers. Now something interesting. Can you see here? Something is there. Now see on MLO. What do you think it is? It's an accessory nipple. I've marked it with a stapler. Okay, and can anybody diagnose this? From the students, of course. You can see the difference in both the CCs. Now see MLO. Any difference you can pick up? So it's important to see the surroundings also. So this is a Poland syndrome, yes. And finally, when you work with breast, they give you some love and happiness. Thank you.
Thank you, Dr. Anita ma'am, for reminding us that understanding the normal mammogram is the foundation of accurate reporting. Your step-by-step explanation of BIRADS has made the approach clearer and more practical. Moving on, it is my pleasure to introduce Dr. Bijal Jankaria ma'am, an experienced and respected breast imaging specialist and ex-vice president of Breast Imaging Society, India. She was also the director of Breast Outreach Program of IRIA conducted from 2019 to 2021. We are honored to have you here today to enlighten us on USG breast and USG BIRADS. Please begin your session, ma'am. We will first continue with the lamp lighting. So may I request our esteemed dignitaries, Mr. Arunesh Puneta, Regional CEO, Apollo Hospitals, Dr. Kiran Shingote sir, Unit Head, and Dr. Ravi Shankar sir, DMS, Apollo Hospitals. May I also request our faculty to please join us. As the lamp is lit, let it symbolize our shared commitment to advancing knowledge in breast health, improving patient care, and strengthening collaboration among care professionals. May I please request DMS sir to please share few words.
So first of all, happy Women's Day to all the ladies sitting here. And what a novel thought that, yes, this kind of interaction, this kind of activity should be organized on Women's Day, which benefits women at large. And to educate women, to sensitize women, I really congratulate Dr. Anita Bajaj and the whole of the radiology fraternity to have taken this initiative and initiated and organized this event. And I really thank all the people who have come here to attend on a Sunday morning and really gain and benefit from these activities and these talks. All the best. Thank you so much.
Thank you very much, sir. So now we have already introduced Dr. Bijal ma'am, so please come for your session, ma'am.
Differentiated as indistinct when there's a wide zone of transition between the lesion and the surrounding normal tissue. Sometimes they form acute angles or sharp corners to the mass, and then they're called as angular margins. Multiple undulations giving it a microlobulated appearance and speculations. And all of these are suspicious for malignancy. Echo pattern, quite easy. We all have been doing ultrasound for years. So anechoic and hyperechoic are more likely to be benign. When we use the term isoechoic, it means isoechoic to the subcutaneous fat and not to the glandular tissue. Hypoechoic, heterogeneous, mixed hyper and hypo. And now that complex cystic and solid is now not used, and now they call it mixed solid and cystic in the version 2025. Posterior features could be none, enhancement more likely to be benign, and shadowing more likely to be malignant. Now we come to this new concept of non-mass. And what is non-mass? It's shown in the version 2025. These are abnormalities that do not conform to a mass. That means they don't have a shape, they don't have margins, they don't have convex outer margins, and they may be well seen in one plane as compared to the other plane, and they are distinctly different from the remaining normal parenchyma. Now, when we talk about non-mass, we also talk about the distribution of the non-mass, which could be focal, which could be regional, which could be linear, or could be segmental. You know, like how we were talking about the microcals and their distribution. In non-mass, again, we also talk about its echo pattern, which could be hyper, hetero, or hypo, and here we can see that it is hypoechoic, and posterior features, which could be none, enhancement, or shadowing, and here we can see shadowing. In non-mass, we also talk about associated features. For example, here there is ductal extension as well as calcifications, and all that is more suspicious. Now, one thing is there, that on screening, if we start talking about non-mass, we'll have a lot of false positives. So we should do clinical as well as imaging correlation. Like in this patient, she had a spontaneous solitary duct bloody nipple discharge. And this is areas of non-mass which are focal, hypoechoic, focal as well as linear, no posterior features, and with duct extension as well as calcifications. So this is our description of this non-mass. To look at imaging correlation, she of course had a mammogram done first, and we can see segmental microcalcifications. And on MR, we can see there is segmental non-mass enhancement. So putting everything together, this is very suspicious for, can someone say? What does it look like? Yes, extensive DCIS, and this also had areas of microinvasion. Calcifications on ultrasound, we just talk of them as being macro or micro, but we also talk about the location, which could be within a mass or non-mass, outside of a mass, or intraductal. These are words that we must use while describing on ultrasound. Now, associated features of everything on ultrasound. Let's go only through a few of them for lack of time. We talk about an echogenic pseudocapsule, which is a thin white line surrounding the mass, which is very likely to be benign, versus an echogenic rind, which is now introduced in the version 2025. By that, we mean a thick band of irregular echogenic tissue surrounding the mass or a non-mass and likely represents desmoplastic reaction or peritumoral edema. Another interesting thing is, I know Anita said that do not include the speculations in the measurement of the mass. This, of course, has a high PPV for malignancy, but it is found that measurements, including this echogenic rind, have the best correlation with histology. Associated features, vascularity. If it is peripheral, it is very likely to be benign. If it is internal, especially if you have blood vessels going on from like perpendicular into the mass, it is extremely likely to be malignant. Elasticity, I'm sure all of you all do it. Who all have elastography on their machines? Great. So it's just a touch of a button, and it's based on the premise that benign lesions are soft and malignant lesions are hard. Look out for this color map because it changes between vendors. So here blue is soft and red is hard. We could have strain or we could have shear wave elastography, which also helps us with quantification of the stiffness of a mass. And it's very useful even for follow-up of lesions in patients who are put on NAT. Then there are special cases. We'll just go through a few of them. A simple cyst, as you all know, completely anechoic, no intracystic masses or vascularity or even echoes, thin imperceptible wall. Clustered microcyst. This is when we see small cyst 2 to 3 mm in size, clustered together, separated by thin septae, and they may even have a microlobulated appearance because of the cluster. There should be no solid mass or vascularity within. And then complicated cysts are cysts within septae or echoes within. When we talk about lymph nodes, we have to say whether they are intramammary, internal mammary, axillary, or even supraclavicular lymph nodes. And axillary lymph nodes are divided with the pectoralis minor muscle as being level 1 or 2 or 3, depending on whether they are lateral or posterior or medial to the pectoralis minor muscle, which is very beautifully seen on ultrasound behind the pectoralis major portion, only in this part of the breast. Location, she's already shown you the very same picture. We talk about which breast, which quadrant, the O-clock position, the distance from the nipple, the anterior middle and the posterior depth. In addition, on ultrasound, we can also talk about the anatomic zone. Like we can say it is at the junction of the subcutaneous fat with the anterior fibroglandular parenchyma. So it will be easy for us even to follow up benign lesions. Next, we come to the assessment categories. which are similar to what Anita said, but let's look at what happens on ultrasound. So category 0 means the assessment is incomplete and it is now divided into two. One is that we need additional imaging evaluation, and the second is we need prior images for comparison. If you see something, but it has already been reported in the mammogram done 4 years back or in the ultrasound done then you would just like to see the images and compare. Now this lady came for an ultrasound, 35 years old, with a lump in the breast. It looks fairly circumscribed, but we were not sure if there were areas of calcification with shadowing seen within it. So BIRADS category 0, we ask for a mammogram, and we can clearly see that it is a hematoma or a fibroadenolipoma. And once we figure that out, it is no longer BIRADS category 0, it is definitely benign, so we'll put it as a BIRADS category 2. Now category 1 means there are no masses, there are no suspicious lesions in both the breasts, and then we document one image in each quadrant as well as one in the retroareolar regions. Category 2 means that we are seeing a lesion or an abnormality, but we are 100% sure that it is benign. When do we use it? A simple cyst like this. If she had come only for a mammo, we would have given a BIRADS 0, asked for an ultrasound, proved it is a simple cyst, and then a BIRADS category 2. Fibroadenoma with involuted fibroadenomas or fibroadenomas with coarse calcifications, BIRADS category 2. Now BIRADS category 3 on ultrasound. All three is the same. It is not an intermediate category for malignancy. It should not happen that when the radiologist is unsure, when the resident is doing, she'll report it as BIRADS category 3, follow-up after 6 months, and then she will think that when Anita sees it after 6 months, she'll put it in its proper category. No, it is not like that. There are specific characteristics of lesions when we put it on BIRADS category 3. It cannot be put on screening, and the management is follow-up at 6, 12, and 24 months. Remember, we should try and push it as much as possible into a category 2 or a category 4, because follow-up becomes very query, especially in our country. You would not expect them to regularly come back at 6, 12, and 24 months. So there are two specific findings with robust evidence of it being BIRADS category 3. One of them is this, and remember, each word is important. A circumscribed, solid, oval mass in a parallel orientation. Likely fibroadenoma. If it had coarse calcifications within it, we would push it into BIRADS category 2. But if it does not, we should still keep it as BIRADS category 3, even if the patient is coming to us for the first time with a palpable mass. If there are multiple bilateral, at least 3, and at least 1 in each breast, then we can push it to BIRADS category 2. But a solitary one like this would be BIRADS category 3. And be sure that it is like this and not like this or this, both of which were triple negative breast cancers, very often mistaken for fibroadenomas. The other robust evidence is an isolated hypoechoic mass almost looks like cyst with echoes within, likely representing a complicated cyst. This would be BIRADS category 3. The chance of malignancy is like 0.08%, but it's not 1%. I mean 0.8. So after 2 to 3 years of stability, or even earlier, it can be pushed to BIRADS 2. However, if it increases in size or the margins start appearing irregular, push it to BIRADS 4 and do a biopsy. There are few other conditions, unique cases, where we can still use BIRADS category 3. One of them is a probable abscess, but we are not seeing classic mobile echoes within it, or a hematoma. Fat necrosis very often can give all kinds of suspicious abnormalities on ultrasound. What we should do is do a mammo, prove that it is benign, and then we can push it to BIRADS 2, because we can see fat very well on mammo. But if it is not done or the patient refuses, we can do this. And a reactive lymph node. So this lady had come after COVID vaccination, and we had seen an enlarged axillary lymph node in the same arm as the COVID vaccine. We asked her to follow up, and the lymph node has decreased in size. So BIRADS category 3 first, and then later BIRADS 2. Now 4 is a large probability of malignancy, 2 to 95%, therefore further divided into A, B, and C, and we should be biopsying these lesions. 2 to 10% is 4A, which is low suspicion. For example, this lady had come for screening, sister had breast cancer, looks relatively benign on mammography, but on ultrasound we can see some angular and microlobulated appearances. It is heterogeneous and even shows us internal microcalcifications. We are not going to leave this alone. BIRADS category 4A, this was biopsied and it was a fibroadenoma. Now 4B is 10 to 50% chance of malignancy. This is an intermediate risk. And again, there are specific findings where we can use this. For example, an intracystic solid mass with vascularity within. And this would be BIRADS 4B. This could be a papilloma. This could even be a papillary carcinoma. 4B. What looks like a phyllodes tumor, a mass which is rapidly increasing in size, has cystic areas on ultrasound, but phyllodes could also be benign, borderline, or malignant. BIRADS category 4B, this was borderline. And 4C, when it is very likely malignant, for example, this. An irregular solid mass with posterior shadowing, everything goes in favor of malignancy, 4C. And category 5 means it is almost always sure of being cancer, and that usually happens if there are associated microcalcifications within an irregular mass. BIRADS category 5, and this turned out to be malignant. Category 6 is proven malignancy. We knew that was malignant, and there's nothing else in the same breast or opposite breast which looks suspicious. BIRADS 6. When we write down our reports, we will talk about all of this, and it's available on the BIRADS manual. You can just look at it. We've gone through most of it already, but the composite report is important. Like, we should compare with the mammograms and then give a single combined assessment. Most of the times we do an ultrasound when we do the mammogram, so it is possible for us to give a combined assessment. For example, here she has a BIRADS 2 in the right lower outer quadrant. She has a BIRADS 3 in the right breast medially, and she has a BIRADS 4C in the left lower outer quadrant. So we are very pessimistic radiologists. We look at the worst BIRADS, which in this case would be, yeah, louder. 4C, why are you so worried about it? Yes, it is 4C, and in the decreasing order of relevance is 5 to 1 in this manner. With that, I thank you for your attention. I'm sorry, I just closed it. You'll have to just start it again. I just closed it.
You're done, ma'am.
I'm done.
Thank you, Dr. Bijal, ma'am, for decoding breast ultrasound and BIRADS so beautifully. What seemed complex now feels structured and will be more confident while reporting.
Now it is my great privilege to introduce our next speaker, Dr. Sabita Desai ma'am. She is a consultant radiologist at Breach Candy Hospital. She has made significant contributions in the field of breast imaging and interventions. She has been faculty in the IRIA outreach program on breast imaging and at national conferences like USCon and BCCon. We are truly fortunate to have you here today, ma'am. Please give us your valuable insights on granulomatous mastitis.
That one. Good morning. So thank you so much to the entire team of the Apollo Hospital. Happy Women's Day to all of you, and it's nice to see enthusiastic faces even on a Sunday morning. Well, the topic for today is imaging in granulomatous mastitis. It is a little bit of a challenging topic, but we'll only look at the salient features and important take-home messages. So at the outset, we are all like detectives. We need lots of information to crack a case. So whenever we start, how we approach a case, we have to look at relevant history. We have to look at notes from the referring doctor. We have to follow a particular imaging protocol. We have to look at the prior images. If there's a lump, you look at the details of the lump, do a triple assessment of the lump, and finally, last but not the least is rad-path concordance or discordance. So this is briefly going to be the contents of the talk. So what is the definition of mastitis? Mastitis is inflammation of breast irrespective of the cause. It may or may not be accompanied by infection. So why is it so important for us to work up these cases and come to a diagnosis? And this is because mastitis is a mimicker of malignancy. Now let's look at the clinical features of mastitis. The patient presents to you with redness of the overlying skin. There's increased temperature at site of lump and pain. And in imaging, we are always looking out for axillary lymphadenopathy. Is there a breast abscess? Is there thickening of the skin? Dilated ducts? Is there a breast mass? Is there parenchymal edema, or are there any discharging sinuses? So this is the whole gallery of cases of infectious and inflammatory diseases of the breast, and it's a big entire topic by itself. We will not talk of all of this, so we're only going to talk on granulomatous mastitis. Now, granulomatous mastitis is a rare, benign, chronic inflammatory breast disease, and it is characterized by inflammatory granulomas. It's divided into idiopathic granulomatous mastitis, or IgM, or secondary granulomatous mastitis, and this can be caused by conditions like tuberculosis, sarcoidosis, foreign body reactions, infectious mastitis caused by fungi, or very commonly seen are these corynebacterium infections. So why is it so important to differentiate and diagnose and differentiate between them? Because the management of granulomatous mastitis, it depends on the causative factor. For example, in a case of IgM, steroid therapy is very effective. But on the other hand, if you give steroids to a patient with TB mastitis, it can exacerbate the disease. Now, what is the choice of imaging modality? Now, any patient who is less than 40 years of age, you're going to do an ultrasound. For patients who are older than 40 years of age and in younger patients in whom ultrasound features are suspicious for malignancy, you're going to do a bilateral mammogram. However, in this set of patients, for patients, even if they're older than 40 years of age, who present with a tender lump, the preferred imaging modality of choice is ultrasound because compression during mammography is going to be very painful. However, once the inflammation resolves, if it is required, you must go ahead and do a bilateral mammogram. Important thing for all of you all to know is intervention in granulomatous mastitis. So whenever we are doing abscesses or aspirations, so if there is an abscess, you do aspiration of the pus from the abscess cavity, use the thickest needle which you have. Then you send it for gram stain, gene expert, TB-PCR, and culture sensitivity to look out for staph species, Corynebacterium, and Mycobacterium tuberculosis. Then, if you see a thick wall, you have to do a core biopsy from the wall. And this has to be sent for formalin, for histopathological analysis, and in saline or water for culture sensitivity. Let's talk about TB mastitis. It's a rare type of extrapulmonary tuberculosis, and it accounts for less than 0.1% of breast pathologies. It may occur as a part of systemic tuberculosis or as an isolated lesion. It affects young, multiparous, lactating female patients. They commonly present with features of mastitis, presence of multiple sinuses, fistulae, skin ulceration, nipple retraction, and axillary lymphadenopathy. We all know that there are 3 types of TB mastitis. One is the nodular one, which is commonest, which presents as a solitary or multiple well-defined, slowly growing painless masses. Then you have the disseminated type, which manifests as multiple foci of infection, which may later lead to abscess or sinus formation. And the last is the sclerosing type, which has extensive fibrosis as dominant feature, which may lead to secondary retraction and atrophy of the breast. So let's look at some cases. This was a 58-year-old lady who presented with a lump in the left breast, and she was referred for a biopsy because there was no resolution of the size of abscess post a course of antibiotics. So we did bilateral mammography and ultrasound. So here are mammography, this is the mammography, and you are seeing an equal density irregular mass here with indistinct margins. I've purposely put on this BIRADS descriptors, so whenever you are reporting, you heard 2 wonderful lectures in the morning, so when you do your reporting, make sure you use these terminologies. So this is an equal density, irregular mass, indistinct margins. And then we also look at associated features. What else are you seeing? There is retraction of the nipple, which is very beautifully seen in the tomo images. On ultrasound, you're seeing a cystic lesion. There is a thick wall, thick echoes, not much vascularity on color Doppler. On RF elasto, you're seeing this area to be soft. SF is soft, HD is hard. So the white areas are soft. The dark area is hard. And when you look at it, there is this duct extension with nipple retraction. Very beautifully, you can correlate the mammo and ultrasound images. So because RF revealed soft areas, we put in a needle, aspirated pus, and sent it for cytology and culture sensitivity. And we also did an FNAC from the wall, and it showed inflammatory lesion with granulomatous reaction. Dense inflammatory infiltrate predominated by neutrophils along with aggregates of epithelioid, histiocytes, and giant cells. So this was a nodular form of tuberculosis where you're seeing a solitary mass that may turn into an abscess. So this patient was treated accordingly, and she resolved very well with a little bit of residual scarring. Next was a 45-year-old lady presented with a lump in the right breast, and there were lots of discharging sinuses on the skin. Gives history of taking sufficient antibiotics but no respite from symptoms. Mammography was offered, but patient refused, so we had to be happy with just an ultrasound. So what you're seeing here, you're seeing abscess in the retroareolar region. There's thickening of the skin, overlying skin, and there's increased echogenicity of the fat lobules. There's no vascularity on color Doppler. And there were these multiple sinus tracts extending into the skin. There was an enlarged axillary lymph node with thickened cortex and increased vascularity. We again went ahead, did aspiration of the pus and FNAC from the wall, and this was an inflammatory lesion with granulomatous reaction. So this was the diffuse or disseminated form, which involves the entire breast, multiple communicating abscesses and discharging sinuses. You saw a lymph node. There was a cystic lesion with thick wall and thick echoes, and there were discharging sinuses. I unfortunately don't have an image of this, but the sclerosing type of TB mastitis presents with diffusely thickened skin, nipple retraction, and hard irregular breast mass, and that resembles malignancy. We now come to idiopathic granulomatous mastitis. Now, idiopathic granulomatous mastitis is also known as non-puerperal or granulomatous lobulomastitis. It is a rare benign chronic inflammatory breast disease which was first described by Kessler and Wollock in 1972. Every word in this is important. It is characterized by sterile, non-caseating, lobulocentric granulomatous inflammation. And it occurs in women of reproductive age who have been pregnant at least once prior to presentation. Pathogenesis is linked to autoimmune disorders, pregnancy, lactation, hyperprolactinemia, oral contraceptive pills, and alpha-1 antitrypsin deficiency. Now, the most accepted theory is that there's an initial insult to the ductal epithelial cells in the breast, and that causes a transition of luminal secretions into the lobular breast stroma. This transition causes local inflammatory response in the connective tissue with macrophage and lymphocyte migration into the region, and subsequently a local granulomatous response. So this is how clinically you'll see there is skin erythema, and you can see this inflamed terminal ductal lobular units. So let's look at some cases. 35-year-old presented with a tender lump with redness of skin in the left breast. There was discharging sinus at site of lump and redness, and she said she had fever and complained of malaise. She was 35, so we started with an ultrasound, and we also did a mammography of the symptomatic breast. So many findings. So there are multiple abscesses. There are tubular extension of these, very typical of IgM. So you can see this tubular extensions into the surrounding fat. There's increased echogenicity of fat lobules, and there's also sinus tract there extending up to the skin. She also had these multiple sinus tracts, which you can so well see. We did a mammography. It shows these equal density masses with indistinct margins, and she also had thickening of the skin focally. That was in the left breast laterally, because all these lesions were at 3 o'clock position. So what we did aspiration of the abscess, and we also did core biopsy from the wall, and this revealed dense inflammatory infiltrate comprising histiocytes with interspersed good number of neutrophils. Granulomatous reaction, very important that it was negative for the Zeal-Nielsen stain for acid-fast bacilli and GMS stain for fungus. So this was a sterile, there was no infection seen, so they said this is granulomatous mastitis, which favors IgM. This patient then, she came to us in 2023, she was put in steroids, and now she's doing pretty well. Everything has resolved pretty well. 32-year-old comes 19 weeks of pregnancy, presents with a lump in the breast, 10 weeks duration. Prior FNAC from somewhere has shown granulomatous mastitis. Swelling had persisted after 2 courses of antibiotics. Her older child is 4 years old. This case was given to me by Dr. Janki. Now here you're seeing this heterogeneous mass. Then what is important, you can see this tubular extensions into the subcutaneous tissue, like you saw in the previous case. Color Doppler revealed increased vascularity. Core biopsy done showed idiopathic granulomatous mastitis. 41-year-old presents with redness and tenderness in the right breast. She had so much pain that she, even while doing her ultrasound, she was very uncomfortable. And she said, I'm going to get the biopsy done only if you give me general anesthesia. So we actually did the biopsy and abscess aspiration in the operation theater. So here you're seeing this big heterogeneous mass in distinct margins. This is the increased echogenicity of the subcutaneous fat. You're seeing tubular extension into subcutaneous tissue. She also had a big abscess in the retroareolar region here and lots of inflammation around. So we did a core biopsy from the wall of the abscess, and here again, this shows granulomatous lobular mastitis. So what are the imaging features? On ultrasound, you'll see heterogeneous or hypoechoic irregular masses with tubular extension into subcutaneous tissues. You'll see abscesses and sinus tract. On mammography, you'll see focal asymmetry with architectural distortion, equal or high density irregular masses with indistinct margins, and lymphedema with skin thickening. So what are the differences between IgM and TB mastitis? IgM mainly affects premenopausal and Paris women after nursing period. Then the mastalgia is more in IgM and less in tuberculous mastitis. Axillary lymphadenopathy is more in tuberculous mastitis. The mammography appearance will be almost the same, but what is you see in IgM, the tubular extensions on ultrasound along with the irregular hypoechoic masses. But the clinching feature is the histopathologic features, where in IgM you'll see lobulocentric non-caseating granulomas. They are negative microbial staining and culture results. And in TBM, you'll see caseating granulomas with positive AFB or Phyte staining results. So this is the algorithm which you follow. If a patient is clinically suspected of mastitis, you treat her with antibiotic treatment. Then if she does not resolve, you subject her to radiological investigations like ultrasound or mammography if she can take the compression. If there's an abscess or a collection, you do a fine needle aspiration and send it for culture sensitivity. If there is an abscess, maybe incision drainage. If it doesn't respond, then you follow her up. If she resolves, fine. If she doesn't resolve, then you do a core biopsy from the wall. If you have the answer for the mastitis, then you treat it accordingly. Sometimes, what if it's malignancy? Whatever, you treat the patient accordingly. But if it is idiopathic granulomatous mastitis, then we come to this algorithm for IgM. If there are localized findings, mild symptoms, put the patient on surveillance. Generalized findings, moderate to severe, put the patient on corticosteroids. Partial response is surveillance. Complete response, return to screening. Contradiction or failure to steroids, you put the patient on either methotrexate or bromocriptine. If there's complete response, return to screening. If there's no response, then you subject the patient to surgery. Now the latest thing is intervention with steroid injections for IgM. Ultrasound-guided injectable triamcinolone acetonide has shown promise. I know a few people who are doing this. It has shown promise in symptom control and lesion resolution and can serve as a bridge to surgery by reducing inflammation. So what's the procedure? You aspirate the pus from the collection. Then 1 cc of Kenacort diluted in 1 cc Loxicart is injected in and around the collection using a 21 gauge needle. So this is what we saw today. So take home. Always remember, there are only 2 things to take home from this message. Mastitis is a mimicker of malignancy, clinically and on imaging. So be very aware of the imaging features. Although IgM and TBM have different etiology, clinical and imaging features are very similar. Now remember, infectious and inflammatory diseases of the breast are commonly seen. As I said, be very aware of the imaging features. And interventions for granulomatous mastitis, they are aspiration. Remember, do aspiration of the abscess, do a core biopsy from the wall, and do not collect it just in formalin, collect it in formalin and saline or water, which your institution prefers for culture sensitivity. These are the references. These are very nice articles. You must go through them. Thank you.
Thank you, Dr. Sabita ma'am, for such a comprehensive and insightful session on granulomatous mastitis. With its rising incidence and diagnostic dilemmas, your session was extremely relevant to our daily practice.
Now it is my privilege to introduce our next speaker, Dr. Smriti Jha ma'am, Senior Consultant Radiologist at Apollo Hospital, Navi, Mumbai. She brings with her more than 25 years of rich clinical experience in the field of radiology. She has a special passion for MRI with a particular expertise in women's imaging. Her deep understanding, meticulous approach, and dedication to diagnostic excellence has made her highly respected in this field.
I'll just make a quick announcement. Anybody wants to have tea, coffee, can just pick it up and come back. We are not taking a break. So, tea and coffee, I said we'll not take a break because so if people, no, people can just intermittently, it's lying outside, just pick up and come back.
Yes, sir. So, everyone getting tea, coffee? Good, good. I don't want anyone to be sleepy here. So, please, you are encouraged to go get tea and coffee till I just keep everyone else entertained. Right, so Isaac Newton, everyone has heard of his name, of course. You can't pass class 9th physics without hearing his name. He said that I can see further. If I can see further, it is because I'm standing on the shoulder of giants. Sort of extrapolating the same thing to MRI. MRI has got two very strong pillars, which are like amazingly good. Mammography and ultrasound. Let us not forget that when we are doing MRI. That is not to say that MRI is not good or not useful. Echo ho raha hai kya? That is, it is not good or not useful. It is just to reiterate the importance of mammography, the ultrasound, which at least in the foreseeable future, we cannot get rid of for the diagnosis and the management of breast-related diseases, be it men or women. How many residents here? Okay, so this is for you, my lecture. So my name is Dr. Smriti. And first of all, I begin by thanking you for being here, being my audience. It's a huge privilege when someone listens to anyone else with such rapt attention. At least I'm seeing in few of the faces, so thank you very much. And I'm given 15 minutes to speak on this topic. So I will not be speaking on any techniques, how to do. I'll not be speaking on contrast. I'll not be speaking on any protocols. Instead, because it can't be expected that you will be taught anything in 15 minutes. So what my intention with this talk here is that, to increase the awareness between all of us, because I think right now, we who are there in this room are the actual serious people here. So hats off to all of you. So, my intention here is that we just increase our awareness that yes, MRI can be a beautiful double-edged sword. If it is a precise science, you know, let us increase our awareness, our dedication, our passion for MRI breast, so that we can also elevate it to the level of an art, okay? So I'll be showing you cases and that is it. First of all, why do we do MRI breast when we have got two beautiful things, mammography and ultrasound, which usually I think 99% of the picture you get by MRI, you get by almost 95% you get by mammography and ultrasound. So why MRI? To know basically four broad categories of reasons. Number one, you know that the patient is having CA. So the patient comes to you after the diagnosis for better extent demonstration of the disease process. Second thing is, in a post-op cancer case, the patient comes for routine follow-ups and to see for routine follow-ups basically, or in just immediate post-op case to see the residual lesion if it is a margin positive. Third thing is when mammography and ultrasound, together they are in slightly BIRADS 3 category kind of place. We are not very, ultrasound and mammography, we are not very comfortable giving a diagnosis, so we take the help of MRI. And the fourth reason why MRI is being done, and increasingly so if I may say, is that screening. People with high risk, high risk cases, they come to us for screening, large breasts, dense breasts. So MR when done at the correct time of the menstrual cycle, not all the time if it is screening, that can be quite helpful in fact. So now, so what I'm going to show you is a diagnosed case of CA. So this is just a resident level thing. We already know it is CA, so why are we doing MRI here? To know the extent of the disease. For example, everyone can see, everyone can tell it's a CA, no doubts. So what is important here? To see that the chest wall is free, to see that there is subtle skin involvement here, which was not as clearly visualized on MRI, on ultrasound or mammography, and to see whether the nipple here is involved or not. So slight retraction of the nipple, we can see the enhancement going till the nipple. These are important points which are going to help the surgeon. This is another case of CA. She was a lactational case. Look at the dense breast. We can all look at how the nipple is also involved. Now, why was this MRI done? It's echoing a lot, is it? So why was this MRI done? For the only precise point that is the chest wall involved or not. Mammography and ultrasound was somehow not very, the radiologist was not very confident about the chest wall. So we did the MRI, we can see that the chest wall is absolutely, the retromammary fat pad, we can see that line very nicely. A similar case, a middle-aged female coming with a lumpish feel and mild tenderness since approximately 4 weeks. This is the MRI. Pre-contrast image and rest 3 are post-contrast. These are the inspissated secretions, what we see here. Post-contrast, we find that there is enhancement along the ducts and some of its branches. So point to be noted is that we are getting this enhancement along a duct and some of its branches till the nipple. So why have I showed you this case if it's an infection? Compare CA, infection. Just so how can we differentiate? Because somehow I have got a feeling that MR and ultrasound, at least when I do, I still get a bit of latitude. Achha, samajh nahi aa raha hai, dekhte hain. MRI, that latitude is not there. That liberty is quite less, in fact, in MRI. So what we see in this CA, both the lesions are going till nipple, both the lesions are at the similar positions, similar distribution. But in CA, we can see that it is, where is the marker? In CA, we can see that sort of irregular masses are being formed here, as we are going. Whereas in this, it is smooth. All the way the duct is enhancing, it is smooth. And on the console, you could also make out that the lumen of the duct was showing inspissated secretions. The walls were getting enhanced. And somehow when you saw the dynamic imaging, you could find out that somehow you had a gut feeling that it is not enhancing that well. I could not get a very good dynamic curve of this, though. Next, middle-aged female came with breast enlargement and tenderness over last few days. This is the MRI. Everyone knows this. This is IBC, inflammatory breast CA. It is rapidly growing. It can have tenderness. It can have redness. The breast is enlarged. Okay. And as a corollary to that, another case of lump, similar sort of symptoms, is this case. This turned out to be infection. We'll see the comparison. First, we can see that this iso to hyperintense thing here, iso thing here, that's the fluid within the ducts. We can see the duct wall enhancing. And of course, the surrounding glandular tissue is also involving, but we do not see any mass sort of forming thing which we could see in the earlier lesion. And this is just comparison, inflammatory breast CA versus infection. In inflammatory breast CA, we'll get, confluent, irregular mass lesions which are enhancing. In infection, usually we do not. Even though the area, the distribution might be the same, we see the ducts which are enhancing, inspissated secretions within the ducts. We'll see the walls which are enhancing. Mostly if you check the early images, usually what I have found is that the walls enhance first, whereas in CA it's not so if the ducts are involved. Next, this is the history, mammography done, health check 10, asymmetric density, BIRADS 5 lesion and 1 satellite. Now why am I showing this case? Ultrasound image. Why am I showing MRI? Ultrasound done with extreme dedication showed only 1 nodule. Here MRI is showing us 3 nodules. This is the main lesion, this is 1 satellite, and these 2 are the other 2 satellite lesions. Trust me, these satellite lesions, the distance from the main lesion, their sizes, they are of extreme importance to the person who is operating. Because nowadays you try to conserve the breast as much as possible. So the knowledge of these, which the MRI is like extremely sensitive to, is supremely important before you go in, the surgeon goes in. Next, 51-year-old postmenopausal, pain, itching nipple since 1 to 1.5 months. This I just showed, this is classical pages. Classical pages, so why do we do MRI in pages? To see the distribution, because usually the clinician knows it's a pages. So just to look at the distribution. So few cases where MRI for me came out as a problem solving tool. This case, non-hemorrhagic discharge, left breast, no pain, tenderness, no lump. Ultrasound showed dilated ducts with echogenic lumen, that means secretions within. Ultrasound could not demonstrate any papilloma, which the clinician is suspecting. MRI, I'm just showing 2 images. The one on this side is non-contrast. We can see the inspissated secretions. Inspissated secretion here. Here we can see the papilloma. So actually it's like, by looking at the kinetics, I'll be more sure of whether it's benign or malignant, take a shot at whether that part. But now we have demonstrated without doubt that yes, a papilloma is there, and once a papilloma is there, you have to go and take it out. Next, patient came for routine health checkup, mammography done. This is the asymmetric density we see, and I hope there are few calcifications here, sort of monomorphic rounded. This is the ultrasound, solid cystic area which we see. I gave it BIRADS 4B, and we did an MRI. So this is the area here. Sort of irregular, indistinct, is it a lesion or what? This, we see cystic areas also in this, we see some solid tissue component, this is like some non-mass enhancement here, something here. On biopsy, this turned out to be apocrine metaplasia. Apocrine metaplasias, they are benign things, which is a part of fibrocystic sort of, a spectrum of that, and clinically on MRI at least, they can mimic CA. So what is the take-home point for this? That I don't see a mass lesion, and even in like somehow when I looked at this case first, so I found that I gave it as 4A only, somehow not even B. Why? Because, and I was thinking it retrospectively, why did I not give it 4B or something? So it was because of the enhancement pattern which I am seeing in the 4th image here. It is not exact, it's like sort of non-mass enhancement, but it's like I'm seeing as if the normal architecture of the breast is not disturbed a lot. Next, follow-up case of cancer breast, felt a lump, sonography done showed solid cystic spaces with calcification and mild vascularity. Dr. Bijal told initially, she told about fat necrosis. On ultrasound, it can present in varied forms, varied ways. So fat necrosis is something we can be 100% shown on MRI, 100%. So like on MRI, you say the patient is relieved, the clinician is relieved. Here, T1, T2 images, both are hyper intense. It is fat necrosis. But just looking at fat necrosis is not enough. We also have to look, because fat necrosis you can say on non-contrast images. So why do we give contrast? To look whether there is any abnormal enhancement. We see that there is absolutely no abnormal enhancement. Any abnormal enhancement to pointed towards whether there is any residual or recurrent disease. Next, a young female with lump left breast with mild tenderness, no mammography, and BIRADS 3 lesion. This, I think everyone can say it is infection, mastitis kind of thing. Now, how can we be very sure on MRI? It is like on MRI, it is beyond doubt. See, this is the T1. I am not very sure whether this is a mass lesion or is it a soft tissue, what it is. What I am sure of, it is not there in the other breast, full stop. Coming to this lesion, I see that there are something like linear things. There is no significant mass lesion per se, even though these two images, I do not think they are on the same plane. Sorry about that. Next, this is just in this, let us come to this first. In this, the contrast is given. We can see that the duct walls are enhancing. And this is the secretion within the duct. It is just the walls which are enhancing, the surrounding breast parenchyma which is enhancing, and these two intramammary lymph nodes are there. Of course, they show mildly thickened cortex, but that's okay. In infection also, the lymph nodes can get enlarged. So this was where we converted 3 into 2 with absolute clarity on it. Next case, on routine follow-up post-CA breasts after surgery, MRI was being done for the first time. And there was a suspicion on ultrasound which was done outside whether there is a disease recurrence or not, because there was some soft tissue. I do not have the image. So this was the MR. This again, we could help the patient with absolute clarity. See, in MR, there are few cases where I do not know. I would like to have help of ultrasound, mammography, previous investigations. Few cases, I know it is it, full stop, nothing else needed. And something is in the gray area. Majority of the cases, at least in my thing, they are somewhat very clear to grayish area sort of. But I was very happy to say that this patient we could help. We were absolutely sure, no, there is absolutely no disease recurrence. And the joy on the patient's face at that time is like worth it. So this is the area where the previous CA was there, surgery was done. These are the staplers here. This is the T1 stir. This is the diffusion. I do not, on this, I'm getting some hypo-intense area here, relatively hypo-intense. This is slightly bright here. On diffusion, I have not put any ADC image, okay. So, but there was no restriction. And most important is diffusion plus the one on the bottom are the post-contrast. We see that the enhancement is absolutely negligible, and the kinetics what we get, the graph what we got was absolutely very slow slope and very gradual going on slow increase. We were categorical, there is no disease recurrence. Now, this is a sensitive topic for me. The reason is at least I feel very helpless where MRI doesn't help me. And trust me, it happens not very infrequently. Follow-up case, so why am I showing these cases? First is to remind myself, because anything I say here on the stage, I know I'll remember it throughout my life, and hopefully you can learn from my mistakes. So, follow-up case CA right breast for routine, now routine follow-up. This is the asymmetry which we got here. This was not there in the previous year mammography. Corresponding ultrasound, suspicious. In a post-CA patient, very suspicious. This is the MRI we did. So, and this is the soft tissue which we got. T1, T2, these are the post-contrast. See, look at the contrast here in the great vessels and look at this soft tissue. It's not even enhancing very well. Again, I was quite confident, no, it is just post-op scarring. There is no recurrence of the disease. And this was done quite early in my career, and I was proven wrong. The patient is still undergoing treatment in one of Apollo sister hospitals. This was disease recurrence. So low-grade cancers can fool us by their enhancement pattern. So, but somehow the ultrasound came to our help, and we did a biopsy then and there, of course, but the thing is MR did mislead me at least. So any low-grade cancers, please be wary of the enhancement pattern. Next, discharged right nipple, dilated ducts. We couldn't demonstrate, ultrasound couldn't demonstrate papilloma, but Strongly suggestible, of course. So MRI is advised. So again we see, this is pre-contrast. I see something white here. It is E-Thrive image T1, inspissated secretion is going to be absolutely white. This is white here. Rest are post-contrast images, like you can see the contrast in the heart. Okay, this is non-contrast image. We can all see this white thing here. All are inspissated secretions within the ducts. The images on the right, they are post-contrast. We can see that the images is almost the same as the pre-contrast one. And post-contrast, we could find some glandular enhancement, but even though I, almost point by point, I compared to find a papilloma very, very hard. I could not. Very confidently, I gave no papilloma at all. Thankfully, the surgeon persisted with her clinical acumen, and she did a microductomy. There was a tiny papilloma sitting right here near the nipple. And even retrospectively, when I have gone and looked at the case, I have been unable to find. But yes, what does this case teach me? Don't be so sure. Don't override the clinical details. Patient is not MRI. Patient is of the MRI. So look at the MRI with the clinical history in details. Small papillomas, I don't know how often it can be missed. Because after that, I haven't missed another papilloma, so let us see. Next, outside ultrasound, fluid-filled cyst, fluid aspirated. It was hemorrhagic in nature, but the cyst filled up rapidly. The surgeon said the patient for an MRI. Why? Because hemorrhagic fluid filling up rapidly, of course you have to rule out CA. This is the MRI. See, I'm not showing ultrasound images because of time factor, okay? Otherwise, all these are done at our institute in Apollo. So all of us can see the cyst here. All of us can see this small nodular component, which was not written in the ultrasound which was done outside. So first of all thing is nodule is there, soft tissue is there, it is enhancing, and the kinetics, my God, you should have looked at it. It was like typical CA. Very confidently I gave it to be CA. Like I gave it 4C, I guess. Looking at diffusion restriction was like intermediate kind of thing. But kinetics and the T2, it was like not very hypo, it was slightly on the hyper side. So I said, no, it is cancer. Surgeon went took it out, it proved to be benign. So my take home message is then I went home, dug up some articles and was reading about post-intervention cyst with soft tissue nodules enhancement. First of all, very difficult to find very pinpoint articles about this, but I did find some theory. So after intervention is the enemy of MRI, first of all. We have to make the clinicians understand, and they do, that please kindly get MRI done before putting even a 21 gauge needle. It changes the picture by lots. But about this nodule, I am yet to learn more. This is just one uncommon case. All of you must be knowing this. 17-year-old girl, breast enlarged, multiple giant fibroadenomas. Why am I showing you this? It's a classical spotter, it's a benign disease, but these all are plain images. None of them are contrast images. Why am I showing you? Because, they are so large, the girl is panicky, the girl's family is panicky, and we may try to be, we also get disturbed by their anxiety, and then we may, like in this case, MR shows it very clearly that it's totally benign finding. That is it. And plus, this is the only case I have seen till now of this particular thing. So why do we do MRI? First of all, that is my go-to question whenever I start any MRI case. Why am I doing this case? My answer is to help the patient, full stop. How can I help the patient? By helping the clinician, full stop. How can I help the clinician? Number one, to give an accurate diagnosis. Not possible in all circumstances, but then the closest to accurate diagnosis. And number two, by telling the surgeon the extent of the disease, so that there are no surprises when the surgeon goes in. So this is this thing. And for this to happen, there has got to be a very transparent, a very free flow of communication between the diagnostic and the treatment team. Diagnostic team consists of the radiologist, the pathologists, the unsung heroes, pathologists. You know, a lot depends on them. And the treating physician and the treating clinician, the breast surgeons, the onco team. There has got to be a free, transparent flow. Trust me, in any hospital, if this flow of communication is good, smooth, make it a point as radiologists to talk to the pathologist, to talk to the surgeon, to talk to the oncologist. It will make, not for them, it's for you, for me. It makes my life easier, you know. So with that, I thank you for your attention, for your time, and I hope we could learn something. Thank you so much. And Shubhi, such amazing words for me. I hope I deserve them. Thank you.
Ma'am, you surely do.
Thank you so much, Dr. Smriti ma'am, for simplifying breast masses. You made a complex subject feel structured, practical, and approachable. It was a wonderful learning experience.
Again, it gives me immense pleasure to invite Dr. Bijal ma'am back on the stage to enlighten us on breast cancer and its molecular subtypes.
So I'm going to be talking about the molecular subtypes and their imaging correlation. So breast cancer, as we all know, is a very heterogeneous disease, and each has a distinct biological behavior as well as imaging characteristics, and most important, response to therapy. The traditional classification is based on histopath, the nuclear grade, and TNM, which is clearly not enough. As you can see here, you know, and this has been given to me by Dr. Roshni Chinoy, a pathologist who deals a lot with breast cancer, and a wonderful person. Look at all the different pencils which are labeled as invasive breast cancer. But some of them are so nasty and some of them are almost angelic. Even the same stage patients have different clinical outcomes. So therefore, this classification is of limited prognostic value, and we really need to subcategorize breast cancer in a therapeutically meaningful way. So in the journal Nature in 2000, way back, Peru and colleagues spoke about the molecular subtypes of breast cancer, which was based on gene expression patterns. But later, there is now a surrogate classification of breast cancer based on the immunohistochemical markers, or the IHC markers. So remember, whenever we do a biopsy, we should ask for these specific markers to be done on the biopsy itself. And what are these? Two of them are hormone receptors, estrogen and progesterone receptors. And again, if you're friends with a pathologist, they'll give you nice pictures of these. The next one is HER2. 0 or 1 plus is considered negative. HER2, which is 3 plus, is considered positive and looks like this crocodile skin appearance. And 2 plus is considered equivocal, and then we need FISH testing for that. And the last one is the Ki67 proliferation factor, which could be low or high, and here we can see low and high. And I really miss Dr. Anita Borges, who has done, you know, Anita, it's not showing properly, even on this and this. It's overlapping with what I've written. That is not how the original thing is. Yeah, if you can just change it. even the labeling, इधर आओ, ये सब हैंडराइटिंग भी अलग हो गया है, ये इसके साथ ओवरलैप हो रहा है.
लिखा हुआ ना कुंदन ये लाइन इसके
Okay, so based on these IHC markers, which are the ER, PR, HER2 and Ki67, 4 subgroups are formed, which are luminal A, luminal B, HER2 enriched and triple negative breast cancer. So let's go on to luminal A breast cancers. By luminal, we mean it is ER positive. Luminal A is ER positive, PR positive, HER2 negative, and Ki67 is low. And clinically, fortunately, it is the most common type of breast cancer seen in older women, often screen detected. This is very important. That means they grow slowly and they have the best prognosis. So these luminal A on pathology are smaller tumors, low grade, and may be associated with well-differentiated subtypes like mucinous and tubular breast cancers. Let's see what they look like on imaging. This lady had come for routine screening. Look at that 2024 going on the second line. It's quite weird. Sorry about that, but just imagine it's in the same line. And the previous mammo is of 2021. And something new in 2024, there is a developing density which is not this, but is this. And since we have tomosynthesis, we can clearly see that there is a small new spiculated lesion which has developed. This problem did not happen in my first lecture. Because now half the things are being cut also. Anyways, so on ultrasound, it's a tiny hypoechoic irregular nodule which was picked up thankfully because we knew where to look for it, as on mammo, which is hard on elastography. And on MRI, there is a small enhancing irregular mass with nothing else in the same breast or even in the opposite breast. So tiny, less than 6 mm nodule, best prognosis. She was, of course, we did an ultrasound-guided biopsy. It was an IBC, grade 2, ER/PR positive, HER2 negative, and lower Ki67. So, what kind? Luminal A breast cancer. Perfect. Another lady came for routine screening. She said her prior mammograms done many years back were normal, but what we see is on the CC view, we can clearly see one mass, but on tomosynthesis, we can see 2 masses, and on ultrasound, these were microlobulated, slightly irregular, one at 3 o'clock, the other at 4 o'clock position, quite close to each other. As far as the right breast is concerned, and let me see if it's seen here, yes, we can see few, what kind of microcalcs would you call it? amorphous, perfect, group, oh, it's already written there. So there's grouped amorphous microcalcifications, and because we saw this and we saw 2 foci on the left side, we asked for an MRI, which would have been the perfect way to go before proceeding with anything else, including a biopsy. Instead of that, they decided to do a PET CT, which said there's no uptake on the right side, let's just deal with the left breast lesions. And in the left breast, on PET CT was uptake only in those 2 lesions. So we biopsied both these lesions. It turned out to be, both of them turned out to be luminal A breast cancers. So her left breast story is that there's a luminal A breast cancer, whereas the right breast story, in the left breast, because there were 2 foci, they just did a breast conserving surgery, gave radiation and endocrine treatment. Whereas the right breast story, picture abhi baki hai mere dost, I will come to it a few slides later. This 54-year-old, her mother had breast and uterine cancer and died of it at the age of 50. She comes for routine screening. And what do we see? A lesion, more like architectural distortion. And look at the speculations, especially on tomo, thin and long. And what is this? There seems to be a central fat density. So I was really rooting for a radial scar. How many people think this is a radial scar? Nobody? Oh, I was in a minority. On ultrasound, we can clearly see that there is an ultrasound correlate to that architectural distortion. And what is important is, since elastography is done, you can see what area is hard. So when we take the measurements, we don't take it including this area, which is just the retromammary fat which is pulled in by the tumor. Not only for the measurements, for the biopsy too, we should be careful that we don't take a biopsy from this area, and we should be sure about taking it only from this area. So these lesions we have to be really careful about anyway. It turned out to be an IBC of tubular and cribriform type. Very good prognosis, grade 1 and luminal A breast cancer. So in short, luminal A breast cancers are screen detected, they are small, they are slow growing, and they have time to form the desmoplastic reaction, which is easily seen on mammo and on ultrasound, and they have the best prognosis. Of course, all breast cancers are devils, but these are the relatively cute devils to have if one had to have breast cancer. Surgery-wise, you just need surgery, radiation, breast-conserving surgery, and endocrine treatment. If it is of a higher grade, then adjuvant chemo. Next, we go to luminal B breast cancers. And there are 2 types of luminal B breast cancers. One is HER2 negative. So that is ER positive, PR could be either ways, HER2 is negative, and there is a high Ki-67 index, more than 30%. The second is HER2 positive, where it's ER positive, PR could be positive or negative, but HER2 is also positive. Ki-67 could be anything. So between 2 of these, what is common? The ER is positive. I'm sorry, the circle is also going haywire. But in all luminal cancers, the ER is positive. And the difference between the 2 is that one has a high Ki-67 and is HER2 negative, but the other one is HER2 positive. Clinically, they are fortunately less common, but these patients are usually younger, could be BRCA2 positive. They grow slightly faster than luminal A, and prognosis is slightly worse. Pathologically, these are high grade, could be even lymph node positive, and do not have the well-differentiated subtypes that luminal A have. Imaging, let's see a few examples. This lady, mother had breast cancer at 82 years, but she just come for routine screening. And imagine we are seeing this large spiculated mass, which she did not come with a palpable lump. On ultrasound also, we can see a large irregular mass, and there's also a positive left axillary lymph node. We biopsied this, and this was ER positive, PR positive, HER2 negative, but a high Ki-67, and therefore a luminal B breast cancer. This lady, I'm jumping straight to MRI. Mammo and ultrasound showed complex cystic and solid masses, multiple. And on MR, we can see that it is multifocal, mixed solid and cystic masses, heterogeneous enhancement, as well as axillary lymphadenopathy. And this was multifocal invasive breast cancer, which was HER2 positive, as well as ER positive, and therefore luminal B breast cancer, which is HER2 positive. This lady came with a lump in the left breast. Interestingly, she had this lump, and on ultrasound also it is seen. We did a biopsy, which was ER positive, HER2 equivocal, and that is why FISH testing was done, which was negative. Ki-67 was high, so this was a luminal B breast cancer, which was HER2 negative. Because of the Ki-67, she's in luminal B. Her sentinel lymph nodes were negative at the time of surgery. She did BCT, chemo, radiation, and was on endocrine treatment. So this was her initial cancer. She followed up 2 years later, and everything looks hunky-dory. These are just post-BCT changes. And then she comes 4 years later, and anybody can see anything? Something peeping out of the axilla. So there was a new left axillary lymph node. Remember, her sentinel lymph nodes were negative when the surgery was done 4 years back. On ultrasound, these lymph nodes are seen one is between the pectoralis major and minor. Those are called as Rotter's lymph nodes. They are also considered level 2. And one more here, which is medial to the pectoralis minor muscle, which is a level medial to the pectoralis minor is level 3 axillary lymph node. So we biopsied this. Oh, sorry, before that they did a PET CT, and the reason for doing PET CT was to confirm that there is nothing else that is enhancing or showing uptake in the breast, which we are missing on mammo or ultrasound in the conserved breast. So that just showed lymph nodes and nothing else in the breast. So we biopsied this lymph node, and this turned out to be metastatic breast cancer. Very interestingly, HER2 positive. So she was HER2 negative 4 years back, but she has come up with a recurrence in the lymph nodes, which is HER2 positive. The reason for this variability could be many. One of them could be tumor heterogeneity with sampling variability, but in our patient, even the entire mass was tested for HER2. Clonal evolution under therapy, like most of it is ER positive, but very little could be HER2, And what happens is when you give chemo and endocrine, all of that gets suppressed, but the HER2 part of it increases. Or it could be genetic alterations and true biologic changes in the tumor. So luminal B breast cancers are slightly worse than luminal A, often speculated multifocal with lymph nodes and a little nasty devil to have. They grow fast and mostly they have to be put on adjuvant chemo. If they are HER2 positive, then targeted therapy can also be given. Then we go on to the next one, which is HER2 enriched. And I really miss Dr. Anita Borges, who is no more with us, but all the histopathology in all my patients have been done by her. Anyway, this is HER2 enriched tumor, which is ER negative, PR negative, and HER2 positive. These are fortunately less common. They are very aggressive and have a rapid growth, worse prognosis with a high risk of relapse. The thing is that very often they are multifocal, multicentric, but with associated DCIS. They are larger tumors at presentation. They are not going to, they literally present as palpable lumps, not incidentally detected on mammography. Because of the DCIS, they often have microcalcifications, which is a common distinguishing feature of these HER2 positive cancers. And they show non-mass areas on ultrasound and non-mass enhancement on MR. So look at this patient, has come with a palpable lump, 47-year-old, and if you look at the magnified view, we not only see the irregular mass, but we see pleomorphic microcals in a segmental distribution. On ultrasound, we could see this mass, and we could see even outside of the mass ductal extension as well as microcals. This was biopsied and was ER-PR negative and HER2 positive. Remember, for calling it HER2 enriched, ER and PR have to be negative. This 44-year-old lump in the left breast, and you can see irregular masses, multiple regional and segmental microcals. So you see at presentation, this is already a widespread disease. On ultrasound, multiple masses, but what interestingly we see is this kind of ductal extension outside of the mass with microcals within. On biopsy, ER-PR negative, HER2 was equivocal, but FISH was positive, and this is an HER2 enriched tumor. You remember I told you about the patient with the left breast story who was luminal A, 2 foci, treated with breast conserving treatment, radiation, and was on endocrine treatment. Her right breast story, I promised I'll tell you after a few slides. The PET CT had shown no uptake. Remember, the surgeon didn't listen to us, and instead of MRI, did the PET CT. She comes back with a 1-year follow-up. She's completely asymptomatic. And what do we see on the right side? And let me compare it with her prior, where there were amorphous microcals, and now 1 year later, we see irregular lesions, indistinct margins, regional pleomorphic microcals, and of course, a big-ass lymph node. Sorry. So anyways, on ultrasound also, we can see an irregular mass and these duct-like extensions outside of the mass, like kind of non-mass outside of the mass, hard on elasto. Now they did an MRI. not when we first asked them to do. And this, oh, the whole movie is not there. But anyways, I can show you what MRI showed us. The index mass, that it was multifocal, that it showed us clumped, linear and segmental non-mass enhancement, and of course, the big A lymph node. This turned out to be an invasive breast carcinoma with DCIS, which showed comedonecrosis, which is again a bad type of DCIS to have. And the whole thing is cut, which shows that it was ER/PR negative and HER2 positive. Oh, there, it comes overlapping. So this was a HER2 enriched on the opposite side and luminal A on the left side. So HER2 enriched tumors are like this. They are large, irregular, multifocal, multicentric, and often show microcalc. So imagine next time you see a tumor, you're going to talk about histopathology to your referring physicians. When you see something like this, you can say, I think this is HER2 positive, and then let the pathologist correlate with you. So they grow rapidly and into ducts with microcalcs. They are really nasty devils to have. But the good thing is some of them respond very well to targeted therapy, and then they behave a little angelic. They can be given other treatment also. And we come to our last one, which is triple negative breast cancer. That means ER, PR, and HER2 negative. Unfortunately, these are seen in young women. Fortunately, they are not that common. They could be seen in patients with BRCA1 mutation. And these also very likely present as palpable lumps rather than incidentally detected on screening. And they have a high risk of local and distant recurrence. So pathology-wise, they are higher grade, and the problem is there's lower associated DCIS. So these cancers are in a rush to grow, bypassing the in situ stage of the tumor. Usually not otherwise specified, but sometimes associated with some specific subtypes. So on imaging, this is a great problem because they are deceptively very benign looking. They are in a hurry to growth, so they present as circumscribed masses, and they don't have microcalcs. So this lady, now she's 40 years old, mother had breast cancer at 50 years, sister had breast cancer at 35, and at the age of 40, she presents with a breast lump. She's sure she has breast cancer even before we look at her. But you can see even on tomo, it is so circumscribed and round. Of course, we can see a lymph node in the axilla. Look at it on ultrasound very carefully. It is a round mass, but we see these irregular microlobulations at its margin, very important, and we see this echogenic rind or peritumoral edema. There is no thin pseudocapsule surrounding the lesion. You remember what I told you about vascularity going straight inside, perpendicular to the mass? What is very interesting on elastography is that there is, because of the central necrosis, very often they have a cystic appearance. If your gains are not adjusted nicely, you would call it a complicated cyst with echoes and with posterior enhancement. It is because of the central necrosis that they have these posterior enhancement, but elastography shows us that it is peripherally hard. So that is where it is rapidly growing in size. and there's an axillary lymph node. We biopsied this, and it showed us an IBC with the areas of necrosis, which was triple negative breast cancer. This is your classic triple negative breast cancer. When we see something like this, please don't call it a fibroadenoma, or if you've called it a fibroadenoma before, and you find that in the follow-up it has increased in size, just don't ignore it and put it into 4A and biopsy it. This 30-year-old came with a lump in the breast, and what we see is one nice oval lesion and another nice oval lesion. But on tomosynthesis, we see a lot of microlobulations, and we would call it an irregular mass and another small circumscribed mass. This was for MRI because she was a young patient. We had to rule out multifocality. She also wanted to conserve the breast if possible. So on the fluid sequences, which are STIR and T2, we can see hyperintensity within the mass, and that is because of the necrotic tissue within the mass. There is no fat necrosis, it has a cystic appearance. That is because of the necrosis within the mass. And of course, on post-contrast, we see irregular rim enhancement. It was multifocal. All the masses show irregular rim enhancement, some even showing speculations, and there were positive axillary lymph nodes. And this was also triple negative breast cancer. So TNBC is like this, can appear circumscribed, but look out for microlobulations, absence of microcalcs, young patient, especially with family history of breast cancer, looking extremely angelic, but is the worst kind of cancer to have, grows very rapidly. And there are no receptors, so they are difficult to treat also. If it is even larger than 0.5 centimeters, the patient is usually put on neoadjuvant chemo initially to reduce the burden of surgery. So the molecular subtypes, in summary, luminal A breast cancer is the best kind of cancer, small, speculated, good prognosis, grow very slowly, easily detected. Luminal B, larger, grow a little more faster, may have lymph nodes, may be multifocal, but still not bad cancers to have. HER2 enriched, nasty with a lot of DCIS, easy to detect because of the microcalcs, and can be treated with targeted therapy. And TNBC, really the worst ones seen in young patients and are the nastiest of them all. With that, I thank you for your attention.
Thank you, ma'am, for such a wonderful session. Now I would like to call Dr. Anita Bajaj, ma'am, to felicitate our esteemed speaker.
And any questions for Dr. Bijal? I'm sure everybody has tons of questions to ask. Can be? Yes. So we can give over the mic. One of the residents can take the mic from there and pass it on if anybody wants to ask the question. Somebody in the second row. Pragya, can you take the mic?
Even on BIRADS, if you have any questions, I'm happy to answer. Yeah, now hands are up. That one turned out to be malignant.
Hello, ma'am. Ma'am, I just want to ask, you mentioned the ER status, HER2 positive, negative status. How much of it are we supposed to put on the report? Or is it like an unofficial thing for us to correlate? Or is it something we can put in our report? Or we can suggest it? Or
Repeat, what is your question?
ma'am, the histological subtypes, we are diving into that right now. So is it something for us to just know, or is it something to document in the report, or maybe suggest it, or maybe, you know?
So I had one more slide, which I did not show. 1 second. I thought I was going overboard, but can someone help me with this?
Yes.
Just go on to the slideshow. Yeah. So this integrated approach of imaging and molecular profiling enhances the accuracy of diagnosis with a paradigm shift in treatment approach. AJCC now includes the IHC also in grading it, but imaging, this is what we want, helps us in every stage, right from the initial detection to monitoring response to chemo. So initially also, if you see what looks like a fibroadenoma with say microlobulated margins, then you can say that it could be a fibroadenoma, but I can't rule out a triple negative breast cancer. Hence, don't put it on follow-up and instead biopsy it. So it is very important for us to communicate with our pathologists and also at the time of biopsy tell them, because first we used to do only ER-PR or 2. We never used to do KI67. Pehle to it was only ER-PR and everything was luminal cancers or not luminal cancers. Then HER2 came into the picture and then KI67 came.
Any more questions?
Fibroadenoma kind, and you said you will label it as BIRADS 3. Why? It had typical features of BIRADS 2.
Sorry.
So basically, you can call it BIRADS 2 only if you see either calcifications within it, number one, or number two is if there are multiple, bilateral, more than 3, at least 1 in each breast. And all of them are looking like that perfect oval in a parallel orientation. Because we cannot rule out a malignancy, a circumscribed malignancy. Besides triple negative, we also get medullary, mucinous, papillary cancers which look very well circumscribed.
So without calcification?
Without calcifications and without it being multiple. And if it's a younger age group, then we can suggest, if it's multiple and without calcifications, then we can say it's BIRADS 2. But if it's say a postmenopausal patient who comes with a lump and you see something like that, for the first time, you're going to put it as BIRADS 3. Follow it up at 6 months, 12 and 24 months.
Thank you.
No more questions? No more? Okay, thank you. Thank you for your attention.
Thank you so much. That's I'm very tired of this.
I'll ask somebody to come with me. Thank you.
Thank you, Bijal ma'am. It was great to have you here today. Now I would like to call Dr. Sunita Malade ma'am for the installation of new committee of Navi Mumbai IRIA.
Good morning, everyone. Let's get on with the installation ceremony for the new team of NMRRIA. So before we start that, a very happy Women's Day to all the women out here. More power to all of us. And there are a host of dignitaries I would like to call upon the stage. Dr. Jignesh Thakkar, past president of IRIA. Please come to the dais, sir. Dr. Samir Gandhi, past treasurer of IRIA and past secretary of MSB IRIA. I would like to invite Dr. Shailesh Sanghani to the dais. He is one of the main founder, secretary and past president of our NMRRIA and past president of MSB IRIA. I would like to invite Dr. Prashant Patil, immediate past president of MSB IRIA. Our very own Dr. Chetan Singhal, current treasurer of MSB IRIA, past treasurer and president of NMRRIA. Dr. Yogendra Mashilkar, Central Council member of MSB IRIA. Dr. Ashok Patel, is he here? Chetan? Dr. Ashok Patel? Dr. Ashok Patel, Executive Council member of MSB IRIA. Dr. Harish Shadapuri, MCR Secretary. So before we get on with the installation ceremony, as the outgoing secretary of NMRRIA 2024-26, I would like to enumerate the activities which were done by our committee in the past 2 years. So we did a day-to-day ultrasound on CME in Apollo, followed by a Raksha event at Panvel. There was an orphanage in Panvel in which we did donation and Raksha event. A very well-attended and well-enjoyed picnic at Karjat. Women's Day celebration last year was done at Wonders Park, along with a donation to Minatai Thakre Hospital. New mothers were given donations. There's an echo, no? So okay. CME was performed at Terna Hospital on musculoskeletal ultrasound. Also, Ultrafest 2024-25, local host team was NMRRIA with ground support. We also did a PCP and DT CME along with NMMC at DY Patil Auditorium in Feb 2005. So now I would like to invite Dr. Shailesh Sanghani sir to felicitate Dr. Jignesh Thakkar. Dr. Chetan Singhal to felicitate Dr. Samir Gandhi. Dr. Vivek Jagtap. Dr. Vivek Jagtap to felicitate Dr. Dr. Shailesh Sanghani. Dr. Anita Bajaj to felicitate Dr. Prashant Patil. Dr. Sunita Malladi to felicitate Dr. Chetan Singhal. Dr. Chetan Singhal to felicitate Dr. Yogendra Mashilkar. Dr. Vivek Jagtap to felicitate Dr. Ashok Patel. Dr. Chetan Singhal to felicitate Dr. Harish Shadaburi. I would like to invite Dr. Ashok Patil sir and Dr. Lakshman Thadani sir on the dais. Dr. Patil sir and Dr. Thadani both are of Navi, Mumbai and founder presidents of NMR-RIA. Dr. Patil sir was also the election officer of recently conducted elections of NMR-RIA. I request Dr. Patil sir to announce the results of 2026-28 committee elections.
Very good afternoon. At the onset, I will all best wishes for today's International Women's Day to all our lady radiologists. It was a great privilege to be an election officer for our team. Election means everybody is scared, but this time it was very easy for me as an election officer. So I would like to invite the two new members of the team for 2026-28. President Dr. Vivek Jagtap. Then Vice President Dr. Ravindra Patil Ghuge and Dr. Sunita Malladi. Then Secretary Dr. Anita Bajaj. Joint Secretaries Dr. Shilpa Berry and Dr. Saurabh Patil. Very important post, Treasurer Dr. Murdula Babar. And now Executive Council members, Dr. Advait Takle, has not come, I think. Dr. Ankita Mehta, then Dr. Asim Patel, Dr. Chetan Khadke, Dr. Pradeep Atkari, and Dr. Swati Pawar. Total 13 numbers है so far. एक दो नहीं है, मेरी नहीं है, हाँ है सब. अभी क्या करना है? हाँ? ना 13 चाहिए, एक कम. मेरी नहीं है, एक कम, एक कौन? एक कम, एक कौन कम? मेरी नहीं है. चांगले बनवलेत पण हो गया संभल और बाकी है ना एक फोटो ले लेंगे ग्रुप का एक फोटो लेंगे एक मिनट हाँ
Bajaj to share her vision on for the.
So this is one of the first of the many activities we have planned. We planned more academic fees, then lot of fun also.
So last week our cricket team won the ARM box cricket tournament held in Mumbai on 1st March 2026. I request the team members to join us on the dais. Dr. Ravindra Patil, the most valuable player. And finally the team member, mentor apparently, Dr. Chetan Singhal.
We have to give also big clause of applause to Ashok Patel, who has, and Samir Gandhi sir, who has mentored the Mumbai team in organizing this RMPL. And of course, our past president, immediate past president, Prashant Patil, who had given immense inputs and help in every of these events.
I just hope India lifts another trophy tonight.
Yes. We'll carry on with the program now.
We now move on to the panel discussion in breast imaging with our esteemed senior consultant, Dr. Smriti Jha ma'am, and consultant Dr. Prabha Ranjana ma'am as the moderators. We will be proceeding with a rapid round of questions for our esteemed panelists, where experience meets practical decision making. I'm sure this is going to be an insightful, dynamic, and thought-provoking session.
Respected seniors and friends, I am Dr. Rajkumar, President-elect MHA. Join us for the Global Cardiologist Conference at Geo Convention Center, Mumbai, India.
प्ले करना ठीक से
Now I would like to call Dr. Sabita Desai ma'am, Dr. Neeta Nair ma'am, Dr. Veena Vanere ma'am, and Dr. Anita ma'am.
You can sit there. Yeah.
कुछ बोलिएगा मैडम, बीच बीच में कुछ बोलते जाइएगा. We'll start. Thank you, ma'am, for being here. It was a beautiful session in the morning. Few of the questions are already nicely, beautifully said by ma'am, Bijal ma'am, Savita ma'am. Now we'll move ahead with the questions. We are seeing a noticeable rise in both breast cancer cases and inflammatory breast conditions like IgM as compared to the past. Is this a true increase in incidence, or are we simply detecting more because of improved imaging and awareness? What factors do you think is driving?
So I think it's a combination of both. So yes, we are seeing more because women are more aware. There's a lot more early detection that happens. People come in for opportunistic screening. But we are also seeing a rise in incidence because we are seeing certain risk factors increase. If you look at your inflammatory lesions like IgM, it's all stress related. So when you have higher stress, more inflammatory responses in the breast, you do get options of IgM. You do have patients who come up. We keep telling our patients on follow-up also that what's going to trigger it is the stress response in your body. Similarly, the cancers that we're seeing, and there's a lot of data that's come up now which tells us the stress, lack of sleep, these are actually risk factors, and all of this is because of your cortisol circulating in your body, the inflammatory response that you get, the fact that we are all gaining weight, and I mean, don't look at Anita, but for the rest of us, that's also a concern.
Okay.
So I'm going to say it's a combination of both, but is I think where we are able to intervene better now.
Okay, ma'am. So are we seeing a shift towards the younger age group in both malignant and inflammatory breast disease, ma'am?
So actually no. So what we are seeing is our population's younger. We have a very wide-based young population. So what we are seeing is in these, our denominator is wider, because of which that numerator looks like it's a lot more. But percentage-wise, cancer is still more common among the older women. So if you look at percentage of numerator versus denominator, it's always going to be higher among older women. But because we have a very wide base of young women, our numbers of young women look higher.
Ma'am, what is your perspective, Savita ma'am?
I think I agree with her.
I wanted to just barge in, like, is last 15-20 years, is there any change in the pattern of presentation amongst the young? By young, I mean maybe less than 40-45. Is there any change in the pattern how they are presenting due to multiple reasons? May it be like increase in the stress, as you said, or maybe, you know, it's a general attitude. People, they are like, ki ye to chalega hi aisa types karke, which actually we may just. So is there any, does that, like, is there last 10 years or something, has there been any change in the how people present?
So one is there's more understanding of breast cancer. We are able to detect things a little better. I think technology in terms of what you all are able to do radiologically is improved. So if you look at it, when you look at screening studies, right? So even if you look at the age trial, which was women between 40 to 50 being screened, the cancers that have been picked up are women in their 50s.
Okay.
So it's not that the cancers that got picked up were between 40 and 50. And once you are in the UK, everyone from 50 goes into the NHS screening model. So it's between 40 and 50 is what the trial group was, and the higher incidence of cancer was still above 50. Which is why all your screening modalities also show you a better reduction of mortality, better pickup, better downstaging in young, older women. It's always above 50. And it's not just because these are dense breasts, these are, you know, other modalities required. A lot of it is because of the base incidence. So older you are, more cancer. The thing with younger women is, and I'm actually very grateful for that, is because of awareness, we are now picking up younger women with early cancers, which used to be something we never saw. Because everyone just assumed she's young, it's not cancer, don't chase it. Now, because everybody from the healthcare professionals to the women in society who are aware, women come in now with early cancers. And I can tell you this, and I'm going to show one or two of those slides. In the last week, we have 4 women between the age of 29 to 31, all with sub-centimeter lesions that are positive. You know, and one is the screen detected. I was like, I can't feel it, I'm glad you can.
True, agree. Absolutely. So, as rightly said, there is a increase in incidence because there is more increase in the awareness as well as the detection. I mean, more and more ladies are coming forward and getting preventive health checks done, and we are able to detect more subcentimetric lesions there. So that's why maybe the
Yeah,
incidence
you are
is
right.
more.
Health checks are.
And one more thing, and I wanted to ask you, Veena, Lord, sometimes when we do a biopsy, we are using a large bore needle, like a 12 gauge for stereo, 14 gauge for ultrasound guided photo, which are good chunks.
Yes.
But still, sometimes we see that the histopath which came out from a breast biopsy that we did and the final histopath report, there's certain discrepancy. How do you explain that? We are baffled sometimes. What happened?
Can we have the next questions over there?
We have tried to target we really work hard to target the most suspicious area.
So I cannot say it as a sampling error, but most of the times what happens is the core, when it is a tissue which is fresh when we sample, and when it gets fixed, there is a little bit amount of 5 to 10% of shrinkage of the tissue also. And if we sample like a combined fibrosis and fat density tissue along with the main lesion, then there the main target area could be little less compared to what is being sampled at the procedure level.
Do regional or urban lifestyle transitions contribute significantly to the rise?
For sure, because it's changing women having children late, breastfeed for shorter times, you have higher stress, you don't eat as well. So for sure, I mean, that's where we're seeing the rise. So if you look at it, there's this beautiful paper which came from the African subcontinent. It was a very old paper by an epidemiologist in the US. And she showed a graph which said that if you look at women in Africa and they have children early, they breastfeed their children for 1 or 2 years, versus you look at the West and there's this sudden rise of cancer out of the difference in those lifestyle changes. So with breast cancer, you know that it's a 12% reduction or 4% reduction after 12 months of breastfeeding. With pregnancies after the age of 30.
So late pregnancies.
See, like a 2% rise per year in terms of incidence for every year that you delay your pregnancy. So these are things that we know out of old epidemiological data, and obviously the fact that we, as trying to westernize our lifestyles, urban lifestyles that we have, we are adapting to that and increasing our risks.
So you mean delayed, the same questions, again, the delayed marriage, first, late pregnancy, reduced breastfeeding are the contributing factors. All right. So now, is obesity and metabolic syndrome playing a larger role in inflammatory breast conditions that we previously recognized?
Again, the answers to that is yes, and I'm not going to tell you that this is new data. We've known this for years, that obesity causes an inflammation. It's like a crown that forms, and this is a beautiful thing that came out of some pathology data. Let me try this. So
there's one more mic.
We don't want
it's echoing.
Yeah. Hello.
So what ends up happening is there is data from old pathology studies again, which tells us that when you have a lot of obesity, the adipose tissue starts forming a crown because it starts dying.
Okay.
The amount of vascularity reaching it. So and it forms this crown of tissue around it. And this happens in the breast very easily because you're seeing a lot of hormonal changes also. And once you go into menopause, all that additional fat that you have is still secreting hormone. It's your source of hormone. So all that fat starts forming these crown cells and increases your risk of developing different cancers. So this is not new data, it's just that we're seeing more obesity because that's becoming the new, let's say, pandemic of the world. And we are actually now, because of that, recognizing it as a very important risk factor.
Okay. Again, are oral contraceptives, HRT, fertility treatments are influencing this trend?
Yes, definitely. Yes, I would say definitely, because these are all hormones which contribute to increasing the risk of breast cancer, especially patients who are on fertility treatments, right? They have multiple IVF cycles. It doesn't stop at one cycle, maybe 1, 2, 3. So you are definitely pumping hormones into the girls. So definitely yes.
Yes, ma'am. We have recently a positive HRT patient, which
That's why before patient begins the HRT, we do a baseline mammogram and baseline ultrasound, and we follow her up very closely to look
How
for.
closely do you suggest for the HRT?
I think we do it every year.
Okay. Okay, fine. So has increased awareness among women and primary physician lead to more referrals and therefore higher case detections?
So I think
Yes,
this is
it's
more or less what
it's
we've
there.
answered.
Yes, ma'am. Yes, ma'am. Is a BIRADS 3 lesion truly a problem-solving category that safely reduces unnecessarily biopsies and allows short interval follow-up, or does it sometimes creates problematic delay in definitive diagnosis and increase patient anxiety?
So I'm going to say that, the problem with the BIRADS 3 lesion is, as politely as possible, the radiologist sitting on the fence. If it's palpable, clinico-radiological,
Ma'am, you speak as such, I think.
I'll be loud enough.
Yes,
don't
yes,
worry.
yes.
So, clinico-radiological concordance, discordance in a palpable lesion is easy for us to then, sort of decide, does this really need problem solving? So, something I really like what Dr. Bijal said was that, TNBCs look like fibroadenomas to untrained eyes. So, I always tell GPs this, that if you examined her and it didn't move like a fibroadenoma, even if your radiologist called it a fibroadenoma, get a biopsy done. So for palpable lesions, BIRADS 3, we do a little bit of clinical correlation. It's not necessarily something that will always delay diagnosis and treatment. It is the impalpable lesions where we are totally dependent on the radiologist. There, I'm going to say that it's a two-way street. It's not like you all are able to magically tell us that, this looks suspicious for sure. It is ambiguous. That's why it's BIRADS 3. The point is, the onus then lies on both the patient and the surgeon to be able to do close follow-up. That if there is something changing in character, and I don't think I would call that delay in definitive diagnosis, or we look at additional modalities. So do you need an MRI for that patient? Do you need a CEDM for that patient? Do you need something else to call that downstage that or downgrade that to a BIRADS 2? Is a conversation I would say would depend on her family history, her risk, her age, her other risk factors. So if you tell me she's a nulliparous lady with a BIRADS 3 lesion, I'm going to say that that's something I may want to get an MRI done on because I know her risk is higher. So the case that Dr. Bijal put up again, where there was a mother, a sister, or somebody, I don't care whether that looks amorphous. I want that calcification biopsy. Her risk is just that much higher. So it's always clinico-radiological correlation, and I'm going to say that these are not delays of diagnosis. These are ambiguity of us needing to be able to correlate two things together.
And how often?
BIRADS 3 lesion, if you feel that you're going to lose that patient to follow up, then this patient is from some remote place, you think she's not going to come back, please go ahead. And there are 3 conditions in BIRADS 3 lesions where you need to go and biopsy. One is this condition, if you feel strongly that you think she's not going to come back, please go ahead and do it. Family history of breast cancer, if she's a BRCA, please go ahead and biopsy. And third is if the patient is anxious or the clinician is anxious.
Ma'am, is there any size criteria? Is there any size criteria? Suppose we see 1 centimeter lesion, which with the lobulated margins.
I think I would go for the morphology that size is not important. In a sense, when you are looking at the morphology, is very important. That's why Dr. Bijol said when you're looking at the fibroadenoma, look at all the margins. Look at that pseudocapsule, that white thin line. If you feel anywhere the margin is little indistinct, then you go for the worst scenario and go ahead and biopsy it.
In a middle-aged or postmenopausal woman presenting with a newly detected breast lump that appears benign on imaging, can we confidently level it as a breast BIRADS 2, 3, or should we lean towards BIRADS 4A? Again, there is no size criteria as you mentioned.
Another important thing which I always tell my residents is always look at the images, not only reports. Look at the previous images. There may have been, because postmenopausal, you don't get lumps in postmenopausal, even if they look like fibroadenomas. If she's done a mammogram before, an ultrasound before, it's normal. And then she comes to you, maybe after a year or two, and you see a lesion which has come up, you're not going to leave it alone. You have to go ahead and do a good biopsy.
We should target biopsy immediately for a middle age. This fibroadenoma
even if they look like a very benign, as
even
mentioned.
if it looks like a benign, I would say that.
So I want to tell you, any new lesion, exactly.
Yes.
So it's as simple as you get lesions in the breast which are either hormonal, infective, or cancer. It doesn't look infective. She doesn't have hormones. You need to biopsy this
Right.
to rule out cancer. It's that simple.
Yes.
And one thing I would ask you, Veena, how confident pathology can be of a fibroadenoma? I know there are grey zones there as well. So what do you, how do you, we can help, how we can, collaborate together to get into the final thing? So what there are still grey zones?
Fibroadenoma versus a malignancy?
Yes.
So fibroadenomas are like a very distinct, have a epithelial and a stromal component.
What I'm asking is, can in a fibroadenoma, which if we look like a classical fibroadenoma, in histopath also, are there entities where you get fixed features, where it can be confusing whether it's a fibroadenoma or it's equivocal or it's some.
So cellular fibroadenomas can sometimes be deceptive, where the epithelial component is more malignant, and there is versus a desmoplastic tumor where there is lot of desmoplasia which can mimic as a stromal component of a fibroadenoma. So in those cases we need to definitely correlate with the radiological findings, the kind of lesion, the margins, the borders of the lesions, how they are radiologically, are they well circumscribed and all. So, and some immunos can help us, but definitely there can be, dilemma in diagnosis.
What's another important thing is whenever you do biopsies, see that you record, you take an image when you're doing the biopsy. Because you have it on record that you have done the biopsy from the right place. We always take a pre-fire and a post-fire and keep it on record. So we know that we biopsy from, sometimes when you do the scan and you see areas of necrosis, you know which area to avoid. You go from the area where you're seeing more hypoechoic, where it's more uniform. But please document your biopsies. Take images too. Even if there's any question in future, you're talking to your pathologist, you show them, yes, I biopsied it from this space. Was it enough?
So Veena ma'am, do you just want BIRADS to be written on the paper, or you want the entire descriptive form to make a diagnosis on the paper?
No, of course the descriptive. I'm having this habit to go through the entire description of the report, because it definitely gives us the pictographical image of the lesion, as to the margins, as to the contents, as to the heterogeneity, hypoechoic, ecogenicity of the lesion, and of course the size and the solid cystic component, and definitely it has a lot of meaning, rather than just the BIRADS score.
Yes.
I always write it like a mini ultrasound report only. It is.
Same.
Yeah, we give we give the
So
copies.
it's very helpful.
Yeah.
It's very helpful.
And if any other study also.
Yes, it's very helpful, always.
Wants to know.
Yes.
What is the background? What
kind of lesion hai, everything.
Usually write the entire thing.
It's very helpful always, ma'am. Yeah.
Yes.
When imaging strongly suggests a probably benign lesion, BIRADS 3, but histopathology shows borderline or atypical features, how should we reconcile radiological pathological discordance? It's a, okay.
Excision may be wider sampling with the excision.
Rebiopsy we don't. Just go.
So that has to be your patient's decision. So I think what would happen is what we'll be able to talk to her in the clinic about is that there's something there. We need more sample of tissue. Now you try telling a patient that I want to do this one more time and it may one more time come back atypical, then I use an excision. Most of them will opt for the excision.
First only if it's a BIRADS 3, that means there is something.
Yeah, I mean, there is a reason we biopsy.
Yes,
And
yes.
then there is a suspicion raised. Better to just go ahead and just get it. Absolutely.
So it's excision biopsy then.
So basically, what I'm getting is, in case of breast imaging, take-home messages are on the side of caution. Be more aggressive.
So I'm going to say that that's the easier answer. Aggression is, in terms of that, it's like she said, if your patient is someone who is going to come back, she's going to follow up.
Hello? Yeah, can you?
Better about it. So it's a BIRADS 3 lesion. She's going to come for follow-up. You know that she's not going to get lost. She'll come every month and get an ultrasound done with you. Then you may want to do that. Versus, and there's very little in the description that raises the suspicion that pathology is picking up, right? And even pathology showing atypical features may not necessarily always be cancer-related atypical features. It can just be cellularity, it can be adenosis, which looks a little different. So sclerosing adenosis is something we'd probably want to go and operate. Atypical ductal hyperplasia, we'd probably want to go in and operate. But most other things, we'll be like, if you're going to stay on follow-up, I'm okay for you to keep seeing us every month. Clinically and radiologically, intervene early. The same thing if you have someone who you don't know whether she's going to come back, whether she's understood the gravity of the need for follow-up, or the pathologist raises concerns like ADH in the sample, LCIS in the sample, then we are going to look at additional sampling or excision.
Despite the increasing preference for true-cut biopsy in breast imaging, FNAC continues to be widely used. Considering its lower diagnostic yields and limitation in histological assessment, should FNAC still have a role in breast lesion evaluation, or should core biopsy be the standard approach?
Unfortunately, as a clinician and someone who's worked on the guidelines, I'm going to tell you that we have been appealing to all clinicians to stop asking for an FNAC.
Yes, ma'am.
It is a completely senseless investigation in today's day and age. You can FNA a lymph node if you want to prove metastatic or non-metastatic. Core today for a breast lump has no meaning in clinic.
Even for the IgM,
for
even
anything,
if you get the pus
anything.
aspirates.
I need, even to prove IgM, I need you to biopsy the wall and tell me that yes, there is granulomas in that. And FNA is just going to tell me atypical cells. Atypical cells mean nothing to me. So when you ask, so we see, my boss used to say this earlier, a lot of people have a habit of aspirating cysts and sending that fluid to pathology. Yeah, so that's the thing, right? And all atypical cells, and Veena can tell you that, will look swollen, all cystic fluid. It just looks swollen. So it'll look atypical. So she'll say atypical looking cells. I need a biopsy of that wall. I need you to tell me that there is something in that which has larger chunks of tissue that have come out. And if it's malignant, there are 100 other things that I need from the biopsy report, which cannot come from the FNAC. So,
It's a wasted investigation in today and age.
Yes, ma'am. I purposely made this slide to understand biopsy because we also get FNAC. The doctor has asked FNAC, do FNAC. So
I feel today's era, FNAC is a wasteful, investigation, and we are just wasting one more chance. With the biopsy, we can get lot of information like the cytomorphology. We can do molecular testings. We can do IHC. We can understand the hormonal profile of the disease. Of course, benign versus malignant also, but it's just a wasteful procedure, I suppose.
Breast, yes,
Yeah, in breast. Yeah.
In cases reported as a atypical ductal hyperplasia on core biopsy, what percentage are upgraded to malignancy on excision in your experience, ma'am?
Part of it Meena can answer, but it's about 15 to 20%, and it's going to depend on other features also. So it's the radiological evaluation, and whether there was something more on radiology which was suspicious, then that ADH may upgrade in about 20 to 25%, but otherwise it's usually about 15%.
Yeah, of course. So if there is a malignant lesion which is not sampled by any chance, but we are getting an ADH in the biopsy, what we have in the sample material, so there are chances because it's a developing lesion. So a malignancy can have surrounding areas with ADH.
So again, you go for the excision technique.
I think most of us would excise.
Okay. All right. When pathology reports, yes. Yeah, so yeah, it's excision only.
There's a big topic of rad-pad
Discordance, yes, ma'am.
So whenever we do a biopsy, your report is not complete till you. So what we do is we always talk to the pathologist the next day. What was it? Was the sample sufficient? And then you go back to your imaging features and see whether there's a concordance or a discordance. That's very important.
In breast diagnosis, which carries the greater weight, morphology on imaging or microscopic architecture on pathology? So it's a both. For you also, ma'am, Veena ma'am.
Both, yes, both.
For us, only radiology. and I guess breast, of course, ma'am, your clinical. For us also, your clinical judgment is also.
Most of the times it goes hand in hand.
So is there any research currently to prevent breast cancer? Do we see a realistic possibility in future of a preventing vaccine or even a complete eradication of it?
So I don't think there's any work on a vaccine in terms of prevention. There is some work going on a vaccine which is treatment related, and it's, I think, targeting triple negative breast cancers. The only vaccine which talks about, today we have only one vaccine for cancer, and that's HPV for cervical cancers. The other vaccine, of course, there's a lot of talk about the Russian vaccine, which has had no trials, but is available to the Russian population. There's absolutely no data available for us on that.
Is male breast cancer truly a rare entity or it is underdiagnosed? What is the clinical significance of gynecomastia in male, and does it require routine follow-up? What is the modality of choice then?
So gynecomastia you see in young adolescent boys. That is because of sudden increase in estrogen, and then testosterone takes over, and then it settles down. So the second time it happens is when the men get older. But if a young patient comes to you, what the ACR appropriateness criteria says, the imaging modality of choice is ultrasound. So very commonly you see gynecomastia in these young adolescent boys. Having said that, if an elderly male comes to you, the first thing you need to do is a mammogram. Of course, clinically, even if they say they will clinically see and say, okay, this is gynecomastia, but first is to do a bilateral mammogram and look at the lesion in respect to the nipple. If it is subareolar central and you can see glandular tissue, rest assured that you know that you're dealing with gynecomastia. But if you see a mass which is eccentric to the nipple, because now it's a very big topic, so let me explain. Because there is no terminal ductal, there is no progesterone in the males, right? So there's no development of terminal ductal lobular units. So you'll see, very rarely you'll see cysts and fibroadenomas in male. So if there is a mass which looks circumscribed in a male breast, you have to go ahead and biopsy it to rule out a male breast cancer. Gynecomastia is BIRADS 2 benign. Many times these elderly men come to you and they are very scared. You do your imaging, and if you see gynecomastia, you assure him. Ask him if he's taking any anti-hypertensive, because most of them have this spironolactone, can cause gynecomastia. You reassure him and tell him there's nothing wrong. But yes, you have to do imaging in an elderly patient who comes with a breast lump.
And how often, if at all,
As I said, young patients, ultrasound. Older patients do a bilateral mammogram.
Ma'am, one question. Does gynecomastia in young males, does it have any correlation with them having those supplements they get in the gym? Because somehow this is the few males which have
yes.
That has been one common factor. I don't know whether it actually...
Anecdotal, no.
No, no?
It's more hormonal. Gynecomastia is more hormonal driven rather than this. But all they need is reassurance. Even adolescent boys come to you, it'll settle down. It eventually settles down.
Okay. So, ma'am, my question is like, what is the role of MRI in breast screening? Number one, in normal population high risk, and just what do you mean? First thing is, when we say high risk population from breast point of view, what do you mean by that? Dr. Savita ma'am or Dr. Neeta Nair ma'am?
Family history of breast cancer, if there is, and I think younger than 30 years, you're not going to subject the patient to mammogram. So I think there is in the protocol, you can do a baseline MRI for these girls. And with ultrasound, no, not mammo is after 40. Yeah, MRI. Yes, MRI and ultrasound.
Okay, so high risk includes just the age or
age, family history, BRCA genes.
And?
BRCA gene positive.
Anything else?
No, yeah.
Implants. Okay, no problem. So coming to the...
So what I'm going to tell you is that in the normal population, we don't want the use of MR to suddenly become the way that we screen with. But for a high risk or an average risk population, which is someone who either has significant family history, carries a genetic mutation. BRCA1 and 2 are not the only two mutations that we'd look at. There are at least about 22. Or someone who's had, breast cancer once and one is high risk with other mutations. We do expect to pick up more, and that's why we look at more sensitive modalities like an MR.
Okay. So for high-risk group, the screening should be how frequent? Once a year, once in 2 years?
So per the guidelines, if they carry a mutation, then it is every 6 months. And it does allow you to alternate with another imaging modality. So like she said, in a 30-year-old, you're not going to see anything on the mammo anyway. So what is the point of that? So could you do an ultrasound or do, an MR every 6 months? I'm going to tell you that that's a discussion that needs to happen with the patient. But for someone who is just got family history, doesn't carry the mutation, is young, I would do it once a year only.
Okay. Any group of patients in which it is once in 2 years? Because it increases, we say get a MRI done. We also have to realize that the number of MRI machines are limited and the load it puts on the machine.
And also it's an extremely, and your patients are not necessarily comfortable with getting an MR every time.
Absolutely.
So, and it's a much more expensive modality of therapy. So I think from the guidelines, everything that talks about screening for the mutation positives, unfortunately, still continues to say 6 months.
Okay.
So we've not reached, but there are these abbreviated protocols of MR, which now are coming in for once every 2 years. Yeah.
To that point, that is what I was looking for.
Yeah, so the abbreviated protocols is what now everyone's trying to sort of bring in, and it is a better modality in terms of a screening because it's quicker, it's less troublesome for them.
Okay. So this is the question.
No.
Is it? No. So in
I think it's very surgeon specific.
Very.
It's a lot of things. It's surgeon specific, it's tumor specific, it's breast density specific.
Surgeon specific, radiologist specific.
Everything specific.
And your relation with the...
Yeah, so I'll tell you, I'll tell you a very funny incident, and Palak is going to murder me for this. When Palak had just joined Tata, everything used to read, if planned for BCT, consider MRI.
Okay.
And I went back and told her, Madam, this is a medico-legal document. That patient does not require an MRI. If you put this down, and she gets a margin that's positive, which can happen in 1 to 2% patients, she's going to chase me, saying, why didn't you do the MRI? So there are very specific things where we would want to do it. Either if there's a dense breast, there's multifocality on routine imaging, then we would want it. Or if there is some radiological and clinical discordance, then we definitely ask for it. And there are certain subtypes, like for ILC, I would ask for it. If your patient, let's say, has a BRCA mutation, I would ask for it as my baseline.
So basically high-risk group, plus few of the cases if you want to see the multifocality, the multricity.
So everything comes
dense
under,
breast.
so when we used to tell students this is when you ask for it, clinico-radiological discordance. So dense breast, ILC, all of that comes under clinico-radiological discordance.
Okay, thank you. So, Dr. Neeta, so if the margin is positive, and Dr. Savita, Dr. Anita, anyone, like how soon should the MRI be done? Because this is actually a practical question.
Yeah, I mean, it's a very difficult answer to give you.
So that is why the question.
Yeah, so, so I'll tell you where this comes up. It's not necessarily so much in a margin positive, but it's very common. If your patient presented with nipple discharge, had nothing on the mammo ultrasound, and we didn't do an MR, and then when we go ahead and do a microdocectomy and it comes back as DCIS, then we are like, oops, now I need an MR to map this. The problem is you need it immediately prior to surgery to plan your surgery, but it's going to throw up artifacts and it's going to tell you a lot of noise which you can't answer.
So basically,
It will give you surprises. It will give you findings which are not there. So that's positive.
So basically what I'll tell you that the few cases which are in brain, for example, I'm just taking the example of brain. When the neurosurgeon does a surgery, supposing it's a GBM, almost impossible to take it out all the time. So the patient gets an MRI, first post-op MRI immediately as soon, because the post-op edema takes 48 hours or something like that to settle in that well. So in breast, the few cases which I have seen, very few.
Fortunately, pathology takes 10 days to come.
Dr. Sabita, any comments on that?
No,
Okay. Because the few cases I have done, edema has played havoc with my...
I think we should wait 2 to 3 weeks ideally, at least. Or you would say even more, 6 weeks.
No. 5, 6 weeks,
5,
nothing
6
going.
weeks. I know most of the people say 6 weeks is the time when.
6 to 8 weeks
Only
is like...
thing is the patient gets panicky, the relatives.
So, yes. So, okay. So in a recently, supposing biopsy has been done on ultrasound, unfortunately, instead of fibroadenoma, it comes out to be triple negative in and MRI, how much does the edema affect the MRI imaging? So we do the MRI. So any comments on the edema which is affecting? For example, the edema and the NME, at times, they can overlap, I've seen, in few of the cases.
Which cases would you want to do an MR after doing a...
Ma'am, it is there. For example,
like she says, it's multifocal.
it is multifocal, ma'am, or... And we didn't expect it. For example, a fibroadenoma, it is now like we are getting suspicious about it, but not very. So we do a biopsy after ultrasound. It comes out to be, say, triple negative, but we want to be like more
Because
sure.
triple negative is aggressive, some surgeons want.
And
but
there are multiple
I think
fibroadenomas, we do
it
MRI.
is again the biopsy is going to mask.
So these
the
questions,
findings.
basically, I have purposefully asked these questions because these questions are a very great going towards black zone for me. I am yet to get clear answer to that. Every single MRI is, like post-op MRI is tough battlefield.
And I think best is to speak to the surgeon.
Oh, trust me, I
Before
always,
doing it.
I always do that, and
But
I come back
see, there
wiser.
are cases we get from outside, being
No, so that's
Apollo.
what I'm saying.
So
You'll get a lot of cases, like what Prabha said, you get patients insisting on asking for an FAA. So you will get treated at other centers.
So
coming
in,
to you,
exactly.
Where and you won't even know who the operating or the clinician
Absolutely,
is. It doesn't, they don't always come to you saying that this clinician sent me.
So in-house, we can, I think, safely dodge it.
So foci smaller than 5 mm or MRI, they are not given much weightage. But like supposing something is 5 to 10 mm size, enhancing, supposing in right breast there is a mass lesion confirmed CA, supposing in some other quadrant, same breast or the other breast, we get something like 5 to 10 mm enhancing sort of mass lesion, sort of glandular tissue, we are not sure. And we are unable to see it on mammography, of course, and even ultrasound, they are not very convincing. So how do you go ahead about this?
This is a nightmare situation.
Ma'am, all my nightmares. I'm looking
Yeah, so I think the follow-up is the only option, close follow-up.
No, so I'll tell you that there are two concerns with this. If this is a patient who has a malignancy diagnosed, now when I want you to map disease for me, this 5 mm lesion will matter or 10 mm lesion will matter. If it's close to the lesion, I can still excise it, you know, if you can give me a distance from it. If it's in a different quadrant or in a contralateral breast, I unfortunately need this biopsied, because either don't ask for the MR if you're not going to act on it. And this is the biggest concern with diagnostic MRIs, is a higher probability of mastectomies. Because if you pick up additional lesions in other quadrants opposite breast, you have to chase them. It's very difficult for us as clinicians or you as radiologists to ignore that, saying we'll keep it on follow-up and we'll see, go ahead with the BCT. So that's the thing. So we've actually, I have had.
Even if you have to biopsy this 5 millimeter.
It's not easy on MR.
I'm sure it's definitely not easy, ma'am, but it is doable. We have done biopsy of even 4 mm and got positive results.
So I was actually at Athena yesterday with Jyoti, and Jyoti now biopsies all these lesions on MR because she has access to it. Yeah. Yeah. So there are maybe 3 centers in, that's the, if nobody's here, we have maybe 3 centers in Bombay that do MR guided biopsies. Yeah, so Tata does it, and I think Nanavati does it, and one more. Yeah. So we have to push to get that. Mera to rehne do.
Yes. 100%. Rightly said. Yeah.
Now this is open to house. Please, because this is absolutely no way, this is, I have not had any experience of AI. I have seen presentations on MRI, people have come to our place, but I have not used it regularly for at least not even for 1 month regular use. Like I've used it, I've seen it basically, not used it for the regular basis. Any idea? Any comments?
No, know about it.
In UK, for example, can you use it as a tool to help you, but it cannot be
It's an aid. I think it's an aid. It's about an aid. It's an additional aid that helps you.
Can help you. Does it bring about any medical legal issues or problems?
It's too early to say that as of now.
As doctors do, as radiologists in particular, what caution should we take, try to take if like AI comes? Because for mammo, at least the images which they are showing in presentations, they are like, wow, this is God's gift to humanity. It is
No.
not. Nothing ever is. So, it's still some time.
So I'll I'll tell you one example of AI that was circulating on all the WhatsApp groups, okay? So there's a mammo image saying that when the algorithm was fed with all the images, AI suggested in a normal mammogram that potentially here there was a high risk of breast cancer. Patient developed that 3 years later in that same area, right? So this was one of the early AI in screening proposals that had come up. The point is, all you did was create anxiety. Because till there is something that is biopsyable, it has no meaning for us, right? That's the first part. So AI alone can do nothing. It requires the human brain to work with it to make it clinically adaptable. So what I think where AI fits in any part of healthcare is as an additional aid for problem solving. But the initial bit has to be the clinician who has examined the patient, who has done the ultrasound, who can feel the way the tumor feels. The additional aspects of, whatever modalities of therapy we use, look at what the risk is by understanding what that patient's risk is. And it's never going to be just AI. Even for screening today, where the UK is trying to put it in as, because they don't have enough radiologists to screen and report screening mammos, they're trying to use the AI model. It still requires some radiologists to be involved in that. It's not yet just AI. So it's supposed to be, so which is why they're running out of people, and they're trying to use AI as one of those. Thank you.
Take it out from them, okay, and get it so that we also do better for the patients. Thank you.
So the academic feast continues. There are a lot of interesting talks a lot of interesting talks, case-based panel discussions. So please continue, and we'll just felicitate Veena. Dr. Smriti, you can do the honors. Dr. Veena is mic also. Dr. Sabita and Dr. Neeta are there now. So next talk is.
Thank you to all our distinguished panelists for sharing your experience so candidly and confidently. It was truly educational. The results for the lucky draw will be declared post-lunch, so do make sure to attend the post-lunch sessions.
Now I would like to call Prashant Patil sir to share his views.
Hello.
Is it working? Good afternoon, everyone. I will not take much time. So first of all, congratulations to the incoming President, Dr. Vivek Jagtap, and his team. He has done a wonderful job last year, and probably he will continue the same work with his team. And lucky to see Anita in new role as a secretary. Prudula will continue as the Lakshmi, or the treasurer of NMR, and the entire team. In this crowd, there is one person who is telling us learning does not stop. Guess who? Dr. Jyoti Chaubal. She is a national, international faculty. She is sitting here to learn something from here. She is teaching many students, delegates, radiologists all over the India, but today she is attending as a student. So that tells us that learning does not stop, and that is the best tribute to Happy International Women's Day. So taking this point, I would like to invite you. First of all, tell me how many you have registered for Global Ultra Fest 2026. Raise your hands. 40%, 60% still not. That is good for me, so I can tell you what is going on. So Global Ultra Fest 2026, the premium ultrasound conference of MSBRI. This year we are hosting in Joe World Convention Center, BKC, Mumbai. I'm very happy to say we have invited Dr. Carlos, Dr. Gratogos, the father figures of their own field, MSK and fetal medicine. They both are coming. And along with them, we have our own stalwarts, national and international faculty. Dr. Nitin Chobal is there, Dr. Ashok Khurana, Dr. Nidhi Bhatnagar, Bipin Shah, and many other people. You can go through the brochure, you can see everyone. The academic program is curated in such a way that you don't miss your lecture because of workshops. All the workshops are planned on 17th April, evening 6 to 8 p.m. There will be 11 workshops. You can opt only one because all the workshops will start at the same time. 8:30, we're starting the lectures. They probably end by 5 o'clock. And with a break, then we can start with the workshop. Workshops are only on the Friday. Friday is your MSK day with Carlo. We'll be spending a lot of time with Carlo, sir, and our own faculties. Saturday will be your fetus day, and you will be spending time with Gratogos and our own faculties. Sunday will be missed back because being a radiologist, we should know apart from radiology, apart from fetus, other part of radiology, so we are having Dopplers. Almost 23 workshops are there with demos. So I will request not to miss this conference because this is the learning process what will be continuing. So Vivek requested me to give something to us, and I will say last year UltraFest was hosted in New Bombay, and the success of UltraFest 2025 was because of 90%, I will say, because of Navi Mumbai chapter. Credit goes to Shailesh Sanghani sir, Vivek Jagtap, Chetan Singhal, Sunita, Rudola, and the entire team. And it was a very successful conference. And happy to see the same faces for my UltraFest also. So I'm very confident we will be much more successful. We have crossed 700 registration before 20th February. We are targeting 1,000 registrations. I will request all of you to please register for the conference. Send your papers and be part of this historical movement. Me and my entire team will be waiting at Joe World Convention Center to welcome you all. Thank you very much.
Thank you, sir. Now I would like to call Dr. Sabita ma'am back on the stage to share her expertise on the topic, unraveling breast pathologies in pregnancy and lactation.
Can you hear me? अभी और कुछ चालू नहीं है ना? So I hope the screen is visible there. Confirm. Screen is visible? And am I audible? So this is the Samsung R20 machine, and with a we are trying to we are doing a demo of breast. So it's a fantastic machine. So just to take over how we scan and how we document is, we scan all the 4 quadrants on both the sides. Then you go to the retroareolar region, scan the axilla, inframammary folds has to be seen properly, and in between both the breast, the central sternal area also needs to be scanned, because sometimes you never know, the lesions can be picked up at the edges. So it is very important to do a complete thorough scanning and not to miss out those areas which are kind of sometimes hidden. So you have to, while scanning any breast, you have to put a marker on so that you label exactly at what point it is, and what is the depth, which area are you scanning, and haath upar. The patient position will be hands up. We cannot show the patient, but that's how. And then so we go through. You can use your technique. Some people like to go around. Some people go up and down and then scan the patient, or side to side. So you use your technique, but don't miss out on any area. So here what your normal breast parenchyma you can see is, start from the skin. You can see the subcutaneous fat below. Can I have the marker? The arrow. So below that is the subcutaneous fat. Yeah. So yeah, that's better. Then these are the fat and the dense glandular tissues interspersed between the breast. The fat and the fibroglandular tissues that you can see. Then you can see it's not a very, very dense, but definitely a little dense breast. Try to see any areas, any asymmetry, any mass. So from skin right below to the chest wall, everything should be seen in the same plane, so that you should not miss out on any lesion. Then once you've scanned the entire breast, go on to the other side. You can use the harmonics for a better visualization if you see a cystic lesion. I've just turned on the harmonics and you can see the visibility. The ducts are so much better seen. Can you make that out? So the ducts are better seen when we turn on. Anything which is anechoic is much better seen. We can see the ducts just there. So any pathology there on the ducts can also be seen. We scan the retroareolar region completely. It has to be thoroughly checked below the nipple. So there's some bit, see, these are the few prominent ducts. Any inspissated secretion, any lesion needs to be picked up. You can put on color if there's. So this is just normal breast, but we'll show you many cases in the case-based panel discussions. Then we go to the axilla after scanning the entire breast, the retroareolar region, all the quadrant. The axilla needs to be, the marker on the axilla. Then we'll increase the depth a little so that you cover and here you can see the pectoralis, major and minor, and you can see where you can see the level of the nodes from here, as Dr. Bijal already explained. So these are normal reactive lymph nodes with maintained fatty hilum, good fatty hilum, no cortical thickening. These are absolutely normal. So that's how you go and scan the entire breast, and then start on the other side. Again, all the 4 quadrants needs to be scanned, and then the retroareolar region, the center, in between the sternal area also needs to be checked, just to the inframemory folds. These are things which should not be missed out. The axilla completely. And from outer to inner or inner to outer, or go in, some people like to go in a circle and scan it completely. So there is a subtle architectural distortion here. We'll have to evaluate it later with also do a mammo or something else. See, now I've just put on the harmonics. Yes. So this looks like they are well defined, 2 small lesions. See, yeah, much better seen now. Yeah, so that's the zoomed up image. Of course, we need more evaluation on these. So this is MV flow also. So if there's any enhanced vascularity or anything, that can be seen. But anyway, that looks pretty okay. The vascularity, and this is a well-defined lesion seen on both the views. And this is on the upper outer quadrant. So we'll follow up. Most likely it is a solitary thing. If we scan the other side and we see more lesions like that, then we label it as fibroadenoma. Even otherwise, now this will be a BIRADS 3 lesion. We'll follow it up. Check on mammogram also, ideally. How does it look like? Any calcifications anywhere? So that's how we scan. There are 1 or 2 other small cysts. And these are the ducts there, which are little prominent. However, they look okay. So I think that's about it. Any questions? We'll take it in between during the case-based panel discussion. Thank you.
Moving on, it is an honor to invite Dr. Savita Desai ma'am back on the stage to share her expertise on this topic, unraveling breast pathologies in pregnancy and lactation. May I kindly request you to take the stage, ma'am? Yeah, ma'am. Second one, no?
Yeah. Good afternoon. I know everyone's hypoglycemic and it's pre-lunch, but this is a topic which I think is very, very important and it's very close to my heart. So let's look at, so today I'm going to be speaking on breast pathologies in pregnancy and lactation. My favorite slides have all the information at hand before you do anything. Now this is going to be the contents of the talk. Now, what is the aim and goal when you scan a patient who is pregnant or lactating? Now, very important for us to remember that physiological changes that occur in the breast during pregnancy and lactation, they create a lot of challenges for breast cancer screening and diagnosis. Imaging evaluation should not be deferred because delayed diagnosis of pregnancy-associated breast cancer or PABC is associated with poor prognosis and advanced stage. Therefore, any palpable mass in a pregnant or lactating patient requires prompt evaluation with selection of the appropriate imaging modality and image-guided intervention. So what are the imaging modalities we have at hand? We have ultrasound, you have mammography shielding with the lead apron, there's MRI, and we have to talk about interventions in the breast. Now, ultrasound is the imaging modality of choice in patients who are pregnant or lactating or who present with breast lumps. Because of safety due to lack of ionizing radiation, interventions are done ultrasound guided. evaluation of axilla and the opposite breast, and serial ultrasounds in pregnant patients in evaluation of tumors with response to neoadjuvant chemotherapy. Now, this is a very frequently asked question: is mammography safe during pregnancy and lactation? Yes. They say that for mammography, the fetus is indirectly exposed to scattered radiation. The radiation dose to the breast from a 4-view mammogram is less than 3 milligray, and for a 4-view mammographic examination, the fetal radiation dose is less than 0.03 milligray. Now, in addition, you can use a lead apron to shield the uterus, which reduces the dose to about less by 50%. However, we do mammography only if there's a strong suspicion of malignancy or if malignancy has been proved by core needle biopsy. Is MR safe? Yes, MR can be safely performed during lactation, but not during pregnancy. This is because contrast-enhanced MRI is contraindicated in pregnancy because of the unknown risks associated with exposure to gadolinium-based contrast agent. That's because gadolinium chelates, they cross the placenta and have the potential for dissociation or into toxic free gadolinium ions. Now, interventions in the breast are usually done ultrasound guided. You will do either a ultrasound guided aspiration or a core needle biopsy. And what are the common complications? One is risk of bleeding, as the breast tissue is very vascular. Then you have bloody nipple discharge, which happens, but it's eventually reduces. You have to tell the patient that there may be bloody nipple discharge post-biopsy, milk fistula formation, infection. And these risks can be minimized by cessation of breastfeeding before the core biopsy and by paying close attention to hemostasis by maintaining strict asepsis. Now, when a patient comes to you with a new clinical concern, if she is pregnant, you first do an ultrasound. If it is negative or benign, you put her on follow-up. If you see that the findings are suspicious, you do a mammography, and if you put it in the BIRADS 4 or 5, you do a ultrasound-guided core biopsy. If a patient is lactating, if she's under 30 years of age, you do an ultrasound. The same thing you follow for what you have done for pregnant patients, and mammography with ultrasound. If you see any suspicion on the ultrasound, you do a core biopsy. These are the whole gamut of cases that you see and during pregnancy and lactation. I have quite a few cases. So what are the common things that you see? Breast disorders closely related to physiologic changes. You can see inflammatory and infectious diseases, mastopathic disease. You can see benign tumors, morphologic and physiologic changes that happen in fibroadenoma secondary to pregnancy and lactation, and you can see malignant tumors. We all have to be very, very aware of this, that there are a lot of physical changes that happen in the breast during pregnancy and lactation, and you have to be well versed with these changes. Now, this is because during pregnancy and lactation, changes in the serum levels of estrogen, progesterone, and prolactin, they result in physiological changes in the architecture of breast, and hence, clinically and radiologically, the breasts during pregnancy and lactation can be very challenging. Now, there is conversion of breast tissue from proliferative state in pregnancy to secretory phase. So during early pregnancy, from isoechoic, the breast tissue becomes hypoechoic as lactational changes fill the acini with secretions. In the lactational, that is in the secretory phase, it becomes more hyperechoic. That is because of increased vascularity and prominence of the ducts. Now let's look at lots of cases, and I hope this will help you in your day-to-day practice. 26-year-old lady lactating presents with a lump in the left breast. Now I always put these descriptors here. You heard some excellent talks in the morning. So whenever you're describing anything, just write this, put this all down on paper so you know what you're dealing with. So here you're seeing an oval, circumscribed margins, parallel orientation. It's hyperechoic. There are dilated ducts. Now this is the commonest lesion seen in the breast is a galactosele. Here is a 29-year-old, she's lactating, presents with a tender lump in the right breast, and you're seeing a cystic lesion with very fine echoes within. So your first thinking is, am I dealing with an infected galactosele? You put in a needle and aspirate and send it for culture and sensitivity. We did multiple aspirations, and this was an infected galactosele. Here is a patient who has just stopped lactating. There is a lump. I've never seen something like this, very odd looking. So you're seeing a hypoechoic area and a hyperechoic area. So just to know what I'm dealing with, I just did a representative mammogram, and this corresponds to, this yellow star corresponds to the fat which is seen, and the green star corresponds to the milk, which is the protein in the milk. So this was a galactosele. Now galactoseles are the most common benign breast lesions in lactating women. Milk is retained and stagnant when breastfeeding is stopped. This causes ductal dilatation and development of galactoseles. Now their appearance depends on the proportion of fat and water contents, and infection is a relatively common complication of galactoseles. Here was an interesting case. This lady, she's 40 years old, came for a routine mammogram, and what I'm seeing on the mammogram, I'm seeing accessory breast tissue in both axillary region. This one is looking fine, but what am I seeing in the left axillary region? Whenever you see something like this, you do what is called as an axillary tail view to understand, to delineate this lesion better. Now here you are seeing a fat containing lesion. There is fat within the lesion. There's a beautiful thin capsule around, and margins are circumscribed, it's oval. So you do a targeted ultrasound, and you're seeing a mass here which is hyperechoic and anechoic. This is a duct which was leading to an accessory nipple. So this was nothing but a pseudohamartoma or a chronic galactosele. Now, a common place for galactoseles to form is in the accessory breast tissue, in the axillary tail segment of the breast. Now, milk is not unable to drain from the accessory breast tissue, as there are no major ducts which connect the accessory tissue to the nipple. Pseudohamartomas or chronic galactoseles, they occur when galactoseles contain variable proportions of old milk and water, and the mass shows a mixed content closely resembling the features of a hamartoma. There is one condition which is called as the rusty pipe syndrome. Here, there is presence of blood in the breast milk, and it renders a rusty or brownish color. This is a self-limiting condition and may be noticed during pregnancy, but more commonly in early lactation. This rusty pipe syndrome occurs because of the increased vascularization of rapidly developing alveoli, which have delicate network of capillaries which get traumatized easily, and this causes bleeding from the nipples. But you have to be very, very alert and see, is this discharge spontaneous, single duct, or unilateral? Then you have to evaluate to rule out any malignancy. Then we come to infective and inflammatory diseases. 29-year-old lady, she's lactating, she presents with a tender lump in the left breast. I'm seeing a small cystic lesion here in the left breast with echoes, and there is an increased echogenicity of the surrounding fat over here. There is vascularity on color Doppler, and elastography revealed soft and hard areas. This was just inflammation of the fat lobules because of lactation. 35-year-old lactating lady presents with a lump and redness. We see this very commonly in our day-to-day practice. Thick wall cystic lesion, thick echoes. Additionally, what you're seeing, there is increased thickening of the overlying skin, increased echogenicity of the surrounding fat. Whenever you're looking at lesions, you have to look around. You know, what are the additional features that you're seeing along with this? There was peripheral vascularity on color Doppler. So what do? This is a breast abscess. You just put in a needle and aspirate the abscess. 35-year-old lady, again lactating. Now she had multiple abscesses. So I have put the star accordingly with the color. These were, and there's one large one which was near the retroareolar region. So what we did is you put in a needle, aspirate it, send it for culture and sensitivity. But this, because she had this many communicating abscesses, they had to do an incision and drainage. This is how we mark the areas where the abscesses are, give them the depth and distance from each other, so it is very easy for the surgeon. She just took a incision like this and she could drain out all the abscess. Post-drainage, she's doing quite well. Now, puerperal mastitis occurs in lactation. This is the most common form of mastitis and usually occurs from infection with Staph aureus or Streptococcus bacteria. Infection often arises from disruption to the skin surface of the nipple areola complex, and milk stasis is a risk for infection. How do you treat it? Aspirate the abscess under ultrasound guidance and send the pus for culture sensitivity and treat it accordingly with the appropriate antibiotic. This is a case which, if you have seen my earlier talk, this was a 32-year-old, 19 weeks pregnancy, and FNAC somewhere had said granulomatous mastitis. So we've seen this. This was idiopathic granulomatous mastitis. Important for us to see these heterogeneous masses and these tubular extensions which extend into the subcutaneous tissue. So idiopathic granulomastitis, also known as non-puerperal mastitis or granulomatous lobulomastitis, rare benign chronic inflammatory breast disease, described by Kessler and Woloch in 1972. Most cases of granulomatous lobulomastitis occur in women of reproductive age who have been pregnant at least once prior to presentation. Then we come to benign tumors. This is a lady who said she is lactating since 3 months, and she says, I can feel a lumpish feel and heaviness in the right breast. So whenever you see lesions like this, you always ask the patient, do you have any previous scans? She did not have any previous scans. So here you are seeing a mass which is oval, circumscribed, parallel orientation, hypoechoic, increased vascularity on color Doppler. If I had a previous scan, I would have been happy thinking that maybe these are just lactational changes in a fibroadenoma. Because there were no previous, okay, let me get back to that later. I just did a representation mammogram. You're seeing a high density mass over here. Margins are partially circumscribed and partially obscured by overlying glandular tissue. You can see this parenchyma, as I said, look at the breast parenchyma, it's hyperechoic because she is lactating. So because I have no earlier images, I give it a BIRADS category 4A. I'm not suspecting any less than 2% chances of malignancy, and this was a lactating adenoma. This patient came in 2022. She came after a year, and post 1 year after lactation almost. See, you can see this has come back to normal. Another case, lactational status with lump in the left breast. Here you're seeing a mass which is gently lobulated margins. You're seeing certain cystic areas. There is increased vascularity on color Doppler. We did a core biopsy, and this was a lactating adenoma. So lactating adenomas, they are benign breast lesions that occur in response to physiological changes during pregnancy and lactation. It is simply a variant of fibroadenoma or tubular adenoma that has undergone certain histologic change owing to the physiologic state. On imaging, they are indistinguishable from the fibroadenomas. Here is an interesting case. This is a 32-year-old young girl lactating. She presented with a lump in the right axilla. She said she hadn't noticed it earlier. Now, this looks very bizarre on ultrasound. So because she's 32, we first did an ultrasound and saw this mass, which is irregular, multiple lobulations, hypoechoic, cystic area. There's some foci of calcifications. I said, am I missing something? So we do one image of the mammogram, and I did the axillary tail view. And here we are seeing this mass, which has same multiple lobulations, foci. Now these are coarse calcifications, a little reassuring though, but all the same, this warranted a biopsy, and this was a lymphangioma. She came 1 year after post-cessation of lactation, and this had settled down. Now, lymphangiomas are benign lymphatic tumors which are developmental in origin and typically consist of dilated lymph channels lined by endothelium. This may be due to blockage of lymphatic channels with secondary dilatation, congenital weakness of the lymphatic wall, or proliferation of lymphatic vessels. Then we come to morphologic and physiologic changes in fibroadenomas, secondary to pregnancy or lactation. This is a 31-year-old, second trimester of pregnancy, came with a lump in the breast. Now she said, I had this lump before, but it had increased in size during her pregnancy. Now I'm seeing this mass over here, which is hypoechoic. Margins are quite angular. It has peripheral vascularity and it is soft. However, because of the angular margins, I said it is sensible, I must do a biopsy, and this was a fibroadenoma. All patients who are pregnant, they are very, very concerned. They say, if you do a biopsy, will it affect my baby? So I think I always do a before and after documentation of the cardiac activity. Another lady, 28-year-old, came with a lump in the right breast. This looks like a clover leaf, I thought, and extremely vascular. And you can see this was one of our old analog machines. We didn't have Tomo that time. You're seeing the mass over here at 12 o'clock position. This is superiorly. She refused a biopsy. They did an excision biopsy. This was a fibroadenoma with secretory hyperplasia. So morphologic and physiologic changes in fibroadenomas, secondary to pregnancy and lactation, we do see them. Fibroadenomas are tumors which are commonly found in pregnancy or lactation. They are hormone-sensitive tumors, and the increased hormone levels associated with pregnancy and lactation can induce tumor growth. This growth accounts for the fact that pre-existing or unknown fibroadenomas may be discovered during pregnancy and lactation. And as I said, ask the patient, do you have any previous ultrasounds supporting that? Then we come to our worst nightmare, which is malignant tumors. This was a young 21-year-old, 32 weeks gestation, came with a lump in the right breast. She was referred to us for a core biopsy. Ultrasonography of the breast was done, and then we advised a mammography, but patient refused. This is a very, very, very ominous looking mass, hypoechoic, angular margins, hard on elasto, vascularity on color Doppler. So you give it a BIRADS 4C, do a core biopsy, and this was a triple negative invasive ductal carcinoma. Again, documentation of cardiac activity before and after the biopsy. This was a very interesting case. This girl, we diagnosed it in 2007. She fought very bravely, but unfortunately we lost her last month. She was 37 years old, delivered just 13 months ago, and stopped lactating a month ago. And she said, I just can feel some thickening in the breast inferiorly. There's no lump. We said, okay, you're 37, so first let's do an ultrasound. And she said that thickening was there for some time. So when you do the ultrasound, I'm seeing this, my heart sank when I saw these multiple hypoechoic masses here with angular margins, a lot of vascularity. What else did we see? Associated features with calcifications within and outside the mass. So what do you do next? You have to do a bilateral mammogram. First, why? You need to evaluate the extent of disease because you saw calcifications. When you see calcifications, what do? You have to do a spot magnification view. Without that, you will not be able to understand the morphology and the distribution of the calcifications. Look for multifocality, multicentricity, and of course, you have to assess the opposite breast. So here on mammography, I'm seeing these masses here, all these calcifications. This is the skin thickening this girl had felt. You can see it so well. So we did spot magnification view, segmentally distributed fine linear and linear branching calcifications. Core biopsy showed invasive ductal carcinoma. So what have we learned? That mammography plays a complementary role in evaluation of these patients. Must be performed if ultrasound findings are suspicious, as multifocality, multicentricity, or bilaterally may not be suspected only on ultrasound. So let's talk of pregnancy-associated breast cancer is defined as cancer diagnosed during pregnancy in the first 12 months postpartum, anytime while the patient is lactating. It is a rare but serious occurrence with an incident of approximately 0.3 in 1,000 pregnancy, and around 2/3 of these cases are diagnosed in the postpartum period and mostly in the first 6 months following delivery. Commonest finding is a palpable, painless lump, unilateral breast enlargement with skin thickening or nipple discharge. There have been cases of milk rejection where the infant refuses to nurse from the affected breast. Now, always remember, any palpable mass in a pregnant or lactating patient must be promptly evaluated with ultrasound and do a core biopsy if suspicious for malignancy. Plan of action, of course, Dr. Neeta is here. I hope you agree with me. First trimester, unless it's a precious pregnancy, the patient should be offered a medical termination of pregnancy. In the second trimester, mastectomy or breast conservation, because some chemotherapeutic agents are considered safe. In the third trimester, if it's diagnosed, you do an early induction of labor and is done with the surgery, and chemotherapy is done after delivery. Now, sometimes we have no answers. This was a lady, 31-year-old, and she said, both my breasts are engorged, and she had redness and powder orange appearance in the left breast. Now, here we are totally in the dark because I can't do an MRI for her. So you're seeing this glandular tissue, of course, is showing that she's pregnant. There are dilated ducts and everything. What is surprising was the skin, very, very thickened. Okay, the lymphedema resolved postpartum, so we don't know why this happened. So this is the whole gallery of cases which I showed you. Now, just one line more. Amongst all patients, they say that, ACR criteria says screening, but we rarely get a request for screening in patients who are pregnant. The patient, when she's pregnant, she goes for ANC checkup, and the obstetrician does a breast examination, and only if there's a palpable lump, she's referred to us for imaging, and it's almost always ultrasonography of the breast. So to summarize, clinical breast examination during pregnancy is challenging but important. Hormonal changes that occur throughout pregnancy may increase the nodularity of breast tissue, raising the concern of palpable masses. Any recently palpable lump should be evaluated with ultrasound, which is the primary imaging modality of choice. We all have to be familiar with the normal ultrasound appearance of the breast seen in pregnant and lactating patients. Most of the breast lumps in pregnancy are benign, but always keep that possibility of PABC in your head. This PABC is defined as cancer diagnosed during pregnancy in first 12 months or postpartum or any time while the patient is lactating. Common masses are galactoseals and abscesses or lactating adenomas, and important for the clinicians. At the first obstetric visit, it's imperative to perform thorough breast examination and encourage the patients also to continue self-examination throughout pregnancy. These are my references. Thank you. Yeah, should I wait for questions? So everybody's hypoglycemic by now, I'm sure.
Thank you, Dr. Sabita ma'am, for shedding light on breast pathology during pregnancy and lactation, a phase where diagnosis can be particularly tricky. Now, may I request everyone to kindly proceed for lunch. The results for the lucky draw will be declared post-lunch, so please gather back in 30 minutes.
Welcome back, respected faculty members and dear colleagues. Hope you enjoyed your lunch, especially the soup. To carry forward our session, we are delighted to have with us Dr. Neeta Nair ma'am, a renowned breast cancer surgeon known for her clinical expertise and academic contributions. With years of experience and a passion for teaching, along with numerous publications, both national and international, she has guided many professionals in this field. We eagerly look forward to learning from her valuable insights on what a surgeon needs from a radiologist for surgical planning.
Thank you. Can we get the slides up? So like Sabita madam said, everyone was hypoglycemic earlier. Everyone's going to be quite satisfied, but I wonder if there's any blood in the brain to pay attention. But we'll try and keep this a little interactive for you. And I'm changing the topic a little bit with permission from Dr. Anita, where I'm going to talk to you about clinical planning and not just surgical. So very grateful to the Navi, Mumbai, Raigad Radiology and Imaging Society for this opportunity, and both Dr. Anita and Dr. Smriti. It's always a pleasure to talk to radiologists and interact with them so as to understand what we as surgeons need from you to be able to plan and treat our patients. So when you look at any screening mammogram, and the first thing is that if your patients had, thank you, if your patients are BIRADS C or D, we need you to do that additional imaging before you send them off. Because most scans that get reported as BIRADS 0 needs additional imaging leaves a patient very anxious. And they'll end up in our clinic. We're doing clinical breast examinations, but unable to complete that evaluation till we have that additional imaging that you think is necessary. So, young girl who had a mammogram done as part of a screening protocol. She's about 45 years old. And this complete credit, this is from Mona at Leelavati, and complete credit to Mona, who picked it up saying that there is something there which is suspicious, and she called it a BIRADS 4A. She wasn't happy to call it very significant, but she told me that this is new. She has old scans, exactly what we discussed in the panel earlier. Something new needs to be evaluated. It took a lot. We got an MR done because the girl was very apprehensive about getting a biopsy. MR also suggested it was suspicious. We went ahead and biopsied it, and it's an invasive tubular grade 1 cancer. This is an extremely low-risk disease. So this lady has actually now, this was an 8 mm lesion, so this is a stage 1 treatment. She's completely cured of it with the fact that we've had good imaging done that was able to pick this up. So for non-palpable lesions, we are truly just dependent on our radiologists. This is something that you have to be able to highlight suspicion for us to act on. So Anita madam's also going to show you the same case because this is something we're all a little troubled by. She was a 31-year-old who presented with history of nipple discharge, one single episode. She took antibiotics, after which it stopped, and that's when she had presented to the clinic. But someone who's presented with blood-stained nipple discharge is a clinical concern for me. So I've asked for an ultrasound. It said maybe it's a fibroadenoma, called it a BIRADS 3 lesion. We got an MR done. Unfortunately, this was not done at our center, and it was downgraded to a BIRADS 2. Again, clinical history of blood-stained nipple discharge. We kept the lady on follow-up. She was sensible enough to come back with that, and we repeated an ultrasound 3 months later. What I need from a radiologist is the expertise that Dr. Anita brings to the table, which is that 3-month ultrasound. She was able to say there's something different. And all she said was that the margins are now lobulated. I am not comfortable to call this a BIRADS 3 anymore. She upgraded to a 4A, and we biopsied this, and this is solid variant of DCIS with a focus of invasion. This girl is 31 years old. It's very easy for us to write it off as a fibroadenoma and send them off. I cannot feel this. This has to come from the radiology team. And when you biopsy small lesions like this, especially when we indicate a suspicion clinico-radiologically, we need you to place a clip in that tumor if possible. And the reason for that is that very often we take 14 gauge cores. We take about 4 cores at a minimum, if not 6. In a 5 or 6 lesion, the entire lesion may be out. And I'll tell you that I've actually had one patient who came like that, elderly lady, 8 lesion, biopsy done. Now, fortunately, that biopsy is by Roshni Chenoy, which is why I believe it blindly. And we've done a wide excision beyond that. There is absolutely no lesion left there. You can see post-biopsy changes, but there is no disease in that breast anymore. So we need that clip placed for anyone who is clinico-radiologically suspicious in a non-palpable lesion when you're doing a biopsy, because that's what's going to help us locate that lesion later. When we look at any mammogram, and this was when I moved into private practice for the first time in 23, in Tata, spoiled by the fact that you have access to everything. You can call your radiologist and sit on a head and say, redo that ultrasound, re-look at that, you look at digital imaging. And then you look at some of the imaging that's available elsewhere. So she's had a screening mammo, and you can see the lesion. It was palpable fairly easily there. There's some microcal that you can see, which is going to make all the difference to my planning. She's got about extent of microcal in that area. This is a very poor film. And I would have wanted the radiologist to be able to say that digital images need to be re-seen or raise some suspicion if they had access to the digital mammo. Because we repeated this mammo. And there's microcal right up to here. So the point being that it becomes very difficult as a clinician to ask for repeat imaging if the radiologist themselves has not raised some concern. So to be able to say that suboptimal image, you know, a lot of places do not have access to digital imaging. So it's going to be a film that even you will get to report. And so if I was to review this, so I did get it reviewed because that went to Aman for a mammo, and that's with Aman done at Hinduja. So Aman's first answer to the mammo was inadequate exposure, needs a better mammogram. And she said, can I first do a mammo for you before we do an MR? And when the mammo showed us extensive calcification, we stopped there because this lady was going to have a mastectomy. One of the biggest things that happens as a surgeon for us is non-palpable multiple lesions, which is focality, either multicentric or multifocal. To be able to plan my case, when I see an ultrasound report, I need to understand not only number of lesions, but distance from each other or a landmark like the nipple, and clock, because this helps me map the disease in my head. Very often, the reports, so I mean, again, blessed with excellent radiology in Apollo, but we get a lot of reports from outside, which will just say that there are additional lesions, possibly satellite lesions, and then there's no description of what that is. So I have to repeat imaging and then get it marked to be able to tell a patient what are you amenable for. So these are just 3 examples of how mapping would be done. And all of these are multifocal disease, but each of them will have a very different connotation for me surgically, because the first patient, I have the opportunity to do a reduction. The second patient, which was just a 2 single lesions fairly close to each other, I can do a local oncoplasty. The same thing with the third patient, needed replacement. That's a wide area. You can do a lateral flap, you can do an LD. This lady's also had a lateral flap. I don't have an image of that one, but that was an LD done. The point is distance from each other and from landmarks makes a difference in planning. when we sit in an institution like this, it's very easy for me to call one of them and say, can you repeat the ultrasound? Can you map the disease? Patient comes back to my clinic. The same thing if you are at a center which is a radiology center, your surgeon is at a different place, patients are not going to go back and forth. So that concordance comes from what you put down in your description of your radiology. Sono marking with us, and I think this Dr. Smriti has been saying forever, is she always puts the patient in the position that she's going to be in during surgery. Arm by the side, supine. If you tilt her because you want to be able to see it better, that's not how my patient's going to be when I'm operating. So that marking changes. Very often you'll place the probe on the tumor and then bring that pen to try and mark it. That changes the location. The probe needs to be angulated, the pen needs to be on the tumor. That's how we'll be able to mark more correctly. And I always need to know depth from skin, especially when we're looking for non-palpable lesions. One of the biggest concerns that we've had is a lot of patients will need an MR when it's multiple lesions. We're pushing for it. And I'm going to tell you that as a surgeon, I still struggle with reading an MR myself. I've been in this for 20 years. MRs are something I will always go down and look at her saying, can you map this for me? As a surgeon, it's easier for me to map disease on a mammo, because I understand the quadrants, I understand how the breast is placed in that. So CEDM is something, if we are able to pick up in terms of the same sensitivity, specificity as time goes with an MR, as surgeons and patients both, we may end up preferring them. So this is a young lady who had a triple negative breast cancer. She presented with a single lesion palpable, an additional lesion seen on the mammo. Her contrast mammo showed multiple lesions. And she opted to have a mastectomy. She could have had a flap, but the point is that that changed my entire plan. So for me, original resection would have possibly been just this. And now it is all the lesions up to here. And this radiological evaluation cannot happen unless you also suggest that there is some suspicion of additional lesions. So for diagnostics, mammo alone is never going to be enough in a breast that looks like that. And we hope that an ultrasound also gets reported with it. If there are multiple lesions, you will have your surgeon connect with you for either a CEDM or an MRI to rule out additional focality. So, like I said, clips at biopsy of any small non-palpable lesion, especially when there's clinical radiological suspicion. But we have also changed the way we treat breast cancer today. A lot of our patients who are early tumors also get chemo and then are going to disappear post-chemo, and not everybody has a residual component. So we need that clip placed prior to the chemotherapy, because we are going to see response patterns that are different. ERPR positive tumors, you heard Dr. Jhankaria talk to you about that. They're very good tumors, but they respond very scattered in the breast. And that becomes even tougher for us. So when we want localization, and if you have multiple lesions, we need you to bracket the furthest of the two along with the primary. Because if this patient's going to get chemotherapy, that quadrantectomy is going to depend on where all the clips got placed, versus a triple negative tumor that will respond centrifugally, just like you saw this one do. And the other biggest concern is that we've now started using a lot more MRI to map assessment post-chemotherapy. And we need to understand how far each of those, let's say, residual spaces are from the primary tumor. So we need the original clips placed at the furthest of the two lesions from the primary tumor. Wire localization, I think, is an art. And I truly believe that. As a radiologist, it's very easy to put in a wire, mammography, it's there, you put it. It's about how you angle that wire, where your entry point is, and what your post localization mammo looks like. You can have a wire which starts for calcification, that's periareolar, coming from the upper central, almost at the footprint of the breast, so at the takeoff of the breast, and you could place the wire here because it's easier. It's out of the plate, and that's the easier way to put it. You could put it from the lateral quadrant because that's how it's angulating on the image. The point is the surgeon needs you to try and do it for the shortest path of the wire. So again, sometimes it's not possible, but it needs to be a conversation that happens with the surgeon so they understand where your wire started from and where actually that calcification is. Because I need to place my incision on the calcification, not the entry of the wire. And I have to pull the wire in while operating. So wire-guided localizations need to be discussions and cannot be done independently either by a surgeon or the radiologist. Even for women planned for a mastectomy, it's important for us to know what the distance of the calcification is from the skin, because we are now doing more and more skin-sparing and nipple-sparing mastectomies. These are old patients. This lady is a young 31-year-old with an implant placed. We've done a nipple-sparing mastectomy, extensive calcification, and when we send it for a specimen mammo, I always clip all the margins so you know how to orient that specimen. But I need 2 views from you to be able to understand how far each of those calcification is from a margin. And I need to understand anterior margin. Because please understand, if this comes back positive, I have not localized where the anterior margin is, and the anterior margin is skin. So I don't know where to go back in and revise. So that localization has to come from you. What we also now do for a lot of our nipple-sparing and skin-sparing mastectomies is Rankati classification, where we look at thickness of the subcutaneous tissue. So you'll see more and more surgeons come and talk to you about it as to what is the thickness of the subcutaneous tissue, because that's what allows us to understand, is this flap going to be viable, how close we can go or not. We have moved towards axillary conservation for most of our node-negative patients, but one step that we've moved further is trying to see whether we can avoid a sentinel node biopsy and use only ultrasound to stage the axilla for early tumors. So I showed you a couple of cases where the tumors are all 5 mm, 8 mm, and 7 mm. Could we potentially just use ultrasound and not do a sentinel node biopsy is where the move towards is. We have 2 large randomized studies, SOUND and INSEMA, which helped us understand that. We do realize that ultrasound has a lot of limitations, especially in obese women and certain subtypes like ILC, but the data seems to suggest you could. So we looked at data that came into our clinic. 200 odd cases, ultrasounds done across the city by varying radiologists, and not all breast radiologists. Unfortunately, there is a very high false negative rate in the reporting of ultrasound of axilla compared with histology. And this, when we looked at by dividing them by breast radiologists versus people who don't focus on breast radiology, we found that the sensitivity and specificity of a breast radiologist was much higher. So now what we need from you, because we have started doing a difference in biology, difference in the way we de-escalate surgery, is when you report ultrasound of axilla, it needs to say cortical thickness, it needs to say whether there's a fatty hilum, it needs to say whether that's an indeterminate node or reactive node, because all of that matters to us. So it's not just about is there a node present or not. So like I said earlier, we had very simple principles. Early breast cancer, you operate up front, locally advanced, you give chemo first, and you de-escalate if it's a large lesion and you want to do conservation. That entire principle has changed. We now do what we call response-adapted therapy. So even T1, T2 tumors that are node positive or negative, that are amenable to breast conserving upfront, if they are triple negative or HER2 positive, we will potentially give chemo to a large part of these patients. So again, we need you to stage the axilla for us appropriately pre-chemotherapy, so we are able to do de-escalation post-chemotherapy for these women. Because today, if our patient started out as node negative to start with on ultrasound and or FNAC, we do sentinel node post-chemo. If she was maybe 1 or 2 nodes not matted, we will definitely ask for an FNAC. We will, in some cases, put a clip in the node also, and then post-chemo, if she's N0 on ultrasound, do a sentinel node biopsy. So we are moving towards less surgery, but that is dependent on the original radiology, because only in certain subgroups are we able to offer this. One of the things that we hope to move forward even further with is what we call targeted axillary dissection, which is placing a clip in the lymph node prior to chemotherapy. And then post-chemotherapy, we do a sentinel node, which is where we pick up lymph nodes using dyes, and we localize that targeted clip. It's very difficult to see a clip on ultrasound only, and especially with the clips that are available. Some of those ribbon clips are not always seen very well on ultrasound. So for us, the concern that rises is in the axilla, if that clip is floating, it's even tougher for us to make you localize that. So what some of the hospitals have now started doing, and because there are other techniques, which is magnetic imaging, use of carbon tattooing, so most of which is not available to us yet. But till that is available, something that people have started doing, and we hope to be able to develop also, is you take surgical clips and place them, because a surgical clip is much wider than your ribbon clips available. So your coils and clips available. So the surgical clip is inserted the same way as you would a routine ribbon clip. It's just that it doesn't come with a barred plunger. You use a spinal needle to do it. And you place that into the lymph node, and then post-chemo, when you want to identify it, you can actually mark it on the skin only, because it's seen that much easier on ultrasound. So we are trying to create some versions of trying to offer our patients targeted axillary dissection, but that cannot happen if we have not done a good ultrasound and or FNAC of the axilla pre-chemotherapy. So like I said, floating clips is one of the biggest concerns we deal with in this situation, and it unfortunately leaves a lot of distress to a patient if you have not removed the clip. And patients read reports, they check everything. So if we have not been able to remove the clip and it was not localized appropriately, that's a concern that we often face and need corrected with. So again, I bring you greetings from Apollo Hospital, and our biggest concern here with radiology is breast radiology is not just about there is a lump, it is suspicious, there is a node, full stop. You've heard everybody from the morning talk about subtypes, you've heard them talk about margins, you've heard them talk about suspicion. I will tell you that there's also a lot that comes from your report that makes us decide how we can de-escalate and help our patients better. Thank you.
Now I would like to call Dr. Anita Bajaj ma'am to felicitate Dr. Neeta ma'am.
Thank you, Dr. Neeta, ma'am, for reminding us that every image is a surgical plan in progress. Your guidance will certainly refine how we communicate and report for better patient outcomes.
Lucky draw, we have the lucky draw. Shubhi will do the honors, pick 3, since she's been working hard since morning. First is
Dr. Ananya
okay, first is Dr. Ananya, our student. Second, Dr. She's picked up all from Apollo, looks like. Dr. Ashutosh Chitnis from MGM. Dr. Ashutosh is there? Achha, okay. Dr. Yogini Shah. हाँ. गिफ्ट्स ले तीन हो गए ना? अच्छा नहीं है. डॉक्टर प्रियंका शिंदे. अच्छा. एक तो अनंत.
Vivek sir, please come on the podium. We now move on to the next panel discussion for today with our esteemed head of department, Dr. Anita Bajaj ma'am, as the moderator. May I also invite Dr. Sabita Desai ma'am, Dr. Sandeep Bipte sir, and Dr. Shweta Harwani ma'am, and Dr. Smriti ma'am. It is a case-based discussion on interesting cases, which I am sure will be highly interactive and rich in practical training.
So mic is acting up, so I think we'll have to share the mic. Then एक और है ना mic?
So this is our first case. A 45-year-old female presented with lump in her right breast since the past 1 year. The lump was initially painful, for which the patient took homeopathic medications. The patient came as a third referral after doing 2 sonographies outside that were reported as ductal dilatation and BIRADS 2 lesion. Patient felt the lump, and as of now the lump was not painful and had no tenderness on local examination.
These are the images. Basically, there was ductal dilatation, but the trick was it was in one segment only. Yes, yes.
Now these, you want to add?
No, ma'am. Continue. No, you carry on.
Though she's 45, so why a mammography was not done? That is first.
This patient refused for a mammogram because she said, "मेरे doctor ने बोला है सिर्फ ultrasound." So she has come to us with 2 ultrasound previous, all reporting as BIRADS 2. I insisted, let's do a mammogram. She refused. We did an ultrasound. These are the findings. So on that, I told her, let us do a mammogram. So she still refused. I said, at least one let me do. So we got one view, that's it. That's all she accepted. So, and she was a very, she didn't want to accept there's anything wrong with her, but she knew something is wrong, that's why she kept coming around. So we did just a 1 mammogram which shows this kind of pattern, and you can see there is.
Can we go back on the ultrasound? Now this recently at one of the conferences, you look at this pattern of this ductal dilatation. It's not normal. Normally you get ductal dilatations which are straight,
Linear,
less branching.
absolutely, that's the.
So this is a coral type of pattern in DCIS.
Yes.
So this, once we do pattern recognition, no?
Yes.
So then we know that, okay,
Yes,
as you
so
said, we are dealing
finally
with
we
something.
convinced her and did the biopsy.
Perfect,
Yeah.
perfect.
So I want to ask this with all the panelists, I'll take it. How do you, one is this, how do you convince, it was very hard to convince this woman. One, for, she refused to do a mammo in spite of, I can pretty well convince, but she didn't listen. So once, then I said, okay, one, I am coming with you and this technician, pain nahi hoga, all that. So then she did. Second, she refused to believe her diagnosis. When we gave it as not benign, meaning that is, it's a 4C lesion and looked like a DCS, as you said, because that's why I want to highlight all ductal dilatations are not benign. Please see the pattern. Then second, they were only in one segment, this ductal dilatation, and only in one breast, which tells you what it is. So as a surgeon also, Dr. Sandeep, how do you?
No, I think it's an index of high suspicion. When my radiologist say, no, it's a high index suspicion, we have to convince them then. And a majority get convinced because previous to may not be with the expert radiologist, which has missed. It's happened in practice, right? But this time, with this pattern, she requires additional imaging, which we have to convince in, and intervention has to be done with the biopsy. I think with the team, with the radiologist, and I think we work together, we've seen such cases, and patient get convinced.
Yeah, so actually once the biopsy was done, she came back. Again, she was not believing that this is a malignancy, meaning this needed a surgery, so it is not benign. So it was a tough task to get her to get it operated. So these are the kind of patients where we have a lot of difficulty to convince. So the histopathology infiltrating ductal carcinoma, it's not even yes. So lumpectomy was done with right axillary dissection. So how do you, I was asked Shweta, now we have been thinking about that, how would you, as a histopathologist, would you, is it easy diagnosis or clear cut or?
Most of the cases, the diagnosis of
DCIS versus infiltrating is
most of the cases it's easy. Sometimes some of the IDC, they show DCIS like pattern, we say. So in that cases, we do myoepithelial cell markers. So that will help. But in most of the cases, infiltrating duct carcinoma is something which we can easily diagnose on a needle biopsy.
Okay, let's go to the second one.
This is a case of a 53-year-old postmenopausal woman that presented with left breast lump. Ultrasound performed outside diagnosed the lesion as cystic, following which fluid aspiration was carried out. Patient was sent for review to us.
Yeah, so this is a very common practice. The patient comes up after all that has been tried, cyst aspirative. So it is very confusing for us to deal whether this is post aspiration, all this has happened. Then I asked the patient what was the color of the fluid when it was coming out and all that. And so, aspiration as a surgeon, I would ask, would you such a complex or complicated cyst, whatever?
Generally, we don't aspirate. If it has solid element, generally we try to get the core from the solid element, that's all. And if the index is high, then we plan to excise them.
What we do is, whenever you see lesions like this, the only reason for aspirating is when you do a biopsy from the solid component, there is leakage of tissue fluid into the surrounding tissue. But having said that, if the solid component is very small, then once you aspirate, then you've lost your sight of that thing.
So we have had
so it's a catch-22.
It's a catch-22.
Yeah, but in this case, it would be wise to first aspirate, and then there's quite a bit of that solid component which is there.
So that's what we did. We aspirated first. Although the aspiration has been done, it was refilled. The first moment I said, is it post-aspiration, all that hematoma formation? We get that also as well. But then we realized there was color flow and it is a solid component.
Again, color flow is important.
Yes, absolutely. So, Dr. Smriti, what would you do? Aspirate and?
So, soft tissue component shows vascularity. Definitely, it's 4A ke upar, maybe 4B or 4C.
Yes.
Depending upon the vascularity indexes or how low resistance the flow is. And I'm also seen that, if it's a simple hematoma or an infected cyst, the surrounding skin is going to be edematous. It is not so. Surrounding, even the posterior acoustic enhancement is there. That is explained by the cystic component. But the side walls, you see, absolutely no edema.
Yeah.
So it's not an inflammation thing. And if there is blood, there has got to be some sort of inflammation if there is acuteness. So my needle is pointing towards more of malignancy. So definitely not less than 4B.
Yes, so we aspirated, and after aspiration, luckily it didn't disappear. We did the biopsy, but that has happened with me, where I had to struggle back, aspirate, and now the solid area is only this much or hardly seen, so you have to make out where it is. So it came out as high-grade invasive papillary carcinoma, and wide excision was done.
Case 3 is a case of a lesion detected in health checkup screening at Apollo.
So, no, go back on the one. So whenever you're looking, reading mammograms, always look at this symmetry between the two.
Yes.
There is one sign which I think if you heard Dr. Tabar's talks, on the tent sign,
Yes.
which is the retraction.
Retraction.
Yeah? This bit, if you look at this, these are all the zones which you have to look very carefully. If you see this, it's as if something is pulling it from there. So there's focal parenchymal retraction there. Of course, there's also some lesion there, but I don't know if that had so
on
much.
MLO.
Yes.
And this is the area. So this was just a screening again. So I wanted to actually emphasize on screening. Dr. Sandeep, how would you advise such a patient? They come to the breast surgeon after this. They do, most of the times from our health checkup.
Absolutely, absolutely. I think with this report, she required maybe stereo core or maybe localization then. Generally, we had the stereo core.
Yeah, so anyway, we tried an ultrasound and we could see a lesion on ultrasound. So ultrasound guided it, although this is not as hypoechoic, it is slightly iso to hypoechoic, and then we could see the lesion, we can see the calcification.
Yeah, absolutely.
So ultrasound versus stereo, ultrasound is more easier.
Whatever is easier, we do.
Most easier.
Yes. That was the lesion. And this, we localized it and sent it, and Dr. Vipte operated it. So that's your case.
Nice.
And it came out as DCIS. So how do you feel the prognosis in such cases?
So early DCIs, they are curable cancers, but most important decision making for surgery, how the extent is about, if it's small, lumpectomy versus subtotal mastectomy or mastectomy with reconstruction. But generally, if the DCIs, they are extremely curable.
And how much convincing does the patient need? Especially they've come for health checkup.
It's very difficult because a lot of patients with DCIs come in a screening. I have a patient, if you remember, madam, she came in walking screening. She had microcal, extensive microcal. So first time, but localized area, we did excision, DCIs only, and then I did wide excision, sentinel node. 1 year down the line, she got routine scan and she got another microcal at side.
I remember this.
Yeah, and this time she required complete mastectomy with reconstruction. Can you imagine? For a recurrence, she required complete mastectomy with a big surgery reconstruction. So sometimes it's a double-edged sword. So DCIs, sometimes they are ERP negative, HER2 positive DCIs. They are a little bit aggressive type than compared to the hormone positive. So we have to look into it whether they are ERP negative, HER2 positive, and we have to keep follow-up. But annual follow-up must with the same imaging.
Yes.
So this is a case of a 45-year-old female who presented with complaints of left breast lump since the last 3 months, and it was painful.
Left retroareolar. Oh, next MLO.
So
Almost like
this
a
is
focal asymmetry
painful
there.
lump.
Left retroareolar.
So this was
one.
painful, that's why the left axilla is not
Yeah.
come out so
See,
well,
you
because the
can see
patient
it.
was not cooperating. So what would you think? There are a lot of signs there.
First. Yeah.
Yes.
Edema, lymphedema.
Trabecular thickening.
Nipple thickening,
Yeah.
the distortion there.
Coarse trabecular pattern.
Yes.
Trabecular pattern. Thickening of the skin.
So we need a compression as well as a ultrasound.
Yes.
So compression she didn't allow because it
Must
was
be
too
painful.
painful. Yes.
Predictable.
So this is the lesion. So
Yeah.
how would you feel about this lesion? I will ask both the radiologists to give their opinion.
So this is definitely a complex solid cystic mass. I'm not very happy with the margins. Okay, all the margins are not so well seen. There's also increased echogenicity of the surrounding fat. If you see, the fat around looks very bright. So she warrants a biopsy. Put
Yes,
a
for
4B, 4B at least.
At least, yes. And see the margins here. So I don't know if you
Yes.
can see this margin, these margins, this.
Very very indistinct.
So this, we did a biopsy and it turned out to be granulomatous.
This is
so
very-
this is quite a nightmare for us because we scare the patient. You have got a possibly a
Because
cancer. So how do you
mimicker of
deal with it? That's the, when they come back to you with that report.
Biggest mastitis is the biggest mimicker of malignancy, as you said. You have to treat it as if it's something suspicious. Go ahead with the biopsy. And as I said in my earlier talk, whenever you're collecting cores, see that you're collecting it in formalin and either saline or distilled water. It's in our hospital they prefer distilled water, and you have to send it for gene expert, TB-PCR, and
Yes.
histopath,
So
everything.
yeah.
Because she is not going to come back to you for a biopsy, for a rebiopsy. Because many times we see reports, patients coming with only course collected in formalin. They only have the histopathology,
there
but
are
you don't
two
have
things,
the culture.
Yeah, so two things I'll add which clinch. One is, as you said, the surrounding breast parenchyma is little echogenic and the painful lesion.
Yes.
Of course, we can see that sometimes with malignancy, but so it was very important to collect in saline as well. Our hospital, we'd give it in
I think-
saline.
Yes.
So I will ask you, Shweta, how do you, I mean, granulomatous, when it comes to you as a histopathologist, it is more from the microbiology point of view. But how does it work for pathologists?
Ma'am, actually nowadays we see so many cases of neutrophilic granulomatous mastitis. It's very common nowadays, and especially in breast, it's more, rather than mycobacterial, it's more of a chronic neutrophilic, which is
Yes.
caused by Corynebacterium.
Yes.
So we see it very frequently, and the biopsy is done with a suspicion of malignancy because maybe the lesions are irregular
Yes,
and
ma'am.
all. But yeah, we see frequently, and more than mycobacterial, it's more of a bacterial, like Corynebacterium causes it is there.
One more question, Dr. Shweta, I would like to ask, like, when biopsy is taken, fine, is there any difference between the biopsy taken from the walls, rather the junction of apparent normal tissue and this thing, or the center? What do you prefer?
Because see, the dictum normally is some amount of normal tissue, wall, so that you are going through, to take the normal tissue, you're going through the wall, you get the wall.
Yeah.
So that's what we try to do.
So ma'am, in granulomatous mastitis, it's, we get always the representative tissue. It's more of a caution when there is a solid cystic and a papillary lesion. Many a times, sometimes it's said, ductal dilatation is there. And even on histology, we see only dilated ducts. There is no intra-epithelial proliferation which we see. So in that cases, the site of biopsy is very important. For granulomatous, like mastitis things, it is okay, but for the, ductal intracystic lesion, the site of biopsy then matters a lot. Sometimes we may get only the wall and the main lesion is missed if the component is not targeted.
Yes.
I think these are very challenging case practice. Everyone will get this. Clinically, look cancer. How thorough you are. When you examine, you look like it's cancer. Send to mammography 4B at least and cancer. By the time we consult patient, we are suspecting 4B, probably cancer. And the report come as a mastitis. It's very challenging to treat them. So good radiologist is a real key in this. And it changed the whole treatment. I have a couple of cases where I had explained them as cancerous, and then got the biopsy. Biopsy also benign. Sometime I had to do excision also because my colleagues will say no, excise it. We get the input from them. I got the core, but there's a high index suspicion. So it's a joint venture between the radiologist and surgeon. We had to look into it, and sometimes we had to excise also. In a smaller cases with the high suspicious.
And they take long time to heal. It's like a really, sometimes your patient
Have you
just keeps
seen
coming.
granulomatous mastectomy with cancer also?
Yeah.
Granulomatous mastectomy with cancer?
With cancer. Coexistent.
So sometimes very small group of patient.
This kind of patients, this, yeah.
Like triple negative breast cancer, most of the times they have a lot of inflammatory components.
Yeah.
Yeah, so if you don't see it carefully, once I had case somewhere, it was out, matlab, sent for review, it was given as mastitis before, and now the patient had came,
with the triple
and then we had reviewed the original biopsy, and that small cancer was missed because of so much of inflammatory component.
Yeah, so this
So
is a
triple
good tip.
negative breast cancer, sometimes they are associated with a
They
lot
are
of
the worst nightmare
inflammation.
Surgeon prospective, I always tell them to have an antibody course in a week's time and come back and get the core biopsy. That's a sensible decision. We tell them there's an inflammatory part, just get it, get the good course, see that your needle is going into the lesion. Sometimes we have to choose this tricky cases.
And so many times many times it is with all your attempts, it's
And
still, till you get the histopath, you're never sure it is
Absolutely.
granulomatous
And
or
this,
it's a
this
cancer.
patient need to be follow up also.
Yeah, absolutely.
This is a case of a 65-year-old female presenting with complaints of left breast lump since the 3 months. That was painful. She had been following up outside and was reported as a BIRADS 3 lesion fibroadenoma.
So here are 2 lesions. I think it can be easily, now with after all day of breast imaging, everybody can pick up which is the one which is problem.
Margins, 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 and margins. Look at the margins.
Yes.
They
So,
are.
See there. So this was, ultrasound was being done and we did the mammo.
Yeah.
And these are the lesions. And you see I have magnified the one which is the problem. Yeah. Yes. So just to emphasize how much the margins are important. So, and with all cores, popcorn, whatever calcification, but so everything has to be seen on totality. Yes. And very difficult to convince the patient. So I was going to ask you, how do you?
So I had same case. She was 26-year-old and got mammography somewhere in Chembur. And my colleague reported as a BIRADS 3, fibroadenoma. Small lesion. Clinically I examined and I feel little suspicion. What's a margin? Na? Little irrigation. Before reaching to me, she got FNSE, which was says fibroadenoma by one of the colleague expert pathologists. What next? We shall reassured because small lump. But when I examine clinical index suspicion also plays very important role. When I examine, I feel little bit induration, little bit. I say, for my sake, just take it out. I took her to Bridge Candy, I excised. You won't believe when I excised, it turned out to be IDC. I just inequalated, saving that, but I had to revise the margin. So index of suspicious plays very, very important role. Again, core biopsy. Get the core biopsy. Now FNSE, please exclude FNSE.
Yeah, no FNSE,
so no FNSE,
please, only core
it's
biopsies.
not core biopsy. So for a clinician, index of suspicion and core biopsy, 98-99% will yield the diagnosis.
And see what it turned out to be. Mucinous.
Tomorrow, madam is doing 74 lady who come to me in casualty yesterday. Small lesion, palpable 4A, somebody 4A. But why 74 had this lesion recently, right? If we always look out a mucinous carcinoma, low-grade carcinoma, little bit marginate, core, and core. That's
So anything special you'll add in Shweta for mucinous? We should know.
So, ma'am, they come under the differential diagnosis of the circumscribed lesion, be it like a radiologically circumscribed lesion, which you all mentioned, be it like a intraductal papillary lesions, mucinous. They come like radiologically, they are relatively well circumscribed. So mostly that we come as a well circumscribed lesion, and on biopsy it turns out to be mucinous carcinoma.
You have to have the antennas up.
Yeah.
This was a 70-year-old.
This was a 70-year-old male patient presenting with a left breast lump. He was a known case of stage 4 NHL, being treated with chemotherapy right now.
So since he is above, at a good age, we thought let's do a mammo and see. So this is what the mammo showed. It's like a rounded, almost well circumscribed nodule, okay, a lesion, almost well marginated. Then we decided to do this compression view is taken. But does it look that well defined in mammograms?
See, the trick in male, go back just. What else you're seeing this patient has bilateral gynecomastia.
Yes.
Okay? Now important
It is almost looking like a female breast.
Yeah. So this is this typical nodular type or maybe dendritic type gynecomastia.
Yes,
now,
dendritic.
the glandular tissue in gynecomastia is subareolar, central, just fanning out little. I told you earlier that in the male breast, there is no progesterone. So terminal ductal lobular units are not developed at all. So if you see a circumscribed lesion in a male breast, you have to look at it very suspiciously, because you will not see cysts unless it's some cyst. There'll be ducts, cystically dilated duct. But when you see something like this, even if the margins are circumscribed, you have to think of malignancy, have to do a core biopsy. And typical location, subareolar, eccentric. Subareolar but eccentric. It is away from the retroareolar region. So very important to remember this.
So we did ultrasound also, of course, to add to it, and this is how it looked.
Very
Now,
nice.
what would you say, Dr. Smriti?
Not good.
Huh?
Not good.
Not good, yes.
Or since it is male, I would say 4C. Agar female, if it is in a female, I would maybe put it 4B, maybe.
Yes.
But male, definitely, I'm fighting for 5, but I think officially written report, I'll just give 4C.
Yes.
So even look at the elastography also. So we get areas which are increased in firmness, the solid component. So yes, needs a biopsy as soon as possible.
So we went and did the biopsy. So it was an infiltrating breast carcinoma. And a left radical mastectomy was done. So I was going to ask Dr. Sandeep, in males, is that the right way?
Yes, absolutely. Because male do have very small breast tissue. And most of when they come, 60-70% they are adherent to skin, already exist skin. And nowadays I see always monthly 1 or 2 male breast cancer, so common. So recently operated 84 years male cancer, and they asymptomatic until they get invasion of skin. And the treatment would be a radical mastectomy. Nowadays we are avoiding the muscle. If it is not infiltrating, we can safely take out the breast tissue. Early days we used to remove the whole muscle, but now only we can shave off. If the margins free, we don't have to remove the muscle. Yeah.
And if it's not involved, you'll still do it?
No, we
Only
can save. Only the muscle is very close, because generally no tissue between the muscle and the breast tissue. They are hanging on the muscle. So we have to take out the sling of the muscle along with that. Yeah.
Okay.
In male breast cancer, in a large male, I had done a BCS also in male, where it's small tumor, central excision. We had done it when they have some large breast. So it's possible.
Okay. And Shweta, I would just ask you, what does this mean to simplify for us? Invasive carcinoma with mixed features of cribriform carcinoma.
So ma'am, in breast, for all tumors in general, 90% is the cutoff to say it anything like a pure. If you say pure tubular carcinoma, the percentage of the tubular component should be more than 90. So similarly, if you say pure cribriform carcinoma, the component of the cribriform should be more than 90. So somewhere if it is between 50 to 90, we call it as mixed.
Okay.
And cribriform carcinomas, they are low grade, like grade 1 usually, ERPR positive. So, but in this component, it's a mixed cribriform and IDC. The grade of IDC is not mentioned, it should be like what type grade of IDC it is. But otherwise, cribriform carcinomas, they are grade 1. But to call it as pure cribriform, it has to be more than 90% of the tumor should show cribriform pattern. For that matter, even in mucinous carcinoma, which we had seen, so more than 90% of the tumor should have a mucin component to call it as a pure mucinous carcinoma. If it is less than 90%, we call it as mixed mucin plus IDC.
Okay, got it.
This is a case of a 27-year-old young woman visiting us for follow-up of a fibroadenoma that she has been following up for the last 1.5 years.
So this is an interesting case because it just happened, and this I have been following up myself. And for the last, and just happened, Dr. Neeta also showed the same case. So this looks like a well-defined, well-marginated lesion, which was labeled as query fibroadenoma, and we have been following it's about 7 by 8 by 4 mm. And we followed 6 months later, and actually she wanted a true cut biopsy then and there. But I told her, let's follow up, and she was somebody who would have followed up. She was very anxious. So she came after 3 months. The lesion was the same. And then she came to me now after about a year, meaning after 6 months it was okay. After 1 year, you see the change in appearance. And this is from 9 millimeter, it has just gone up to 10 millimeter, but the appearance. So I immediately told her we should do a biopsy. Of course, that time, earlier she wanted to do, that time she refused a biopsy. I said, you have two options. We closely follow up, we do a MRI, or let's do a biopsy. If you don't want a biopsy, we'll do a MRI. So we suggested a MRI, so at least she'll be more convinced. And I have zoomed the images to show why the appearance and see the margins behind. I hope everybody can appreciate that's lobulated, and you can see the angulations. Yes, so the duct was, yes, so it was in very close continuity, almost like a continuity from the duct. And we did the MR. And Dr. Smriti, you can explain the MR.
So I think I have done this MR few days back, Feb, na? Last month only, yeah. So when we look at the MR, the single most important sequence, if you ask me, that patient has to lie down prone in MRI, which is not very easy for many patients. So if there is one sequence which is important, that is dynamic, post-contrast dynamics scan. And the eggshell is, I think, no, these are just post-contrast, these are not dynamic. But I wish there was dynamic, because then I would show you, first, the lesion margins, they are irregular, that we know from ultrasound. Second, the most important thing which clinched the diagnosis for me was that there was washout. There was very rapid upslope, and then absolutely it came down very fast. It came down more than 10% in a very short time. So that is a very, very important feature for the kinetic curve, what we call it. Otherwise, I could have thought something else, but the margins combined with washout, it actually clinches. So this is a no-brainer kind of thing.
So that MRI helped us actually to convince the patient for a biopsy. And the biopsy turned out to be solid papillary carcinoma breast. So we were happy we picked up at a very early stage, and thank God the lady has been following up regularly. So Shweta, how would you say these, how are the prognosis with a small lesion?
So ma'am, on a needle biopsy, we would not be able to comment most of the times. We would not be able to comment whether it's a intracystic solid papillary in situ carcinoma or it's an invasive solid papillary. Most of the times it's an in situ carcinoma.
So but it was, I think, labeled as with areas of invasion.
Yeah, so that will be on an excision.
That was exactly.
Yeah, on a needle biopsy, that cannot be commented upon. So on the excision, then we look carefully if it is entirely an in situ component or there is an invasion, and then we measure the size of the invasive component. But on a needle biopsy, that cannot be done.
Okay. So surgery-wise, Dr. Dept, it is clear-cut, small, and just a regular follow-up. But she now would be on active surveillance because she has had a history for screening.
Sorry, one question, Dr. Dept. When you excise, how much of the normal tissue do you take along with the tumor?
Grossly, the 2 centimeter margin, and microscopically, once it is okay. good margin we have. But again, depend upon the size of the breast, we have to decide then. Sometime when you excite, if you feel something clinically, we little go extend, sometime we revise the margin. But I think once it is good tissue, but saying once it then never happen, it's almost 2 centimeter, yeah.
And these kind of small lesions will have to put in a wire to set
Always
the
wire
surgeon
localization.
cannot operate without.
We had burn our finger as a surgeon, midnight troubling madam.
Yes.
So whenever in doubt, non-palpable, always put. I had burned my finger and decided non-palpable lump, put wire. Even not skin localization, put wire. And exercise, make sure.
Case 8. This is a 58-year postmenopausal female presenting with complaints of right breast lump since last 2 months.
Yeah, as you can see, it's nicely tend, yeah.
So about
See?
this
is my view.
This is on. There's a so this is the post we put in a clip at the same time and this was on ultrasound.
Radial scar है क्या? IDC.
So
Radial scar है क्या? IDC.
No, it is not a radial
This
scar.
is a mass.
Mass.
This is 100%. So radial scars will have the, as Tabar
That's what-
says,
हाँ.
black star. Because you'll just see lucencies and you'll see long spicules. But in this case, this is called as a white star. You may see lucencies within, that is fat which is trapped, but the spicules are short and the center is dense. So you, they don't,
They
the radial
don't, yeah.
scars look totally different.
Yeah, and it was not palpable. But
Secondly,
still.
yeah, radial scars are not palpable. I've seen big radial scars and complex sclerosing lesions, not palpable at all.
They are imaging, only imaging.
Which radial scars? Very challenging, very challenging.
Very
you have to look
challenging.
at, so these radial scars, there will be one small cyst somewhere. There will be what Tabar calls it, whenever we describe it, he says you must not use the word speculations. Because when you say speculations, you're telling them this is malignant. So you use the word radiating structures. And these radiating structures are what? They are just ducts which are filled with either fat or fluid or something. That's where you get that appearance. So you'll get these long spicules. You might find a small cyst and a small hypoechoic area there. So many a times what we do is we do a core biopsy if you can. If you have to excise, we put in the wire ultrasound guided and take one image on the mammogram to show that we have targeted correct area for excision.
Actually, that's what I was coming to. So normal, if we see a radial scar, ideally we cannot leave it because you cannot leave it because you never know what it is. We are assuming it's a radial scar. So we have to, ideal would be, as you said, wire localization and uske baad excision.
Or there is a thing nowadays with VAB, you're supposed to take 12 cores and that weight should be some 4 grams or something. There is some criteria, but all institutions do not have VAB.
Yes.
So then a wire with the wide excision.
Yes.
Because what if you do a biopsy? Like I was lucky, I had a radial scar. I did a biopsy and I got DCIS. What if you do the biopsy from an area which doesn't have DCIS? You not sampled the entire lesion, right? It is wrong. So in that case, I think a complete excision makes sense.
Makes sense.
That makes sense. This was the resected lesion. This is
A 50-year-old female came with 2 outside reports of benign cysts in her left breast.
So this is another case where the lady refused to do a mammogram and she has been doing ultrasound all around. So 2 reports where she said it is benign, it's benign. So, but when she, of course, something must be bothering her that she came. And then we said, I insisted that these are not looking okay. So there are multiple reasons. You can see why. You can see those linear structures from the sides. Do they look normal? All these And the, it's like almost speculations from there. From here. Then there are tiny calcium. The Cooper's ligaments are absolutely stretched. So that means there is some architectural distortion happening there. Plus the surrounding breast parenchyma. It is like that desmoplastic reaction how we get. And see what happens on mammo. She refused to do a mammo and had to convince her to do a mammo, and with mammo, everybody can say what it is. So it is, a big question here when the patient comes in, convince them for a mammo versus, so now I tell them, you have to do it. I mean, there's no option. So otherwise it's like a half-hearted examination. We wouldn't have struggled so much time we spent trying to, and then see, it's like a very classical, and see the compression view. Even more, the amorphous calcifications. So it was.
So just go back on the images again on ultrasound. So wait, so if just when you look at this, you saw the earlier one with the coral. Now there's something called as the cumulus type. DCIS cumulus, where you'll see it like this, and you'll see like ducts and cystic areas,
yes,
like, within.
Yes.
And the other one you showed was the cigar type, which is beautiful, which the earlier one, with
coiled, like.
Yeah. So now in this panel discussion, you've seen all three types of ultrasound appearance of.
Yeah. And see the tiny calcifications.
Absolutely.
There. So that's how.
Very nice.
So this turned out to be in intraductal papillary CA.
Very nice.
This is the last one.
A 55-year-old female visited us for routine screening.
Okay, yeah. So this is, so routine screening we picked up. We have put arrows because it's difficult to pick up actually. So there's some asymmetry there in the outer quadrant. You can see the same thing on MLO view. Can you appreciate that? That there are two areas of focal asymmetry there. We took a compression view. Okay, now how nicely it is visible. And now, what would you ask for next? Ultrasound. So yes, targeted ultrasound. Here we see two lesions separately. They are at some distance from each other. One is a spiculated lesion, one is little indistinct but oval but tiny calcifications. So I would ask Dr. Sabita, would you biopsy both the lesions?
No, you'll biopsy one and then give the distance between those two. Because when you look at the mammogram, those calcifications are 4B straight away. They are not, they are suspicious.
Yes.
So if they were a little apart, or if they were in another quadrant or in the opposite breast, then I would have biopsied both. This one you see is very close to that.
Yeah,
So if you're going to, if this I'm sure A is going to be malignant.
They are about 2-3 centimeters apart.
He can be able to excise it in one.
Whole purpose is, if in different quadrant, my surgery plan will be changed. So it's in one quadrant, I'm going to excise the whole quadrant, right? If it is say 12 o'clock, 5 o'clock, then my plan will be changed. So I need to biopsy both then, and I need to see intermittent tissue also. That's more important.
Absolutely.
So if it's going to change the quadrant, then 100% both biopsy. So one quadrant, one biopsy.
So the surgeon here wanted us to take from both. So we went with what the surgeon wants. So we did from both the places. So the left breast, the lesion A came out as infiltrating breast cancer, carcinoma ductal.
Expected.
And the B came out as ductal carcinoma in situ with foci of invasion. So I would ask Shweta now what to...
So generally why this is important? Because of the ISC. Sometimes the surgeon may think one is ERP positive, whether HER2 positive or negative. Today oncologists are very tuned. They want to find out whether they are HER2 positive or negative, two different tumor.
So this actually more than the surgeon, there were oncologists involved, yes.
Oncologist
and the
generally,
surgeon
not
involved.
the surgeon, but
So
oncologist tends to get the both the ISCs.
So
ISCs because they're trying to find the pathway HER2 triple negative for the line of treatment.
But one of the things we had a discussion in one of the meetings, and they said if you have a triple negative, then I spoke to Dr. Dabar, who is our oncologist. if you have a triple negative and if you have maybe a luminal A, luminal B,
Yeah.
whatever, he said we treat
Aggressive-
as triple negative.
aggressive one.
Okay.
The aggressive one, we
So
treat it
aggressive one.
Yes.
Because
So
that's going
the
to relapse than the luminal A cancer.
Yes.
So this case came sometime back only, and the oncologist, breast surgeon, everybody was involved, and very little high
What
profile
was the
kind of
IHC?
case.
Is the IHC?
You have the IHCs. She's not bothered to, but we had done all the workup for this. I don't know if Shweta remembers. No. Anyway. Yes. So we are done with all the cases.
Wonderful. That
very
was
nice
nice.
I hope everybody had a learning
Very nice.
experience.
Very nice. Excellent cases.
Nice cases, yeah.
Very
We will now move on to the felicitation ceremony. It is our privilege to honor and express our gratitude to our distinguished guest for today. May I request Dr. Anita ma'am and Dr. Smriti ma'am to do the felicitation.
It was a real pleasure, and Navi, we have an interesting talk by Dr. Sandeep also right now, Dr. Dept. More light on what the surgeons need from a radiologist, or rather what we do for them.
It's always a teamwork.
It's always a teamwork. I think we speak so much to the pathologists. They also come and ask us, "What do you feel? What was this?"
My pathologist is always on hotline.
Yes.
I ordered him yesterday also.
Yes.
Because
And we keep
some
calling,
slide
how do you, and sometimes when there's discordance, we get bugged also. How can it be this? So no, you have a relook.
She's very patient. Even at 10 o'clock, suddenly I'll remember. I said, क्या निकला?
Uska kya nikla?
वो
Yeah.
बेचारा.
We keep bugging them the same, both of them. Whoever does it, please tell us.
Ma'am, I have a question. In papillary lesions like a circumscribed and if FNSC was done outside, now many people still outside they do FNSC.
Yeah.
So I had a case in which it was difficult for me to judge whether it's a true invasion in the wall or it is because of the tract which is created by an FNSC procedure. So as a radiologist, you also face that difficulty. Yeah?
No, for us it is.
Because in-house,
The thing changes for MRI when somebody has touched the lesion, or we face it when somebody, like a cyst with solid component, when somebody's already gone in, there's a lot of hemorrhage. So it changes the picture. But otherwise, no problem.
patient has come to you with the
Only
FNSC
thing is
done
when
outside. But it was to have happened.
To answer your question very simply, FNSC, the needle is so fine that the trap is not. Usually it is
So that doesn't interfere with your
Biopsy is
interpretation
still
like of a
different.
circumscription or it is fine.
FNSC
If
no.
there is a
FNSC
vessel in the
no.
way, maybe
Then
yes.
okay.
Otherwise,
Okay, otherwise usually FNSC needle no. Biopsy is a different game.
And by the time patient comes after 5 days, 6 days, 7 days, there is little FNAC is normally a fine needle. Post biopsy, of course, there is some.
But post biopsy then
Post-biopsy, yes.
Yes, changes we see.
Because we use a very thick needles. We can, you use 14 G, na?
Yeah, for all patients.
14
I think you tolerated to get and all the, I mean, you can do, we send for all IHC,
because the patient will say, एक और, I said,
But
you want to
हाँ,
come back
exactly.
for a biopsy?
So it's better
नहीं,
to-
doc, सब निकाल लो.
Yeah, so I use the thickest possible. So
Because they think that biopsy means one and done. So I, in the beginning, only tell them, I said, 4 बार करेंगे. 4 बार क्यों? I said, वापस आना है आपको? नहीं.
Thank you so much.
Indeed a pleasure and an honor, I must say. Thank you all so much. Me too, really. This is very precious. This is so pretty. Thank you so much. Thank you. Yes.
For our next session, it is my great privilege to call Dr. Sandeep Bipte sir. He is a highly respected and accomplished consultant oncoplastic breast surgeon at Tata Memorial Hospital with vast clinical experience. He has done his oncoplastic fellowship and intraoperative radiotherapy training from London.
Hello. So maybe last few session. So I'll keep you awake by putting my photos only. So thank you, Dr. Anita, Dr. Smriti, and the Navi Mumbai Radiology Association. A wonderful session because I think this is the things we need to discuss to become more better day by day. So why today's radiology is completely changed now. It's redefined, right? Gone are the days where there's no correlation between. So there's a person role of radiologists in the breast cancer imaging management. I cannot run the show without this team because it's very difficult to have it. So breast imaging has a profound impact on the millions of the women daily. Early detection, early days, there is no mammogram screening was not there, but today we see cancer in a very early stage. And this significantly impacted the outcome in terms of the recovery, in terms of the cosmetic also. And you play a really very important role. This is a very mammography from outside. Can you see that? Oh, shit, you broke the news. So not only you can see mass, calcification, scintillation, right? So we always used to see, oh, this is what cancer, right? No, it's a surgeon's googly scope, right? You can see that. So those who have missed this lunar eclipse have this wonderful microcal non-mass enhancement, and you can see this. So again, breast cancer, most common cancer in women. Imaging is very important role. Require MDT. Always pick up the phone, talk to your radiologist, make the diagnosis when in doubt. And it's important for early detection, treatment, and planning also. So I'll show a couple of cases. I'll not waste time. So why is important? Because early detection, like a screen cancer. So a lot of people come from camps, the screening mammogram camps, and they have BIRADS 3, BIRADS 2, sometimes 4. Very haphazardly happen in screening, right? And we may miss the cancer. So always I say, go get a proper screening, get the reporting. Precise diagnosis, BIRADS setting. You know, we'll have one person calling BIRADS 3, one person 4. As a surgeon, what I'm missing? I need my answer. I'm selfish. I need my answer, right? Sometimes I need to get a second look ultrasound. Okay, ma'am, please have a second look ultrasound. Review the image, right? So that BIRADS is also important because it still varies. Treatment planning, I cannot run alone because I need your support. So my external surgery, my reconstruction, my simple surgery, it makes sense. So, and it's not only for me, but patient outcome. These cosmetic outcome, patient has seen for a small calcium benign land up in mastectomy. Had lumpectomy only for extensive calcification because of imaging limitation. So this is more important. So there's a paper on the breast imaging, how a radiologist role in breast MDT meeting. So by clear and completely presenting information to the rest of the MD team, the radiologist can provide a vital contribution in guide the treatment and ensure the guideline also. That's more important. What guidelines about? It's not I feel syndrome. Mujhe acha lagta hai, mujhe nahi karna. It's what the guidelines about, right? Second thing, add to the surgical team contribution so that the patient should be the beneficiary at the end. So BIRADS, again and again, BIRADS classic 3, 4, you know, always there's difference between 2, 3, 4. 4C generally most of the gay 4BC, but you know the challenge is between the BIRADS 3 and 4, whether to intervene or not to intervene, that's more important. And the reducing the false positive rate, you know, if I send to the expert, they say, Sandeep, the biopsy is not required, it's classic post-radiation fibrosis, it's not recurrence. If go to someone else, they say, no, it looked like a recurrence, get the biopsy. So the imaging, intervention, surgery has been completely stepped down, de-escalated by the expert radiologist. This is classic scenario. Surgeons are always driver and the conductor like a radiologist, never asked in early days, you know. And what happened then? See the fatal accidents. We don't listen to them. Surgeon, brace aaya, lump nikal diya, dekha nahi. They haven't seen that. Microcal hai, scintillation hai, node hai. And you know, and this is a disaster. What this disaster is about? Extra mastectomies. The person who can have a breast saving surgery had mastectomy, less BCS. And they say, you know, because they're not get the proper mapping. Margin positivity. I have seen a lot of people have margin positivity undue because not mapping. Post-radiation, again there's challenging cases where the post-radiation look like recurrences. Missing high-risk cases like a BRCA positive patient or extensive microcalculi missing. Number of lumpectomies. So without getting mammo, a lot of patients get lumpectomy first and margin again come for surgery, reduce surgery. All these issues, and most of them can have axillary dissection without sentinel node. So all this can be achieved with a good radiologist. And so these are the complication we can see. I feel this complication. Imagine this lady has mastectomy or lumpectomy. Can you see that? Lymphedema, unnecessary, the axillary dissection has done. See the oncoplastic surgeries. Will you accept this in today's era? No, will not accept. If it's family, then will not accept, right? So this can be prevented, and 30% of the work coming to us is this type of work. I'm not saying we are also learn over a period of time, but this is the learning curve. So this is only happening by motivating, by teaching the people and getting the experience shared. Simple example. So post-radiation scar, right? Somebody report. I generally get, a lot of people get the radiation post-BCS and they go to periphery, local doctor, mammography, and they say, query recurrence 4A, 4B. Again, I have to call them, Baba, it's not there. I know, it's a post-radiation, this thing. I need to call my colleague fellow, talk to them, this is the case. And out of 100, 95 have come back as the benign, right? I have to reassure, but again, it adds anxiety to the patient. In spite of good surgeries, good everything, patient come back with a 6 month of radiation and then got mammography in years and ki sir bimari wapas aa gayi. So you played very, very crucial role to diagnose that. So in case suspicious, then we get biopsy. Arcade distortion, post-radiation generally they have arcade distortion, right? And somebody who was not trained, they always report distortion 4B, 4C. Again, this is a dilemma. So I have put some photos for you, not just Jupiter and Saturn. Again, it has to be a pathology diagnosis. If I see on mammography, say a radial scar, it has to match with my colleague. Pathologist say, oh, sir, it looks like a radial scar. It's not something fibrosis. So it has to match with the imaging and the pathology. That's why we always keep on in teamwork, and that's the best way to deal with that. So it's a joint venture. So today is the breast imaging expert occupied a co-pilot seat to the surgeon. I must say you had co-pilot seat. And it's a joint venture when two experts meet together, form some decision for a patient betterment, the landing will be smooth. And how the landing will smooth? These are the results. Which brace is operated? You have two options only, yeah? Say don't left or right. Can you make out? So this lady is a young lady, she is 26, unmarried, and she had breast cancer. But my radiologist told me she had calcification, the nipple is away, the exon is more. So I did a endoscopic skin splitting nipple mastectomy, right? So dense breast, and see the outcome. Otherwise, I would have done a complete mastectomy. But now with the advent of imaging, I could make as, oh, the skin is free, the rest is free. I can just go take out the gland, everything, and I did incision laterally and the armpit here, and see the outcome. It's like maybe 6 months down. So these are the outcome. Who's the beneficiary? The patient's beneficiary. It's a joint venture. So we can yield this type of good results. So why specialist needed? Because higher detection rate for a benign, because again BIRADS 3 and 4 higher, good detection, better intubation of subtle findings where there's a dilemma, the subtle finding, what to do, they always have, and reduce the false positivity and unnecessary biopsies. That is more important, whether to do it or not do it, that will is possible also. Today we have advent of technology like a digital tomosynthesis, contrast MRIs, ultrasound, functional MRI, everything. But these are technology, but I need a pilot who can run the show. No, that's the expertise that come from your end, the breast imaging expert who deal with that, and the more important is interpretation. That's more important, and the experience that matches the diagnosis. And this is a simple example. You can see this case. See, so this lady, this is post-surgery mammography. You can see the skin thickening, right? Distortion, and so outside reported microcal, and say observe karo benign hai. They got the microcal, and then we got here the expert tomo also, and you can see the classic microcal with the ream and the fat necrosis. So somebody has intervened outside to do biopsy and everything, but with the tomo simple, we can solve the problem, and we can keep in follow-up, and it turned out to be a fat necrosis. Another case outside, there was microcal, and they say observe, right? But we got another second look ultrasound mammograph, and we insisted for biolocalization, and it turned out to be high-grade DCS. Can you imagine? The two cases differently. This lady had been observed, will compare with a nodal met, right? So it's a game changer completely how you interpret what case. So because it's very small, and she turned out to be high-grade DCS, and we had intervened it. So role of most important thing, as a surgeon, we are very selfish. We want surgical planning. So accurate tumor localization, extreme disease evaluation, detection whether it's multifocal, multicentric, and whether the base case is feasible. This is my Windows, very rare speed now. Again, it's a routine work like a tumor mapping, evaluation of lymph node. What is most important is this case. This case, she's 40, she came from Dubai to me. Had mammograph, plain mammograph, very difficult to say small. Madam has done this 2 lesion, and MRI has become the non-mass enhancement at 2 and 4 o'clock. So outside they plan for a left mastectomy sentinel node, right? Because consider 2 different lesions. She's young. See, this is a lesion. And then we got with mapping. So we got the biopsy from both the lesions. Here the both biopsy because it was 12 o'clock, 4 o'clock. The decision was changing. So I got biopsy from the 12 o'clock and 4 o'clock, which is IDC. There was intervening area with the DCS. So madam has mapped that, and I can see the outcome. See, this is a pre-op image, the post-op image. Can you imagine? Wonderful. I did a wide exam with LD flap, and see, so this is mapping. So we have reviewed the MRI, we have reviewed the mammography also. We have marked on skin marking where exactly 12 o'clock, where exactly 4 o'clock. We have mapped this area and make sure the rest of the parenchyma is normal. And after making, I exactly excised from the 12 o'clock, you can see the pectoral muscle, the axilla, 4 o'clock. We got a specimen mammogram, and which had surely the microcolors out, and we got the frozen also, the margins. And once it's clear, I got the LD flap and see the outcome. This is 2 weeks down the line. So this is wonderful results. We can give it without advent of the imaging. It's very difficult. This is sunbird. So again, a very important role in a neoadjuvant setting. When I tried triple negative cancer, how to positive, I need to have clear publication, right? The tumor assessment also, whether we are in the right direction, and a decision making also. So this I have shown is simple example. I saw yesterday only this case. I'm going to operate next week. So she came with a small nipple excavation, got the Paget, biopsy confirmed Paget disease. Outside mammography was only localized excavation, but I was not sure. I called mammograph here, and you see my plan was BCS with center on BCS with sentinel node, but with a very good mammography. See, she had microcal. And the micro was going from NAC to at least 6 centimeters away from that. I explained to them, there's no need to biopsy. It's going along the track that, and it could be a 100% DCS. So my plan is changed now. So having said that, if I would have not done the mammography, I would have planned a breast saving surgery with sentinel, which is a inadequate treatment. So people are doing like that. So it can happen with me also. So the imaging and expert has make the difference, and you can see the outcome. So again, aesthetic outcome is not only the high risk category. Today we are screening BRCA patients, especially for the prophylaxis surgeries, dense breast, and the corresponding outcome also. This lady, so they helped me. I done here only, Dr. Anita has done imaging here. So can you make out she had which mastectomy? Left, right? Spot price for the audience. Which one? Right, very good. What else? Chemopody, yes, right side. So she deserves a prize, but I had operated on left side. So why in position BRCA positive patient, imaging had I got MRI, everything to make sure she had right breast cancer, earlier operated. So right breast cancer, earlier operated 2 years back in British Candy with port, and you can see the port is there. She finished treatment, she's BRCA positive. I did the first my robotic surgery on the left side, skin sparing nipple mastectomy with implantation, and last week I did on right side. So see, you can't make out, and see this is scar on the left side. So today with imaging has a much fantastic, for when lady get up from the surgery, you can't make out which breast operated. That precise, it's like an operation Sindhu, very precise. Where we're heading, the extent of diagnosis, where I'm hitting, the specimen mammography, the pathology also. So it goes hand in hand, and the outcome is good. See, endoscopic pictures. This is Jupiter with his moon, you can see that. So impact outcome, early diagnosis, more precise surgery, reduce reoperation rate, that's more important. Improve survival and quality of, if you have a mastectomy versus breast saving, she'll have more positive impact on body image. In conclusion, expert radiologist is central to the modern breast care. imaging at every stage of treatment, and strong radiology surgical correlation improves the patient outcome. I think with this final line, I should say thank you to all of you for this invitation. And this is one of the picture. You can see the sun and the moon on the same day. Morning you can see the full moon and the sun also. At the same time, they're reflecting. So with this, thank you and happy Women's Day again. So imaging is like a co-pilot, I always say. So gone the days, earlier surgeon is to chop all the breasts, without thinking that whether calcification, multifocal, there was no concept. We have learned over a period of time. Now with every cancer, even solid cystic tumor, whether to get a biopsy, mark, everything will come eventually, and it benefit the patient. Thank you so everyone for your time.
Thank you, Dr. Sandeep, sir. Your insights highlighted how precise imaging directly influences patient outcome. Thank you.
Now I would like to call Dr. Sabita Desai ma'am, Dr. Vivek Jagtap sir, Dr. Chetan Singhal sir for felicitating our guests. May I please call on stage Dr. Jyoti Chaubal ma'am, Dr. Manjushri Billa ma'am, Dr. Mrudula ma'am, Dr. Anita Bajaj ma'am. Dr. Smriti ma'am.
This design is so beautiful.
Dr. Prabha ma'am. Now it's time to put our knowledge into action. we move on to our hands-on workshop on breast interventions. The workshop rooms are available on the ground floor. We have arranged 5 ultrasound machines. Each station is guided by an expert faculty member to ensure proper hands-on learning. We have also provided chicken breast models for practice so that everyone can simulate intervention techniques comfortably. Each participant will get one opportunity at the station, so please make the most of this hands-on experience. On the ground floor, we have Ms. Rupali and Ms. Sonal to guide you guys, so you can just head on to the ground floor.